So let's get this conference started. As you can see, today's conference is entitled Untying the Knot, Thrombosis Insights and Best Practices. These are our disclosures for the co-chairs. We also have to mention that there's a disclosure of financial support. This conference has received funding support from Alexion, Bayer, BMS Pfizer, Fresenius Kabi, Leo Pharma, Pfizer Hospital, Sanofi, Servier, and Valeo in the form of conference grants. This program has received no in-kind support. So there's obviously a potential conflict of interest as Alexion, Bayer, BMS Pfizer, Fresenius Kabi, Leo Pharma, Pfizer Hospital, Sanofi, Servier, and Valeo may benefit from the sale of products that may be discussed in this program. To mitigate potential bias, the content of this program was developed by the Planning Committee and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. This program has been accredited by the College of Family Physicians of Canada, the Royal College of Physicians and Surgeons of Canada, as well as the Canadian Council on Continuing Education in Pharmacy. We would not be here today for this wonderful day if we didn't have our great steering committee, so I would like to take the time to thank them all. You'll probably get to meet many of them as they will be presenting or co-hosting sessions. We want to remind our online participants that there's a Q&A feature so that you can ask questions or comments, and Morel and I will be looking at the chat box so that we can alternate between in-person questions and online questions. For today's objectives, we want our participants to apply current evidence in the management of patients with thrombotic disease, manage thrombosis challenges in clinical practice, and implement thrombosis treatment options in a variety of patient populations. As you can tell, we have a very ambitious, jam-packed agenda today. So we will do our best to stay on time. As Morel had said, we have the syllabus that can be accessible through QR codes that will have more information such as our illustrious speakers' bios. In the morning, there's two main sections that are talks, and then in the afternoon, two other sessions followed by workshops. And all of these have been developed based on the needs assessment that had been sent out previously so that hopefully you get a lot of great knowledge today. As you can tell, our evaluation is quite large, so we have broken it up into 4 parts, and the evaluations will be sent out after each part. Please do fill it out as we want to know what you think of our session today. Now we can have Dr. Mark Carrier that will speak to us, our president of Thrombosis Canada.
Thank you very much. And I would like to specifically thank Dr. Koulian, Dr. Shivji, the planning committee, David, Holly. This is a wonderful day and we'll have a great time amongst colleagues. It's good to be in person again. And none of this would have been possible without your hard work. So thank you very much. And that's just emphasizing that Thrombosis Canada is really a community. Thrombosis Canada is made of all your contributions. You're all doing a lot of work for the society, and we really, really appreciate it. We'll have the AGM later, but there's a few things that I wanted to highlight because Thrombosis Canada is moving forward. We heard about some of the things we've been doing. There's some of the things that we want to do and we'll do better. We'll have a new website in early 2023, so stay tuned for that. There'll be better, easier to navigate, better designed. We'll have a stronger patient and family section as well, so we can direct our patients to get information that is relevant to their underlying care. And we're doing a lot of fundraising as well. And you may have received emails or seeing on social media. We're planning a big celebration for the career of Dr. Graham Turpey in the near future. He'll be at the Hamilton Golf and Country Club on October 22nd. So you've got some pamphlets in your registration, so please free to join us. And before starting today, I'd like to take a few moments to highlight Dr. Duquette's contribution to Thrombosis Canada. Is Jim in the room? Okay, we need to get Jim. Stat. We're on a tight. Exactly.
Yes, we're on
Okay, when he comes in, we just say, congratulations. He's not there? Okay. That's a downer. He's probably.
Should we postpone?
Well, we'll postpone it.
We'll postpone our.
We're on a tight schedule, so we'll start right away with the education session. And then we'll postpone Jim's celebration to next year.
Invite the first three speakers up. Make their way over to the table. So we'll have Dr. Sheldon Tobe, Dr. Deborah Siegel, and Dr. Sonia Anand who will be speaking for this first session. And might as well talk about Dr. Sheldon Tobe, who is our first keynote speaker for today. Dr. Sheldon Tobe is a professor of medicine at both the University of Toronto and Northern Ontario School of Medicine, was nephrology division director at his hospital, and is currently the University of Toronto Nephrology Postgraduate Fellowship Director. His clinical activities focus on hemodialysis and patients with CKD and hypertension. His main research interests are implementation science for dissemination of cardiovascular focused clinical practice guidelines. Dr. Tobe was chair of the Canadian Hypertension Education Program from 2005 to 2012, and is a co-chair of the Canadian Cardiovascular Harmonized National Guidelines Endeavor, or C-Change. Dr. Tobe serves on the board of directors of the American Society of Hypertension Specialist Program. With that, we would like to invite him to speak on anticoagulation and non-valvular atrial fibrillation in patients with renal disease. Thank you.
Thanks very much. And it's a pleasure to be invited. And thank you to the Scientific Planning Committee meeting, Scientific Planning Committee. I'm looking forward that we're all going to be together next year with Hypertension Canada and Diabetes Canada and so on. It looks like it's going to be a really exciting meeting, because I don't think we've done that for 15 years or so. It's been a long time. And too bad Jim's not here yet. Hopefully he'll be coming in soon. And okay, you're gonna have to wait, Jim. But Jim was my trainee at one point in time, a long time ago, a few years ago. And anyway, I'm just so proud of what he's done and what he's achieved. Okay, how is a hypertension guy talking to you about thrombosis today and anticoagulation and kidney disease? Well, I'm a nephrologist, and you heard I'm co-chair of C-Change. I'm now an implementation scientist, very interested in how to implement clinical practice guidelines. And as part of our C-Change process, we have developed education modules to promote the particular guidelines, one of which, of course, is to use DOACs instead of warfarin for patients who have non-valvular atrial fibrillation. And our needs assessment came back and said, what about patients who have chronic kidney disease? And so we created a module for that. It's actually quite popular, and I'm always happy to come and share about what the kidneys do and how to assess them and how to take and how to make adjustments for patients who have chronic kidney disease. Here's our learning objectives for the next 30 minutes, 29 minutes and 15 seconds. And here are the updated guidelines from the CCS for anticoagulation and atrial fibrillation. So for patients with stage 3 chronic kidney disease, which I'll define soon enough, but it's a GFR of 30 to 60 mils per minute, it's go ahead business as usual. But what about those patients whose GFR falls below 30 mils per minute? The previous recommendations were quite challenging and suggested that as soon as the GFR fell to 29, you had to switch to warfarin. And then when it went back up to 32, back up to a DOAC and so on. Now it's a little easier, as you can see. And as I'll talk about, we have agents that are approved for use from a GFR of 15 up to 29, 15 to 30, we'll talk about the dose reductions, but it makes all of our life much more simple. You don't have to monitor that GFR every few minutes and then switch the patients back and forth. We'll touch on patients who have end-stage renal disease and need dialysis, and they are still an enigma. Then I'll tell you what I do at the end. So here's an approach to kidney disease. This comes from KDIGO, and we're not going to talk about the albuminuria part today, just to focus on the G part, the glomerular filtration rate. We have 5 stages. G1 and G2, those are GFR above 60. They're essentially normal renal function. Well, why do we have a stage of kidney disease for normal renal function? That's for patients who have abnormal albuminuria or hematuria. Most of us in the room, I hope, are in the green zone. And for patients who have lower GFR, stage 3, that's a GFR of 30 to 60. That's where we expect primary care to be managing patients with chronic kidney disease. And here they've broken it up into A and B, which is 45 to 60 and 30 to 45. Nephrologists get involved with a GFR of 15 to 30. That's when we like to see patients. And that's when all of the things that the kidneys do go out of balance. And then it's time to start dialysis when the GFR falls below 15 mils per minute. Do patients who have chronic kidney disease benefit from anticoagulation? And I'm going to show you a number of meta-analyses and some studies. There's really a paucity of data in this area. So we have some bigger studies, but mostly very, very small amounts of data. So on the left column, patients who have CKD 3 to 5, so GFRs from, really from 15 up to 60, and ischemic stroke. Yeah, they benefit from ischemic stroke. Does anticoagulant therapy increase bleeding in these patients? Sure, it definitely does. And there is also that mortality benefit, just as you'd see with patients with normal renal function. On the right column, you can see patients with end-stage renal disease who are on dialysis, and there is no benefit in this analysis from anticoagulation, but they do get an increased risk of bleeding, and they do not get that mortality benefit. So this is older data, and this was, of course, a meta-analysis published in Chest in 2016. What about our patients? And I'll show you some newer data in just a moment. Just to give you the context of what it's like to manage patients with chronic kidney disease, our anticoagulation clinic at Sunnybrook will not manage the INRs for our patients on warfarin on dialysis because they're just too difficult. They don't like to do it. And this gives you an idea of how our patients do. We have all-cause mortality, stroke, and major bleeding in the 3 columns, and on the different rows are different levels of GFR. But you might focus on the stage 1 and 2, normal renal function, versus the last column, patients on who have severe kidney function, whose GFR is less than 30. And so for all-cause mortality, they have an 8-fold increased mortality, a 3-fold increase of stroke, and major bleeds, a 4-fold increase of major bleeds. So this is a really difficult population, and lots of bad things happen to these folks all the time. The Cochrane group has done an analysis from the major studies looking at the subgroups of patients with chronic kidney disease. And these are all studies from non-valvular AF. You'll recognize the studies, and they've culled out patients whose GFR was 15 to 60 mils per minute. They looked at DOACs, and in this analysis, we're looking at DOACs versus warfarin. And the major outcomes are stroke and embolic events versus major bleeding. Here are the studies. And in the first column, the N, I'm sorry. I spent the weekend 2 weekends ago with the grandson, paying for it ever since. You've got the N of patients whose GFR is less than 60, and then the percent of patients who have either stage 3 chronic kidney disease, a GFR of 30 to 60, or stage 4 chronic kidney disease, a GFR of 15 to 30. Bless you. Thank you. And what you can see is that patients who have stage 4 chronic kidney disease are very, very underrepresented in this analysis. But this is what we've got. So when we look at the impact of DOACs versus warfarin on stroke and prevention, it's non-inferior. This is not bad. And it hit unity there. So maybe just a few extra patients, we would have had statistical significance, but there's no question that the DOACs are preventing hemorrhage and bleeding episodes in our patients with chronic kidney disease. So it's significant for stage 3. For stage 4, we don't have enough data, but I think it's fair to extrapolate to stage 4, but we would really benefit from more data. Well, do patients with chronic kidney disease have the same rate of stroke from atrial fibrillation? Do they have the same pathophysiology? And this observational data set suggests that. So this data set came from Sweden, followed patients for 3 years, and there were 123 patients who had atrial fibrillation, 744 who did not. And so they followed them over time, and there's a number with new strokes. And of the patients who had atrial fibrillation, half of them of interest were on warfarin. And the patients who had atrial fibrillation, as you can see from the graph, are more likely to develop, to have had a stroke over that time period. So, and there's, I think it's 2.2 times, 2.2 times greater risk of stroke. So sure, patients with atrial fibrillation and chronic kidney disease are much more at risk of having stroke, just like everybody else. And is there a benefit of warfarin? Well, in this meta-analysis from 2020, there was no benefit of warfarin for patients whose GFR is stage 5. Most of these patients are on dialysis. Lots of small studies that are included, and the diamond sits right on the line of unity. And this is why we have a tremendous heterogeneity of practice for dialysis patients, and many units are not treating. Our unit does treat with warfarin. Other units are using other things. I'm a fan, if I'm going to anticoagulate, of using a DOAC. Here's newer data from Sweden. And in this study, patients on dialysis are followed, and these patients, sorry, they have CKD 3 to 5, but there's a good number who have end-stage renal disease. The lowest column, the lowest row, 4,179 of them with stage 5. And patients, these patients benefited from anticoagulation, warfarin versus no treatment. And it was an observational data set. And there's a 0.49 relative risk. So we're seeing a relative risk reduction close to that 65% that you would see with warfarin in the general population when treating. And of course, they also had more bleeding. So this is different from those previous meta-analyses I showed you, but something that I would more expect. Another more recent study out of Sweden as well, looked at patients that they collected from 2013 to 2018 in a registry. And look on the left, these are patients with all levels of chronic kidney disease. The blue is use of warfarin, the red is use of DOACs. And I think that represents the general population where we're really changing over appropriately. But now on the right, you can see why nephrologists are laggards in this respect. And for our patients on dialysis, many of these patients in Sweden remain on warfarin. And this is really what I think we would see also in Canada. Another interesting thing that came from this paper is that the time in the therapeutic range is really not good for patients with chronic kidney disease. And the worse the CKD, the worse the outcome. And our patients on dialysis really spend an unfortunate amount of time either too high or too low. And I always cringe thinking about what Bill Gertz says about patients who have INRs that are less than 2 in terms of the risk of thrombosis. And this is why I think our anticoagulation clinic won't have anything to do with their patients, but we do our best to try to keep them in the range. And I confess that my patients are not above 70% time in therapeutic range. 1 or 2 are, but 20% of my dialysis patients have atrial fibrillation and are on warfarin. And here's just a result from that Cochrane analysis showing that overall for CKD, really 3, that DOACs are superior to warfarin. And for bleeding complications, much superior as well. For major bleeds, they cross the line of unity, but for hemorrhagic stroke, they're definitely better. And for intracranial hemorrhage, 0.43, really great risk reduction ratios. And there's the forest plot. And that led to the CCS recommendations from Jason Andretti. And I've added in here that edoxaban has now joined the group for medication DOACs that we can use for a GFR down to 15 mils per minute. So we can use apixaban and edoxaban and rivaroxaban for patients who have really low GFRs. So if the GFR of your patient who has type 2 diabetes, let's say, is slowly going down, and then it starts to oscillate 30, 35, 25, depending on what's going on. If you're using one of these 3 agents, now you don't have to worry. You don't have to, you should be measuring the GFR maybe every 3 months, but you don't have to do it more often than that. So it can make our life much easier, make our patient's life much easier. So what do we know about anticoagulation for non-valvular AFib and dialysis patients? The field is evolving rapidly. There's a study going on right now out of St. Mike's, and we've accrued the patients. Now it's really a pilot comparing placebo to warfarin to DOAC, and we'll find out how it does. An attempt was done to do that in the States, but that study had to stop for futility. And I've summarized some of the guideline groups, and you see international guideline groups have different recommendations around how to manage patients on dialysis. As a guideline person, heterogeneity in practice really bothers me. So this is something we really need to fix, and we need study. And those 3 medications I mentioned, it makes sense that they will be effective in patients who have chronic kidney disease, because they have dual metabolism. They're metabolized by the liver and also by the kidneys, whereas dabigatran is only 20% liver metabolized and 80% renal. So you can see it would be a hard one to adjust for patients with chronic kidney disease. The others are at least 50% the kidney and 50% the liver. What about dialysis patients? We just finish up. I'll take you through a bit of a summary. This is data from Aristotle for apixaban, and the efficacy was not different, but the major bleeds were much less. And these are patients whose GFR was 25 to 30 mils per minute. So stage 4 chronic kidney disease. rivaroxaban, there's two studies here. One, and there's very few studies in this area. One from Matt Weir in the US, where he monitored observational study patients on dialysis and with CKD. 15% were on dialysis. And in terms of efficacy and safety, really the curves for patients with warfarin and the patients on DOAC were the same. And maybe with the eye of faith on the right, there's starting to be a benefit on the right from rivaroxaban. Also, a recent study, the Valkyrie study, and this study came out of Belgium and was done for a different reason. Vitamin K antagonists lower vitamin K, not surprisingly, and that's associated with increased calcification. Our patients on dialysis get calcified very quickly and severely. They get calciphylaxis, one of the most horrible complications that a patient can get. And the question was, if we give them a DOAC, is that going to prevent that from happening? If we give them a DOAC plus vitamin K, can we really make them better? So an interesting hypothesis, but it also gives us an insight into the use of DOACs on patients on dialysis. So rivaroxaban 10 versus rivaroxaban 10 plus vitamin K versus warfarin. And it's an 18-month study. And I'll take you through the next slide, which is another 18 months on top of that. So the results were not very exciting from the first 18 months. Everybody had vitamin K deficiency to start with. And then after warfarin, it got worse. There's only one calciphylaxis in the warfarin group and one in the DOAC, in the rivaroxaban alone group. So you can't tell anything there. And there were fewer life-threatening major bleeds with rivaroxaban. So I think that was a major result from this study, again, confirming the safety of DOACs on patients on dialysis. I'm really for using DOACs for non-valvular AFib patients on dialysis. The idea of putting them on warfarin and having only 40% or 50% of their time in the therapeutic range, so why are we even using that therapy? Now, they followed the study another 18 months and continued the same therapy and started to get some interesting results. More fatal and non-fatal cardiovascular disease with warfarin. Total mortality and cardiac death, risk of stroke wasn't different. Maybe an emerging signal coming, hypothesis generating that there is less calciphylaxis with rivaroxaban and vitamin K. Interesting hypothesis. Fewer lower limb ischemias. And I know there's going to be a talk, Canvas-related talk, talking about preventing ischemia today, and less life-threatening or major bleeds. And our patients on dialysis get terrible limb disease and loss of their limbs. So this is quite exciting for a nephrologist. Edoxaban, we have to look back to 2016, and edoxaban, just like that earlier study from Matt Weir, performed the same as warfarin in that study. So not better and not worse, leading us to the product monographs. And we do need to dose adjust medications for patients with chronic kidney disease. However, it's really important not to underdose the patients. If we underdose the patients, they're not going to get any benefit at all, and they'll only be exposed to risk. And cardiologists really always want to underdose our patients. So forever, I'm saying, no, the patient needs to be on an appropriate dose. So how do we introduce it? For apixaban, 5 milligrams twice a day for patients whose GFR is 15 or above, 2.5, the same 2.5 if the age is above 80 and the body weight is less than 60. Of course, they have chronic kidney disease. So they've already got one of the three criteria. For rivaroxaban, 15 milligrams, and for dabigatran, 110 milligrams twice a day, but we'll stop it if the GFR is below 30. And for edoxaban, 30 milligrams if the GFR is 15 to 30. Monitor the patients closely. And I counsel my patients on dialysis when we talk about anticoagulation, about the need for anticoagulation. And my patients all say the same thing. We don't want Bleeding, we don't want strokes, but given the alternative, we'll take the bleeding. So they're quite happy if I can put them on a DOAC and they're going to have less risk of bleeding because they really want to prevent a stroke. For a dialysis patient, that's the most devastating of all lesions. Lots of information at the Thrombosis Canada website. I don't have to tell you that. And just to summarize, the DOACs offer a clear safety advantage over warfarin in patients with chronic kidney disease, should be used in preference to warfarin for non-valvular AFib for GFR of 15 and above. The three agents, apixaban, rivaroxaban, and now edoxaban, can be considered all the way down to a GFR of 15. So you don't have to be panicky if the GFR is oscillating around 30. So it makes it a lot easier for our patients. For our dialysis patients, we still don't know the answer. More study is needed. My preference is to use DOACs in these patients. Just a shameless promotion for our meeting. That's a C-Change meeting coming up March 25th. And thank you very much.
Thank you, Dr. Tobe. We already have amazing questions online, and obviously people who are trying to run up and do some questions here. I will start with an online question though, and this is from Dr. Scarvelis. In terms of the dosing consideration, what calculation do you use for your eGFR? Is it Cockcroft-Gault? Is it a combination?
I used to be a Cockcroft-Gault fan. I'm still a Cockcroft-Gault, good Canadian boys, but it's not as accurate and precise. So then there was the MDRD equation, but now the equation that you get on the that comes back on the lab forms is fine, and that is a good estimate of eGFR, and it is a calculation, and it's got exponents and various things. So it's I could do Cockcroft-Gault in my head, but I can't do that in my head. But it comes out in the labs, and that one is fine. And it's one of those precision versus accuracy issues. But GFR of 30, whether it's 25 or 30 or 35, it's all a low GFR.
Thank you. I guess Dr. Carey, were you up first, or you were up? Okay.
Thank you for a very nice presentation. I want to pick your brain about something, because I agree with you. It pleases the mind to start patients on hemodialysis on a DOAC because it's easier and more convenient. And as you know, PK and PD studies have shown that at therapeutic dosing, at least with apixaban after 8 weeks, after 8 days of apixaban, when they do trough and peak, there's 2 to 3 times higher the level, which may not be correlating with bleeding in the observational studies. But how do you manage these patients for perioperative management or bleeding? How long do you hold them for?
And as you answered before, we work very closely with our pharmacists and get advice from our pharmacists. So I hold them 2 days before, at least, for a good 48 hours before. Our patients are not the most adherent. There's a lot of cognitive impairment, woolly minds from the uremia. So we're very cautious. So a little bit of extra time is what I recommend.
Thank you. Sorry, we'll just alternate with one more virtual question here. Someone was asking if there's any recommendations or guidelines or differences for patients on peritoneal dialysis versus other.
So there is no data on peritoneal dialysis. So we have to completely extrapolate to those patients. Their clearance is less, but clearance is not really an issue in these patients, and from what we're talking about this morning. But you just have to extrapolate to PD. And so I have some discomfort using a DOAC in a hemodialysis patient, especially when all of my colleagues are using warfarin. And to go to PD, I talk to my patient about it and I tell them that there really is no data, and I let them decide. They always decide on a DOAC, but I'm different in that respect. So your local nephrologists will all practice quite heterogeneously. Rita.
Thanks, Sheldon. So you've given us a lot of comfort around using DOACs no matter what, but which is the patient you'd use warfarin as? Like, paint a picture of who that might be, aside from mechanical valves, obviously.
For a hemodialysis patient, if the thromboembolism service says to use warfarin, I use warfarin. But you know what? They don't say that. So, it's been much easier. So really, I try not to use warfarin, but if the patient's a legacy patient on warfarin and they say, I want to remain on warfarin, it's worked for me, then I'll continue them on.
Thank you. Let's see here. It was a little bit alluded to before, but we have a question about just commenting on the monitoring of anti-10A levels in the CKD patients.
I wish I could see it. I know we do it at Sunnybrook, but we don't order it. And I'm a little bit afraid to see the results because I don't know how to interpret them. But what I would love to see is we really need PK data. And I would love to see a formal PK study with levels measured. So we could see, do they fluctuate over time? Are they stable? And can we correlate those levels with bleeding? And then, can we use that to predict? And maybe, we should be measuring the levels, as you say, 2 weeks out and titrating down if the 10A levels, are too abnormal. But yes, I would love to see factor 10A levels, done on all of our patients. That's something that we could do in Ontario. If there was will for it through the Ontario Renal Network, and we could measure factor 10A levels for 6 months, we would have the answer pretty quickly.
Go ahead.
Hi, just a quick question. So we're talking about atrial fibrillation and stroke prevention. What about VTE? So are there any patients in whom you've ever used DOACs for VTE treatment?
So when we get to VTE, okay, I have no evidence to back me up. There are no studies, but I do use DOACs for VTE because you guys are prescribing them. And our thromboembolism team is prescribing DOACs, and so we'll continue on. But I must say, there's a lot of anxiety around that. On the other hand, we don't have to measure the INRs and really sweat keeping the patient in the therapeutic range. So no, I do not initiate DOACs myself for VTE. That's skating, that's not even thin ice for me. That's way in the deep end.
Oh, thank you. With that, we would love to thank you for your wonderful talk. We have a little bit of time so that Dr. Carey can come back up, and we have Dr. Duquesne here. Or are we going to have the same issue as before? He's there. Oh, perfect.
Do you think we could put the slide back on, or is that too much work? If it's too much work, don't worry. I was just asking. Okay. Ah, perfect. Is Jim in the room? Okay. It was worth waiting for you, Jim. So I wanted to take a few moments to honor Jim Duquesne. He's been a real advocate for Thrombosis Canada. He's been the president of Thrombosis Canada for many years and really was instrumental into the transition of TIGC to Thrombosis Canada. He was one of the first ever recipient of the Thrombosis Canada Fellowship, so that's good return on investment. He's been president for many years and professor of medicine at McMaster University. So Jim, last year, we didn't have time to highlight your career and all your hard work, and we're truly grateful. And Jim is now still on the board of director. He's past president and providing us with insight in his experience as to how to run Thrombosis Canada. I just want to say none of us would be in this room without him, and it's a true privilege to have you as a president for so many years and as past president. So I would like Dr. Castellucci, the vice president, to come on the stage. Jim, we have a little something for you. It's Canadian art that hopefully will combine your different hobbies, and you'll find a place at home where to put it. But thank you.
Thank you, Jim. Thank you.
So Jim is a hockey player, so we were able to find something that hopefully will be an artist that is painting kids playing in the street. You can't see it because we wanted to keep it wrapped, but I just want to say that it's Montreal against Toronto, and the Toronto player is on his knees. But not this year. It's Toronto's Leaf fan.
Thank you very much, Lena and Mark. First of all, I'm kind of embarrassed because I was out of the room. I was actually working the floor and the lobby trying to raise money for Thrombosis Canada. And honestly, I wasn't expecting anything of this nature. So thank you. But any kind of recognition on a personal or individual level must acknowledge the family that Thrombosis Canada is. And this starts with Graham Turpey, who was the founding member of the Thrombosis Interest Group of Canada. And then my predecessor, Andre Roussin, who is not able to be here, and a number of other figures that have dedicated many hours, Alan Bell, Bill Geertz, who unfortunately can't be here either. But also, it's really delighted for me to pass on the baton to people like Lena and Mark, who are such high caliber, but also to recognize that we've diversified and we've become a larger family, in our partnership with Can Vector, with Mark Roger, and now Gregoire Legarle and Susan Kahn. And then next year, in our partnership with Vascular 23 with Dr. Sonia Anand, who's leading that. So really an individual award is a recognition of all of the leaders and all of you really. So on behalf of Mark and Lena and really all the people I've mentioned and on your behalf, thank you so very much for this.
Awesome. I'm glad that worked out. So we still have 2 more talks before the break. So I would love to invite up Dr. Deborah Siegel. She's perfect. So as she's walking up, just to introduce her, she is an associate professor of medicine at the University of Ottawa and associate scientist at the Ottawa Hospital Research Institute. Dr. Deborah Siegel will be presenting Reduce, Reverse, Resume, a multimodal approach to DOAC-related bleed management.
Thanks so much. Thanks so much to the organizers for the opportunity to present. Wow, I feel like that's kind of a tough act to follow. That was a very emotional speech, Jim. So thank you. We're going to be switching gears and talking about bleed management for the next 20 minutes or so. These are my disclosures. I received honoraria that were directed to my institution from manufacturers of some anticoagulants. These are the objectives that I'm hoping to accomplish. We have a short amount of time together. I just wonder if we could get the volume on the mic down a little bit. It's very loud. To recognize DOAC-related bleeding as an important cause of adverse outcomes and the importance of prevention. So we talked a lot about stroke prevention in the previous talk from Dr. Taube. We're going to expand that a bit into the bleeding side of things. We're going to apply key principles of bleed management for patients with DOAC-related bleeding complications, and then describe the role of reversal and or hemostatic therapies within a framework of, people talk about reversal, but really reversal is just one part of bleed management. And I like to think of it as being on a spectrum. And then finally, we'll briefly touch on an approach to restarting anticoagulants after bleeding, which is a really common clinical situation about which we know very little. So I'll start by emphasizing the importance of bleeding complications for our patients and for us, which is it's not a new concept for this audience. And even in 2022, 2 to 4% of patients each year experience a major bleed event, and another 10 to 12% of patients per year experience what we call a clinically relevant non-major bleeding event. And it's important to recognize that, these rates vary according to the indication for anticoagulation, the population under study, the study design. For example, bleeding rates are higher in people who have been observed in clinical practice, so observational studies, compared to those who were enrolled in clinical trials. We are very fortunate now to have DOACs, as you've heard from the previous speaker. DOACs are preferred for a lot of reasons, but particularly because they reduce the rates of intracranial bleeding, the most feared complication of anticoagulation. They reduce major bleeding. But as a class, it appears that they may increase the risk of GI bleeding, and we're waiting for the results of a head-to-head trial led by Dr. Castellucci to have some answers about that, whether or not there are agents that are perhaps better for GI bleeding. I just want to remind folks that GI bleeding is the single most common site of anticoagulant-related bleeding, and we actually know surprisingly little about the prognosis of folks who have GI bleeds on anticoagulation. This slide is a summary, just to give you a sense of, when we're talking to patients and counseling them about the risk of bleeding and thrombosis, I think a lot about the bleeding side of things. These are phase 3 clinical trials of DOACs versus warfarin for atrial fibrillation. And this isn't a meta-analysis. This is just a slide representing the mortality rates after anticoagulant-related bleeding in these studies. And the purpose of this slide is to show, yes, in dark blue, you see the warfarin-treated patients with rates of around, 11 to 14%. In the lighter blue, you see DOACs around 7 to 10%. So it's not meant to compare head to head here, just to give you a sense that, bleeding events are actually pretty serious, even in contemporary studies. The higher rates in the warfarin treated patients may be related to the fact that there's more intracranial bleeding, and that of course has very severe outcomes. I really like this sub-analysis of Aristotle. That was the randomized trial of apixaban versus warfarin for atrial fibrillation. And you can see they looked here at people who had major bleeding events in that study, over 800 patients. And the all-cause mortality after those bleeds within 30 days is really high after intracranial hemorrhage. 43% of people died within 30 days. But if you look at the non-intracranial hemorrhage patients, so those include things like GI bleeds and retroperitoneal bleeds and GU bleeds. 9% of patients here died within 30 days. So it's always a surprising number, I think, when I present to cardiologists. 10% of people have died after a bleed within a month, So this is a serious outcome for patients, which means that we have some good work to do. But there's other consequences too of bleeding complications. We know that they cause impaired quality of life, and that even for people, for example, who've had GI bleeding, there was a nice study by the engaged investigators which showed that people with GI bleeding had impaired quality of life up to about a year after their bleeds. Impaired functional status is a huge issue, particularly for people with intracranial hemorrhage. A lot of patients have functional impairments, long-lasting, serious functional impairments. We know that well-meaning or well-intentioned practitioners like ourselves often withhold anticoagulants for fear of causing harm of bleeding. And this is something that's really tricky in clinical practice to understand, what the net clinical benefit is for patients. Often anticoagulants are permanently discontinued after bleeding, and not just intracranial bleeding, but GI bleeding as well. And I'll show you some data about that. And then finally, we do see off-label use of low doses of DOACs, which Dr. Tobe alluded to as well, for fear of causing harm with maybe the full doses. That maybe a low dose is better, even though we're shifting that, benefit-harm ratio. But I can tell you that over the next 50 years, we're expected to see many more patients who are eligible for anticoagulants. And so bleeding is going to be a growing health problem. So this is a framework that as I've developed along the way, and I added another R here, refer, which I kept out just to keep it for the catchy title. But really, all of bleeding management in the clinic and in the hospital, if you're seeing patients with complications, starts with prevention. And that's really where we have an important role. And I'll actually come back to that at the end, even though I think it's the most important first step, because I think we've got a lot of work to do to prevent bleeds from happening in the first place. It's really important to, of course, to recognize bleeds when they happen, refer patients on appropriately. Maybe they need someone to go in and stop the bleeding with like a suture or a epi injection or a coil, right? Reversing anticoagulation or providing hemostatic therapies is important for patients who have severe bleeding. And then finally, reassessing anticoagulants after bleeding is an important and difficult decision. So when we think about patients who have acute bleeding, I'm very framework oriented, and my colleagues are like, oh yes, of course, the framework thing. But I always think, start at the beginning. There's a tricky clinical situation. It's always good to just start from the beginning. How severe is the bleed? Really important. Not all bleeds are the same. We don't have the same management. We should treat patients differently. Have supportive measures and interventions been initiated, particularly when there's like a really high acuity situation? You just want to stop and take a breath and think, okay, am I doing all the right stuff that needs to be done to save this person's life, like intravenous access and transfusion if needed, right? Those are really important features of bleeding management that we need to make sure are actually ongoing before you even call for the reversal strategy, for example. What DOAC has been taken and when it was taken is like the most important question, I think, that we ask of others when we're called about patients who are bleeding. And at our center, we get called about pretty much all the bleeds on anticoagulants. And the reason that's important is because it leads to the next question is the DOAC present in, quote, significant quantities? And you'll note that I put that in sort of quotation marks, is because, as I'll talk in a couple of slides, we don't actually know what significant quantity looks like, really. Although we have some idea, we don't really have a number, which makes it pretty challenging. So finally, you're going to ask, is there a role for reversal? But as I mentioned, not all bleeds are the same. And this is just a schematic diagram. There's lots of these, but we do this automatically in our daily lives, and people here from varied practices. So you may see people in the green side of things most in your practice. We see a lot of this. I was dealing this week with a patient who had epistaxis, and last week it was someone who kept calling in with hemorrhoidal bleeding. So we do in our practice see a lot of the green, maybe non-major bleeding. Usually those patients are people for whom we would continue anticoagulants and monitor them appropriately. Not all patients need to discontinue, but I should mention also that, DOACs are now convenient. They have short half-lives. They start to work really quickly, 2 to 3 hours, they're at peak effect. So if you do need to stop DOAC temporarily, that's actually, pretty straightforward these days, as opposed to the era of warfarin where, 5 days and it takes to leave your system. But again, you're going to monitor the patient, make sure they're taking their drug properly. I did that this week for my patient. Can we ask him if he's taking an NSAID? Do we know if he's taking an aspirin? What about fish oil? I always ask about fish oil. And so, we did a CBC. So it's just important to make sure, because and I've referred him to a ENT for cautery, for example. Once you get over to the red side of the screen, that's when you're really, we're stopping anticoagulation for major bleeding. This is where we're going to make sure people have, interventions underway. They're getting replaced with volume. They're getting transfused. This is when we start thinking about reversal and hemostatic strategies. I should just say that andexanet is not currently available in Canada, but it will be hopefully coming soon to Canada. And I wanted to also mention here that people often will talk about adjunctive therapies like tranexamic acid, which is great in many settings. We have lots of great quality data about tranexamic acid for postpartum hemorrhage and cardiac surgery and all sorts of other indications. But for GI bleeding in particular, there was a big study which showed that there was no benefit of giving tranexamic acid and a signal for harm with increased VTE. So just be aware of tranexamic acid for GI bleeding. So when do we consider reversing anticoagulation? It's really helpful to have a framework to think about this as well. Like, you want to use the right drug for the right patient at the right time. And so patients, who are candidates for reversal or hemostatic therapies are those who have, really severe bleeds, major bleeding complications, critical organ bleeding. If they continue to bleed despite measures to control it, that's an indication as well. That's much less common, I think, in clinical practice. If there's bleeding with an expected long delay in achieving hemostasis. So I think of an overdose perhaps, or someone who's acutely on dialysis. Maybe they had dabigatran and we just know it's going to be a really long time for that drug to clear and they're bleeding. That might be an approach. Oh, I moved automatically. And then finally, urgent surgery. Patients who are on anticoagulants who need urgent surgery and that surgery can't be delayed and it can't be conducted safely on an anticoagulant, then you're thinking about a reversal strategy. But again, stewardship is critical. These medications that we're giving for reversal or hemostasis have potential harms associated with them, and they're also costly. So the people, when we're thinking about bleeding, people with severe bleeds, people who have a DOAC present in, again, quote, significant quantity. So again, that's hard to know. We're going to talk about that in a couple of slides, but either we know that they have a significant quantity of DOAC, or we think that they have a significant quantity of DOAC. Those are the people where we're going to want to use a reversal agent. And then which reversal agents are available, well, I'm going to talk about in the next few slides. So let's just pause for a minute to wonder about DOAC and measurements. And there were some questions in the last talk about measuring DOAC levels. And Dr. Tobe said, I don't want to know. And that's because we don't really know. And I feel the same way. So I'm with you. We don't, the DOACs were designed to be taken in fixed doses without monitoring. So we know from PK studies that they did early on in the development of those drugs that there's kind of a range that we can expect in patients who are, therapeutic. But we don't really know what a number corresponds to exactly. We also don't know what the threshold is for anticoagulant effect. And this is probably the biggest challenge. So there's some guidance from ISTH, which is a bunch of really smart people who got together to try to help clinicians understand what the levels are. And so you'll see levels of 30 nanograms per mil or 50 nanograms per mil. We don't really know that is the actual threshold, although below 30, you're probably unlikely to have clinically significant effect. But all that being said, most places in Canada and the world don't actually have access to anticoagulant DOAC testing. So, most physicians, when we talk about this, for emerge docs and others who are seeing patients on the front lines are like, well, I don't have DOAC level, so it's kind of meaningless for me, which is, I think, an important consideration. The challenge for us and for those people is that routine coagulation tests, which we would measure for all patients with bleeds, INR, PT, PTT, those are routinely available. We're all familiar with those. They're not accurate or reliable, but they can still be helpful. And on the next slide, we'll talk about how that is. So you may have a specific assay at your site. At our site, we can get 10A assays that are calibrated for DOACs, but we have to interpret the results, but also the turnaround time is not quick, and often it's a 9 to 5 thing. So that's not very helpful in a bleeding emergency. So I summarized just what we know a little bit about some of the testing on this slide. And on the left hand, you'll see the columns just has the different tests. So on the top 3 rows, you see the routine coagulation tests that we're familiar with. Maybe thrombin people are less familiar with, but we'll leave that aside for a minute. And you can see that some of the DOACs do actually affect some of the routine coagulation tests, which is really helpful if it's abnormal. It's much less helpful if it's normal because the tests are actually not very sensitive to pick up the levels of the DOAC. So you see their rivaroxaban can increase the PT or INR, but not always. And it depends on your assay. It depends how much rivaroxaban there is in the blood staining. Same thing with dabigatran for the APTT. Most times, if you have significant levels of dabigatran, the APTT will be prolonged, but not always. It depends on the assay. The thrombin time is extremely helpful. And I don't know how many people use that test, but if you have a patient on dabigatran and they have a normal thrombin time, there is basically 0 dabigatran in their bloodstream. Very helpful. But you can see on the bottom 3 rows, these are the special calibrated assays. These ones are much more accurate and reliable, but they're not routinely available. So not that helpful in practical terms. But the routine coagulation tests can be used qualitatively. So if you have a patient who's taken a DOAC and they have an abnormal coagulation test and you don't really have another reason to, expect that they would have a coagulopathy, then that means probably they have clinically significant levels of drug. So for example, this week I had a patient who had epistaxis and his creatinine had gone from 130 to 176. And so, he was on apixaban and we had held this apixaban. It's a long story, but his INR was 1.4 2 days later. So I was like, that's probably the apixaban doing that, just to give you a real-time example. But if they're normal, they may not rule out clinically significant levels of drug. So you need to be, put your, the art of medicine cap on and say, okay, well, we're going to interpret these results based on the local assay, which you may not know about, but the dosing interval is extremely important. If they took their drug 4 hours ago, you're really expecting that person to still have therapeutic levels of drug because the half-lives are around 12 hours. Right, for all of these. And you're also going to think about their renal and liver function. So, fear not. I think we can still, have a routine coagulation test in conjunction with what you know about the patient and their metabolic parameters and the drug half-life. And we can still have some reasonable assessment of whether or not they have a DOAC in their bloodstream. So if they do, and they're bleeding, then we're going to maybe reverse their anticoagulation. And there's 2 agents that do this. One is idarucizumab, which is a specific reversal agent for dabigatran, and that's available in Canada. It's a humanized monoclonal antibody against dabigatran. And then there's andexanet alpha, which we don't yet have available in Canada. And this is a recombinant factor 10A molecule. So it's a decoy that binds up the factor 10A inhibitors in the bloodstream. And these are indicated, so idarucizumab is indicated for both bleeding and surgery. Right now, andexanet alpha is only indicated for bleeding on apixaban or rivaroxaban. I'm just going to show you a couple of slides about the studies that led to the registration or the approval of these medications. Reverse AD was the registration trial of idarucizumab for dabigatran reversal. And in that study, dabigatran treated patients either presented with major bleeding or urgent surgery, and they were given a dose of idarucizumab 5 grams. And you can see on the right-hand side, just a summary of the data, which showed that, the majority of people achieved hemostasis. And here, hemostasis was defined in this study similarly to the way it was defined in other studies, particularly studies where they looked at PCC for warfarin reversal. So, most people stop bleeding within 24 hours. That's pretty good. The thing that to recognize about this study and the ANNEXA-4 study, which we'll talk about on the next slide, is that there was no control group here. So this is actually a prospective cohort of these patients. We don't know, there was no comparator group. Sorry. And you can see on the graphs on the bottom, on the left-hand side, that when you give idarucizumab, the levels of unbound dabigatran, that's the active drug, basically drop down to 0, right? It works really quickly. Same thing with abnormal PTT, corrected really quickly after administration. So it does what it's supposed to do. Similar design for ANNEXA-4. This was the study that led to the approval of andexanet alpha in the US and Europe and other places. This included patients with acute major bleeding on the factor 10A inhibitors, and this actually included enoxaparin, and they received andexanet as a bolus followed by a 2-hour infusion, and the dose was dependent upon the type of DOAC they took and then when they took it. Similar sort of thing you can see here, 82% of people achieved good or excellent hemostasis within 12 hours. There are definitions of hemostasis in the study according to the site of bleeding. In this study, there was actually an independent committee that adjudicated a hemostatic efficacy in the study, which was a bit different than the idarucizumab study. But you can see again at baseline, this is the image from the apixaban group, you can see that administration of the bolus decreased the anti-10A activity. Sorry, not sure what's happening. Back down to 0, and that low level was maintained throughout the duration of the infusion. And then afterwards, the levels crept up again because of the short pharmacodynamic half-life of the drug. So what about we don't have andexanet alpha in Canada, so this is something we see, we talk about all the time. What about 4-factor PCC? I'm sure many people are aware, have given it in the set. PCC is prothrombin complex concentrate. It contains the vitamin K dependent coagulation factors. It's actually was designed, for warfarin reversal because that's what it supplies. And much of the data that we have about PCC, and there's more all the time, but it really is derived from, lab studies, animal model studies, and then volunteer studies. Also some cohorts of patients who were treated in routine clinical practice, again, without control groups, which makes it really challenging. But the evidence of reversal is conflicting and modest. And so that's a big challenge for us. So we sort of give PCC in an effort to overcome the anticoagulant effect of the factor 10A inhibitors. I should tell you that the dosing of PCC is actually uncertain and perhaps controversial. So we are coming out with a new Thrombosis Canada bleeding guide, and we will be updating some of this information, so stay tuned about that. There are also new guidelines from the NAC, which is the National Advisory Council on Blood and Transfusion in Canada, about dosing of PCCs for this. But acknowledging that there's uncertainty, we have like a range of options for people. So sometimes people use a fixed dose of 2,000 units, and sometimes people use a weight-based dose, like 20 to 50 units per kilo. And sometimes people have a max dose of 3,000 units, and some sites don't. So I don't know what the right dosing strategy is, but it's just important to have follow your institutional protocols. This slide summarizes some of the results of those cohort studies that I talked about. So you can see Majid and Shulman, those were studies done, with the collaborators from McMaster and other places. And those were patients who were treated according to institutional protocols with PCC for factor 10A inhibitor related bleeds, a kind of a mixed variety of bleeds, but a lot of intracranial hemorrhage in there. And you can see that many of those patients received 2,000 units of PCC, and the majority of patients achieved hemostasis. On the right-hand side, you'll see Connolly 2019, that's the NX4 study, just for sort of some comparison. Again, these are not head-to-head comparisons because we can't do that. The populations were really different. None of these studies had control groups, but you can see that most people stop bleeding, which is great. You'll also see at the bottom what I had talked to you about earlier, which is that a lot of people die after these bleeds. You see rates here of death between 14 and 32%, and that probably reflects the underlying population, particularly intracranial hemorrhage. And I also want to call your attention to the line of thrombosis, which is the second from the bottom. So thrombosis is something that we hear a lot about. Obviously, we are thrombosis doctors and we would like to avoid thrombosis at all costs. But these patients are prothrombotic at baseline, and they now come in with a bleed and we've taken away their anticoagulant, and maybe we've given them a reversal agent or a hemostatic therapy. And now they're sick. Maybe they've had surgery or some sort of procedure. Their coagulation systems are activated. So we're not surprised, unfortunately, to see that there is a rate of thrombosis. Whether one or another of these treatments is better with respect to thrombosis is completely unknown. So what I think this means is A, again, we need to prevent bleeds from happening in the first place. And B, we need to start thinking about getting people back on their anticoagulants when it's safe to do that. This is a meta-analysis that was done, which kind of nicely illustrates that same point, but with a graph for those people who are more graphically oriented. You can see on the right-hand side of the screen, we're like, wow, all these people, most people achieve hemostasis, which is fantastic. You can see the treatments on the bottom, PCC, idarucizumab, and andexanet alpha in different colors. On the left, you see deaths. Lots of patients die after these bleeds. This is a really serious complication for older comorbid patients who, perhaps have difficulty recovering from these types of events. So they're not all bleeding to death. They're not. The causes of death are not entirely clear, but I would say for some of these studies, half of them die of cardiovascular causes, and that can include clots and bleeds, and half of them die from other things, complications of being in hospital, infections, that sort of thing. And then there's that risk of thrombosis that we talked about as well. But at the end of the day, there's a lot of uncertainty because we don't have comparator groups. So we don't know about the incremental benefits and harms of these treatments. And so it is important for us to continue to do data, to continue to do research to gather these data that we need. And I'm just going to end with the last few minutes just about what we do in this scenario. So I said it's really important, get people back on their anticoagulants. Well, we don't actually know when to do that. And in fact, many patients are permanently discontinued from anticoagulation after a bleeding event, more so with ICH than GI bleeds, but even GI bleeds up to 50% of people never restart or don't restart in the long term. And it's just because we don't really know how to do this. The data are not available, and much of the data that we do have is derived from warfarin-treated patients. So I just wanted to show some of this, like, again, shameless promotion, like Dr. Tobe, you're not the only one. This is a study that we did, which is Ontario data, where we looked at people who were admitted to hospital with anticoagulant related bleeding. And you can see that in people who restarted anticoagulants compared to those who didn't restart anticoagulants, there was a twofold increased risk of bleeding, lower risk of thrombosis. And it appeared here that there was a signal for mortality, but I just want to caution you with these data that are observational in nature. This is administrative health data for people in Ontario. Because they were treated in routine practice, this was not a randomized trial. Physicians made the decision to start somebody or not start somebody. And it's likely that the people who were restarted on anticoagulants had a better prognosis overall. So we just have to be careful about the mortality data with these studies. But I think if I can get across one message about restarting anticoagulants, it's that all bleeds are not the same. And there's really no one size fits all. We get asked, well, when should we restart? And you're like, well, what kind of bleed? What happened? What was done? What were the circumstances surrounding the event? And I put GI bleeds here on the left because that's really the most common type of bleeding that we see. And then intracranial bleeding on the right. But even within these categories, there's a huge variety in the risk of bleeding, why they happen in the first place, what would be done to correct the bleeding, and then what the risk is of bleeding afterwards. We did a meta-analysis where we looked at, people who restarted anticoagulants after GI bleeding. And again, you can see the signal, in people who restarted anticoagulants had more bleeding and less thrombosis. But you also see in the blue box on the top that anticoagulants were permanently discontinued for a long period of time in over 40% of people, which is very interesting. With regards to the timing of warfarin restart, this is an area of uncertainty. We're doing some studies now looking at restarting DOACs after bleeding. So maybe I'll come back in a few years and tell you about the results of that study. But if you focus on the right-hand side of the screen here, you can see that the timing of warfarin restart may actually affect the risk of bleeding. That makes sense. So in this study, this was a cohort of patients. We saw that people who restarted warfarin had more bleeding and less thrombosis. That's kind of a theme. But the people who restarted warfarin within a week of their bleed had more bleeding compared to the other time points. So that's actually where this kind of 1 week comes from. If you hear that, I'm not sure if people are thinking of a week. Most of us will say, you know, a week is a reasonable time frame, but that's really based on these data of warfarin treated patients from almost 10 years ago. Similar picture with intracranial hemorrhage. People who resume anticoagulants after intracranial hemorrhage have a lower risk of stroke. And here in this study, again, similar risk of recurrent intracranial hemorrhage, but you always have to ask yourself, if these patients were treated in routine practice, is that just because the doctors were less worried about them having recurrent bleeding and therefore put them on those drugs? We don't know the answer to those questions. There's a lot of trials going on in this space now for atrial fibrillation patients with intracranial hemorrhage. So I just wanted to show this briefly, this interesting pilot trial, which is now being done as a full-scale trial, where they randomize patients to a strategy of avoiding anticoagulants or restarting anticoagulants. And you'll see in this blue box that I just showed here, that among the people who restarted anticoagulants, there were 8 rebleeding events compared to 4 rebleeding events in the people who didn't restart anticoagulants. But if you look at the stroke outcome, you can see that among people who restarted anticoagulants, there were only 3 events, while in the people who didn't restart, there were 18 events. So again, not clear what the net clinical benefit is for this type of study. Both of those events can impair, quality of life and function. And so we'll wait to see. When do we restart after intracranial hemorrhage is really tricky. This is a study, and I'm going to focus you just to the right-hand side of the screen. These were high-risk patients with atrial fibrillation, and the graphs that you're seeing, or the lines, are cumulative incidence of different events: thrombotic, hemorrhagic, and vascular. So these investigators found that if you restarted people at 7 to 8 weeks after their bleed, it seemed like that was the time frame that had the most benefit. And that's actually what's reflected. There are guidelines about this, low quality evidence, but so at the end of the day, we're left with this. There's an approach to anticoagulation after bleeding, which is really one that balances thrombotic and bleeding risks and should be done in collaboration with your patient. All of these, of course, have such an impact on people and their families. But if we return back to this kind of framework, you'll note that I didn't really talk about anything to do with reduce, but that really evaluation and addressing modifiable risk factors for bleeding is extremely important. I think there's a long way to go here. We really need to start moving the needle in the prevention department. And so I encourage you to think about, a long-term management of anticoagulation that incorporates all of these aspects. And I'll stop there because I'm almost out of time. So thanks so much for your attention.
That was an excellent presentation. Thank you so much. We already have a very active audience online, but I might want to ask my own question, because I've been hearing that at an exit will be coming for a long time. I don't know if you have any insight on when you think it might actually come.
I don't have insight on that. I'm just checking that. I don't have insight, but it is in the process of coming to Canada.
Perfect. So the first true question here will end up being about the effectiveness of idarucizumab with the generic dabigatran, just because some of the packaging is slightly different. Is there any pharmacokinetic differences that might be implied with generic versus brand name dabigatran?
Thank you for that question. I don't know the answer to that question, but it's hypothesis generating. So now, I think that we're now seeing increasing use of generic. We now have generic apixaban as well. And so there are, residual questions about whether or not they work as well and are as safe. Certainly the studies that have been done suggest that the pharmacokinetics are within acceptable limits for us to prescribe those. Whether or not it would have an effect, I assume it would. But that's an interesting point. It is a monoclonal antibody directed against dabigatran. I'm not sure if the epitopes are particularly different, but I think the molecules have to be the same. Yeah.
Thank you.
Thank you for the presentation, Dr. Siegel. So our colleague gastroenterologist recently did some clinical practice guidelines suggesting against reversal or PCC use in major GI bleeding. What's your opinion on that?
Thanks, Mark. I'll also note that Dr. Ducatis was on those guidelines as well. So I know to be careful what I say. No, I think that the authors of those guidelines acknowledge that there are limited data in this space to understand, again, the incremental benefits and harms of those treatments. And so to some degree, there is an individualized approach to this. And I think that's an area where we need more research to be done. Certainly in the acute setting, it's challenging because the treatment of a GI bleed, potentially upper GI bleed, would be to go and intervene with endoscopy and epi and cauterization, and whether or not there's some additional advantage of providing of establishing or reestablishing hemostasis is uncertain. So I think the jury is still out. I think there's still an opportunity if you think a patient is bleeding to death in front of you and there is no other opportunity to intervene otherwise. I do think it's reasonable. We don't have the data to say that it's beneficial or harmful in that specific setting.
Can you hear me?
Yeah. Oh, yeah.
So this is a simple question, and maybe a big question, but you spoke about reducing risk, and I spend a lot of time in clinic and I always sort of go through the bleeding risk factors. But I guess my first question would be, what either formal tool or what big risk factors are you looking for? And if any, like I'm often telling my patients, you should be drinking less, we should be controlling your blood pressure, but what modifiable bleeding risk factors do you think have the most bang for their buck? Like, are there studies that show that if patients' blood pressure is really well controlled on a regular basis, that mitigates that risk?
Yeah, thanks so much for that question. I agree with you. That's why I think we really need to start moving the needle in the prevention department. I guess my approach is similar to yours. Address the things that are modifiable, or like NSAIDs, antiplatelet therapy use. Really, does this person need to be on aspirin or Plavix or whatnot? I always ask about herbals because lots of herbal medications interfere with platelet function, and people will come with like lists, back and forth. So I always ask them, and if they're particularly if they're bruisey, I definitely fish oil, ginseng, ginkgo, those things all can interfere with platelet function. It's really important to ask about that. But we do hear this about blood pressure. We don't have high quality data to suggest that there's an approach. And unfortunately, we have risk prediction models that help us identify people who are at higher risk. But many of those scores or models don't actually incorporate a lot of those risk factors are non-modifiable, like renal function and other sorts of things. So I agree with you. Sometimes people ask about PPIs like gastric protection. There is no indication at present that gastric protection should be done for people on anticoagulants in the absence of some prior history of bleeding, et cetera. So that's another we're submitting. We just submitted a grant to look at that for some evidence, but there's some observational data to suggest that PPIs lower the risk of GI bleeding, which we would expect. But it's a good point. I think those are all the things that we should be doing over time. Yeah.
I think we have time for one more question, Dr. Crowther.
Yeah, just really quickly, the comment about Andexanet. So just, is it coming to Canada? As far as I know, so you may know Portola made the drug and was bought by Alexion, who's out there. And then Alexion was bought by AstraZeneca. Yeah, I know, they're right there. And AstraZeneca, I don't know if there's any AstraZeneca spies in the room, but there might be. So AstraZeneca is actively trying to move that product forward in Canada. I think we all know what the major impediment is, and that is that the stuff in the United States is extravagantly expensive. And so it's a major problem for the Canadian government, provincial people who pay for drugs, and then individual hospitals to decide how that's going to be done. But there is an intention to move it forward and bring it to Canada, assuming that some kind of validated costing model can be figured out. And I don't believe the paperwork's actually been submitted to Health Canada yet. So it will be a while before that paperwork is actually moved forward, but there is an intention to bring it to the market.
Thank you.
Thank you. So we would like to thank Dr. Siegel once again. Just as a reminder, especially for the online folks, if you have questions, please do email it to Holly, and then we'll try to get our speakers to answer it, and they'll be available online. Now we'll have our third speaker for today, Dr. Sonia Anand, who is a professor of medicine and epidemiology and a vascular medicine specialist at Hamilton Health Sciences. Dr. Anand is a senior scientist at Population Health Research Institute and director of the Chanchalani Research Center, McMaster University. She will be presenting for us peripheral arterial disease, candidates for dual pathway inhibition. Thank you.
Great. Thank you very much. Good morning, everyone. It's nice to see so many familiar faces. And today I'll describe peripheral artery disease. And I'm wondering if I could see a show of hands, how many of you see PAD patients as part of your regular practice? Okay, so I think you'll see more and more now that there's an increased awareness of peripheral artery disease. I have some disclosures here. And I'll just start off with the overview of today. I'll present to you some of the exciting data that's really been generated since 2018 with respect to dual pathway inhibition for patients with PAD. And the focus of today's talk is not to review the clinical trials themselves, COMPASS and Voyager. I'm sure all of you are familiar with the trials, but to really take the next step to say, based on those trials, which of our PAD patients should we consider for dual pathway inhibition? So I put some questions to you. Should it be all patients with peripheral artery disease? What have we learned from COMPASS, Voyager, such as risk benefit? What about the use of clopidogrel? It's still an ongoing question that we face, especially for PAD patients who undergo endovascular intervention. And what do we know post COMPASS and Voyager with respect to real world experience? So to just remind everybody about the pathogenesis of atherothromboembolism in PAD patients, you can see this graphic. So we have the artery, we have underlying atherosclerosis, which in PAD is generally widespread. And what we think happens is a thrombus develops on the atherosclerotic plaque. What makes that plaque unstable is, could be multifactorial, shear stress, inflammation, etc. Superimposed thrombosis, that's called atherothrombosis. And then atherothromboembolism is a piece of that thrombus breaks off and goes to a distal site. And when we look at data from above knee and below knee amputations under the microscope, you can see layer upon layer of organized thrombus. So we think that this is an ongoing process within PAD patients. And eventually, one of those thrombi that go distally may lead the patient to present with acute limb ischemia, that acute event. So it makes sense that we are targeting these underlying processes. First, trying to prevent atherosclerosis and atherosclerotic plaque. I won't get into that side of the management, but that's crucial in PAD. And then the second part is which is the optimal antithrombotic regimen to prevent atherothromboembolism. And I like to make this analogy of acute limb ischemia to a STEMI, mostly for cardiology audiences, because I hang around with cardiologists a lot, and they always kind of hold STEMI as the most important thing for us to prevent. If we look at patients who have acute limb ischemia, this is a sudden loss of blood flow to the limb, typically the lower limb, where patients present with those 4 Ps, painful, pulseless, paresthesias, and pallor limb. These patients present to the emergency room. And just like we've learned with STEMI, that time is muscle. So we have to get that patient diagnosed and into the OR to prevent ischemia and muscle loss. In STEMI, we need to do that with PAD patients with ALI or acute limb ischemia. And if you don't treat these patients quickly, they may end up requiring an amputation. And if they have an amputation, they are, again, at very high risk thereafter of death. And I'll show you some data to support that. But if we just looked at the mortality at 1 year after acute limb ischemia, you can see it's higher than that of 1 year mortality post-STEMI. So, we often kind of compare our conditions, but it's all this to be said that our goal in PAD management is to prevent acute limb ischemia from happening, because when it does happen, the patient's prognosis is very bad thereafter. And many of the strategies that we've tested in patients with PAD have been to prevent thrombus and prevent acute limb ischemia. And it would take a long time for me to go through all of these trials. So I've tried to simplify it in this graphic. And you can see we're always, like every antithrombotic, trying to minimize ischemic risk and minimize the bleeding risk. And if we look on the far side of the trial to the antiplatelet trials, many of you will remember some of them. I do when I present these or discuss them with my residents. I remember when I was a resident, the Capri trial was ongoing in the 90s. And that trial demonstrated clopidogrel was superior to aspirin in patients with generalized vascular disease, including PAD. So when you look at guidelines, you will see that a class 1A recommendation at a minimum for patients with PAD is to have them on an antiplatelet agent, single antiplatelet therapy, and clopidogrel slightly better than aspirin. So that's kind of where we were at for a long time, pre-Compass and Voyager. On the far side to you would be on the right side of the screen. You can see the oral anticoagulant trials, and I sometimes say that my fourth child was the WAVE trial because this was a trial, a labor of love, CIHR Heart and Stroke funded trial. So, that's really, minimal funding, hard to do. And we tested oral warfarin plus an antiplatelet agent versus antiplatelet alone in patients with PAD, thinking that we would observe a significant reduction in major adverse cardiovascular events as had been observed in patients with coronary disease. But we were surprised to learn that, in fact, there was no reduction in major adverse cardiovascular events and an excess of life-threatening bleeds. So the WAVE trial put the brakes on the widespread use of warfarin plus aspirin in patients with PAD. So you'll see now in practice, sometimes our PAD patients are on it, but we try to keep it to a minimum. So it might be after acute limb ischemia, but it's not long-term. And so that brings us to the center of the slide where you can see the Compass and the Voyager trial. And I call those trials that hit the sweet spot between lowering ischemic risk and minimizing serious bleeding. And we'll go in more depth into those trials. So this is a kind of a schema showing why what we call dual pathway inhibition works. You can see we're trying to prevent platelet activation with the antiplatelet. In the trials, aspirin was used, and the factor 10A inhibitor, low-dose rivaroxaban. And in the case of Compass and Voyager, we had a lot of preclinical data and then data from acute coronary syndromes in the Atlas 2 trial to point us toward going with a lower dose of rivaroxaban. So we chose 1/4 of a full dose, which is 2.5 milligrams BID. And that's what was tested together with aspirin in PAD patients. And I show this slide to just demonstrate the risk that PAD patients have with respect to future MACE, major adverse cardiovascular event. And I like to show it because you can see on their own, so a patient with PAD only or a patient with CAD only has about a 6 to 8% risk of recurrent MACE over a 2 to 3 year period. When patients have both CAD and PAD, it's double. The risk is double. So we call these patients polyvascular patients. So keep an eye out for your patient when you're called to assess them. And you can easily determine by their history, have they had previous stroke, CAD, and do they have PAD? And if they're a polyvascular patient, they are the highest risk patient no matter what. So when you're thinking, should I treat them with more than a single antiplatelet? The answer is yes, if they're polyvascular. In every analysis we've done in Compass, Voyager, and now an ongoing registry, this group of patients comes out as the highest risk. So you can determine it easily and treat them because they're very high risk for recurrent ischemia. Now, this demonstrates Compass versus Voyager and the types of patients that were enrolled into the trials. So Compass came out first, so you may be more familiar with this. And in the Compass trial, we enrolled patients who had what we call chronic stable PAD. These would be patients you'd see in an outpatient clinic, a past history of a peripheral revascularization, intermittent claudication, carotid artery disease, and I'll come back to that. And as well, patients who have coronary disease. And when we measured an ankle brachial index, it was low, indicative of what we may call asymptomatic peripheral artery disease. Those were the patients enrolled into COMPASS. In Voyager, we selected patients who were going to undergo infrainguinal revascularization. So they were already kind of being prioritized by their surgeon or the interventional radiologist to have a revascularization. So a slightly different group of patients. And I will say 30% of the Voyager patients have what we call critical limb ischemia. So that's severe limb ischemia that could convert to acute limb ischemia or may be associated with something such as a non-healing ulcer. Now, the results from the COMPASS trial demonstrated the superiority of low-dose rivaroxaban and aspirin in the black line compared to aspirin alone. And overall, we demonstrated a 31% relative risk reduction in favor of reducing MACE, as well as what we call MALE, major adverse limb event, that includes severe limb ischemia leading to an intervention or amputation. So for the PAD field, this was an incredible result because if you look at other trials, they didn't observe MACE or MALE reduction. Some trials showed a MACE reduction and didn't measure MALE. Others showed a MALE reduction and no change in MACE. So this was kind of the home run observation. And if you look at the black line in the Kaplan-Meier curve, you can see that the curves start to diverge early. So once you initiate this dual pathway inhibition, the patient is accruing benefit very early on. Now, coming to the COMPASS patients, I mentioned they were enrolled with, different subtypes of PAD. Symptomatic PAD of the limbs would be patients who tell you they have intermittent claudication. So that's pain with walking that's relieved by rest. And actually that question is very specific to diagnosing intermittent claudication. If you dive deeper into it, it's called the Edinburgh Claudication Questionnaire. Very simple questions you can ask in clinic, and it may lead you to say, I want to measure an ABI in this patient, or I want to send them for a vascular ultrasound. These included patients who already underwent previous revascularization. And then next you'll see carotid disease, and I'll spend a little time here because this was an inclusion criteria that we debated with our stroke neurology colleagues. And then when we were publishing the paper, some of the reviewers said, how come carotid disease is called PAD? Long story short, the American colleagues don't like to call carotid disease PAD, whereas our Europeans think of it as PAD. So there's a bit of a cultural difference. To get into COMPASS, you had to have a prior carotid revascularization. So that could have been a carotid endarterectomy or asymptomatic carotid stenosis of more than 50%. So think of all the patients you may see in clinic who you see, yeah, they had their carotid ultrasound and they have more than 50%, not high enough to warrant a carotid endarterectomy, but still substantial atherosclerosis. So these patients, we had about 1,900 of these patients in the COMPASS trial, show benefit with dual pathway inhibition. So if you're seeing them for whatever reason, and they're on a single antiplatelet agent, they could be on that for PAD, they could be on that for CAD. If you notice, they also have carotid disease. They are polyvascular in a sense, so you can prioritize them. And then the CAD patients with low ABI. Just a show of hands for me, how many of you measure ABI or send your patients for an ABI? So that's pretty good. That's pretty good. You can do it in your clinic. It takes a bit of time, so about 15 minutes with a handheld Doppler. And different centers have different protocols. So at ours, we could send them for a vascular ultrasound plus ABI, or we could send them for segmental Doppler pressures, pulse volume recording, which is like an in-depth ABI. So know what's available to you locally, but the ABI is quite informative, and certainly in vascular medicine and vascular surgery, it's one of our bread and butter tests like blood pressure. And after Dr. Siegel's presentation, you know that bleeding is really important for us to focus on. And when we looked at the data, you'll see that there's an increased risk of major bleeding when we initiate dual pathway inhibition compared to aspirin alone. And the hazard ratio is 1.7-fold. But when you drill down into the types of bleeding, unlike the WAVE trial, we did not observe any excess in bleeding causing death, intracranial bleeding, or critical organ bleeds. So most of these are what we call treatable bleeds, and 2/3 of the major bleeds in the COMPASS trial were GI bleeds. So you may have seen a follow-up paper from John Eichelboom from the COMPASS data showing that, sometimes people could say, initiate the dual pathway inhibition. If your patient has a GI or GU bleed, it's almost like a bleeding stress test to intensify your antithrombotic therapy, because that manifestation of bleeding then has led people to do endoscopy, cystoscopy, and often can lead to an early diagnosis of GI or GU cancers. So again, try and think of your patients from the perspective of their past history of bleeding. Would they have even made it into the trials? And then if you think their ischemic risk is such that you should initiate dual pathway inhibition, there is a risk, an increased risk of major bleeding. We did observe if a patient bleeds, they typically bleed in the first year. If they make it through the first year on dual pathway inhibition, the risk of bleeding thereafter is quite low. So that when we put that all into a net clinical benefit calculation, we see that the net clinical benefit of dual pathway inhibition increases over time. Especially if you get past that first year without any bleeding, you're going to see increased net clinical benefit. And I will mention in the COMPASS trial, there was a mortality reduction, which is the ultimate measure of net clinical benefit. Now, when we looked at the consistency of that 31% relative risk reduction with dual pathway inhibition in the PAD group in COMPASS, and then subdivide the PAD patients into the type of PAD, we included this in our main paper, and you can see that risk reduction is absolutely consistent across all of these types of patients. So, sometimes people say, well, what about your carotid patients or your symptomatic PAD of the lower extremity, et cetera? You can see just by the point estimate, it's completely consistent. If confidence intervals are a little wide, it's because we had, fewer numbers of patients in those groups, but really consistent. And I think this should be reassuring to you. Now, I mentioned that patients with acute limb ischemia are high risk, and we observed that dual pathway inhibition reduces acute limb ischemia. So that's a good thing. This is just to show you within the COMPASS trial, if patients did develop acute limb ischemia, what their prognosis was thereafter. And you can see that here there's a 200-fold increase in future major amputation for patients who had acute limb ischemia. And most of that occurs in the first year. So it's, again, making the point that we should try and prevent acute limb ischemia. If a patient does get acute limb ischemia, you can see their prognosis. This is for amputation, but I could show you a 3-fold increase in mortality as well. Now, we sub-analyzed all of those patients in COMPASS who had acute limb ischemia and said, was there a difference in prognosis after acute limb ischemia, whether they were on aspirin or dual platelet inhibition? And although the numbers are relatively small, we're talking about 150 acute limb ischemia cases. You can see that patients who were on Riva and aspirin, the dual pathway inhibition, had a much better prognosis than patients who are on aspirin alone. And, we're just hypothesizing here, but perhaps those patients on dual pathway inhibition who had acute limb ischemia had a smaller arterial thrombus burden and maybe a better prognosis on that basis. So it prevents ALI, and your prognosis is better after ALI if you're on dual pathway inhibition. Now, this is the Voyager trial. And the Voyager trial, as I mentioned, these patients, about 6,500 patients, underwent infrainguinal revascularization. And once hemostasis was obtained, patients could be randomized to receive dual pathway inhibition or aspirin. And we left it up to the treating physician to decide if they wanted to use clopidogrel. So you can imagine patients going for endovascular intervention, where there was angioplasty, a stent, a drug-eluting balloon of the peripheral artery. Many of those procedures, the package insert for those stents and balloons say patients should also be on clopidogrel. So there's not a lot of evidence to say they must be on it. We left it up to the physician, and then we did a stratified analysis by patients who were on clopidogrel versus those who weren't. This shows the overall result. In general, there was about a 15 to 20% risk reduction in what we call the 5-point composite. It's very similar to the COMPASS MACE or MALE. It includes cardiovascular death, MI, ischemic stroke, and acute limb ischemia amputation. Here again, very consistent data in support of the Riva aspirin. When we look in the Voyager trial at the risk benefit over time, and I mentioned net clinical benefit from COMPASS, we see the same thing. We see in the first year, the red line would suggest a higher incidence of bleeding in year 1 and thereafter a plateau with the red line versus the continued ischemic benefit over time. You can see that continues to accrue. So again, in Voyager, we see net clinical benefit increases over time. When we put the trials side by side, I mentioned the differences in the types of patient population, but then again, the consistency of the treatment benefit. And I'll show an additional benefit is within or difference within COMPASS. We had about 65% of patients with concomitant coronary artery disease. In Voyager, it was around 30%. And with respect to critical limb ischemia, there was much more critical limb ischemia in the Voyager trial compared to COMPASS. We recently meta-analyzed COMPASS and Voyager together, this demonstrated what I've said repeatedly throughout this morning's talk, that the results are very consistent. So this is for the ischemic events put all together with both trials. And you can see here that there's about a 20% risk reduction for the MACE male composite across the trials. This is very reassuring. Having now 2 large trials, COMPASS with about 7,500 PAD patients, Voyager with about 6,500 patients, that we're seeing the consistency in the treatment benefit. So you'll see now in the emerging guidelines that the dual pathway inhibition in patients with PAD will get either a class 1A or 2A recommendation because we now have 2 trials. When we looked at acute limb ischemia, again, consistency in the benefit for dual pathway inhibition compared to aspirin alone. And this risk reduction is even greater. So, you know, it all depends at what your specialty is and what you're really focused on preventing. In vascular medicine, vascular surgery, like this is a huge treatment reduction with DPI. With the MACE reduction, you might say, well, 15 to 20% reduction we see with other antithrombotic therapies, such as dual antiplatelet therapy. But when we think of the whole patient, we're reducing MACE and MALE significantly for them. So this should give you or empower you to have these discussions with your colleagues. We do observe that some cardiologists are really passionate about dual antiplatelet therapy. It could be aspirin Plavix, it could be aspirin ticagrelor from the Pegasus trial in the post-MI setting. I like to remind them that in Pegasus, there was not a mortality reduction. In COMPASS, there was. And certainly when we think about polyvascular disease and the COMPASS trial, we're seeing overall reduction in mortality. We're seeing reduction in MACE and MALE. You can make a very strong argument in favor of DPI over dual antiplatelet therapy with your cardiology colleagues. The only tricky time would be if a patient has just undergone a drug-eluting stent and the cardiologist deems it's very high risk for restenosis, then you could, say, okay, for 1 year, we'll go with dual antiplatelet and then switch them over to dual pathway inhibition. We did a sub-analysis in the COMPASS trial to try and identify the highest risk patients, or In other words, the low hanging fruit for us to, decide to treat without too much deliberation. And as I mentioned before, in all of our analyses, the polyvascular patients come out as the highest risk patients, and they're described as 2 or more vascular beds affected. And if we look at the number of events prevented per 1,000 patients treated, or in other words, the absolute risk reduction, you'll see the absolute risk reduction in the polyvascular patients is 6%. So that's very favorable. If you look at other risk features, patients with a history of heart failure, patients with a history of diabetes, patients with renal insufficiency, they are the highest risk vascular patients. And so you can, again, by often historical features, categorize patients as a high-risk patient, one that you'll treat with more than a single antiplatelet agent. Eric Kaplovich, who I'm not sure if he's here today, but he's done a further analyses in our PAD lower extremity patients, and we observed the same thing, that we can risk stratify patients based on some clinical characteristics that I just described, but also some peripheral artery characteristics. And we see our patients who have the highest incidence risk of future major adverse limb event are those patients with prior limb amputation, those patients who have prior limb revascularization, and any kind of more advanced PAD history than simple claudication. So all this to be said, when you're trying to decide amongst your PAD patients who should get dual pathway inhibition, if they have polyvascular disease, if they have diabetes, heart failure, or renal insufficiency, or from a limb perspective, previous history of vascular surgery or amputation, they all should get dual pathway inhibition. It's only the patient with mild intermittent claudication without any of those medical comorbidities where I might debate to say they're going to be fine on a single antiplatelet agent. So in my mind, it's pretty straightforward. We've got great data to direct our care. The majority of patients that you may see in hospital would likely fit into the dual pathway inhibition category. It's just that mild intermittent claudicant without diabetes, without prior vascular surgery or amputation, where you might say they're fine on a single antiplatelet agent. This goes on to give the absolute risk reductions in favor of that approach. And you can see in the far right, those bars demonstrate the lower risk for a patient who has PAD and none of those other high-risk features. And that's the group where the single antiplatelet may be just fine. We recently did a survey of our Canadian colleagues. Some of you may have completed the survey, so we appreciate that. We included specialists who may make antithrombotic decisions for patients with PAD. And we asked them, which agents do you choose? And this is kind of just after the COMPASS trial results and before Voyager. And all that to be said, we did observe a great deal of heterogeneity with respect to antithrombotic choices. Sometimes it's left to the vascular surgeon. Sometimes it's cardiology. Sometimes it's thrombo or heme. Sometimes it's general internal medicine. So we have a wide variety of specialists seeing our patients, and then a wide treatment range of choices all the way from single antiplatelet to full dose anticoagulants with warfarin. So there's a lot of heterogeneity. It's our hope now with the COMPASS and Voyager trial and the fact that they're being integrated into guidelines that this heterogeneity will be reduced. There is one area where we still need more evidence ripe for a randomized trial, which is the management of acute limb ischemia. So the patient who is admitted with acute limb ischemia, often they would be put on IV heparin after the surgery and thrombosis would be consulted. Those patients were not enrolled in either COMPASS or Voyager. We don't really know what to do, and we need a trial. But there you have a few options. Sometimes a surgeon comes out and says this patient needs to go on warfarin. I said that with a male voice. I could say it, with a higher pitched voice. This patient needs to go. But we often say like, why did you ask us to see the patient? But in the discussion with the surgeon, they have reasons that are not available to us because they're not charted and the dictated notes are not out. But their reasons are if they have they see a huge thrombosis burden and they're fishing out a large arterial clot, that might be a reason. Or if they're worried that the person has what's called single vessel runoff, so that's a arterial conduit below the knee, typically one, those patients are high risk. And if we treat them or undertreat them and they thrombose that single conduit, they're getting an amputation. So surgeons have reasons. If you can find them and have a conversation, that's really helpful. And so some of those patients post-acute limb ischemia go on warfarin, sometimes warfarin and aspirin, but what we arrange is a very close follow-up of those patients. We'll see them at 3 and 6 months and decide at some point, can we transition them to the Compass regimen? So acute limb ischemia patients are high risk. There's not a lot of evidence from an antithrombotic perspective. Best to have a good conversation with the surgeon. Warfarin aspirin's okay for short term, and then try and transition them to either DAPT or the dual pathway inhibition. We are involved in a prospective registry called ZATOA, funded by Bayer. It is an international registry, and essentially this will inform us which patients in the real world are being treated with dual pathway inhibition and what are their outcomes. And it's interesting worldwide, and even when you talk to pharma, they'll tell you the main reason that dual pathway inhibition is being used is for patients with PAD. The greatest uptake is with PAD patients. And when we look at the ZATOA registry compared to the Compass trial, you'll see the ZATOA is the name of the registry, we have a substantial proportion of the patients in the registry with either PAD alone, 27%, or CAD plus PAD, 31%. So over 50% of the patients in the registry have PAD. And when we look at the types of PAD, you can see them there. The majority are PAD of the lower extremity. And the second most common would be carotid artery disease as the indication. And we've published one paper with Professor Fox as the first author. And it's very interesting that our observations are the bleeding risks observed in the registry are lower than what we've reported in the trial. So that's something for us to watch. Of course, there's some selection of patients into a registry, but it's not the opposite, which would be more concerning, I think, if we thought, well, the trials were too good to be true and there's a much more bleeding in the real world practice. We're not observing that in ZATOA. So just to wrap up, I hope I can leave you with more, I guess, a deeper understanding of PAD patients. They are high risk. When they have polyvascular disease, they are the highest risk group. We've learned from the WAVE trial that oral anticoagulants such as warfarin have a very limited role in patients with PAD. It's really for those patients who are at high risk of thrombosing their arterial conduit that could then lead to an amputation. Single antiplatelet therapy, there is a role for it. Usually patients who have mild PAD, such as mild intermittent claudication. The dual antiplatelet therapy has a role, certainly for patients who do have contraindications to the low-dose riva-aspirin combination. DAPT, again, extrapolated from, say, the Pegasus trial, has shown some benefit for PAD. But we're really excited in PAD now because we have an option. Before we had aspirin only, then warfarin didn't work out. We went back to aspirin or clopidogrel. Now we have a real option that prevents both MACE and MALE. And I hope that the patients that were enrolled into Compass, plus those other high-risk features, will stick in your mind as the patients you should consider to treat. And we're also excited that this past year we published the Canadian Cardiovascular Society PAD guidelines. And I think Eric led the antithrombotic sections. And you will see the Compass and Voyager results have led to high quality evidence, strong recommendation for this treatment in patients with PAD. And this neat graphic is being put together by CCS, which we're trying to come up with acronyms that people will remember, such as SAVE LIM. And each one of those letters stands for something important. And you'll see more of this year. You'll see more of this in Vascular 2023. So I encourage you all to be enthusiastic and attend this next October in Montreal. We will have all the different societies have their regular meeting, but one common day on the Friday, I think October 28th or so, where we all attend the same meetings. And we're trying to choose scientific sessions that will appeal to everyone from diabetes to thrombosis. So I look forward to seeing you there, and thank you very much.
Thank you so much, Dr. Anand. We are out of time, so I'm going to have to hold the questions. Again, please email Holly at thrombosiscanada.ca, and then we can hopefully get Dr. Anand to answer the questions. We will probably do a 10-minute break. I know we're running behind, but try to come here at 10:53, and we'll be very good about staying on time. Thank you, everyone.
Okay, so we're going to kick off this next portion of today's meeting. I'd like to welcome Dr. Lee to give us a talk on optimizing thrombosis care, themes from CMPA cases. Dr. Lee completed her medical degree at Western University, as well as family and emergency medicine certification at the University of Ottawa. She completed a master's degree in health science education at the University of Toronto, as well as physician leadership development certificate program with the Schulich School of Business. Prior to joining the CMPA, she was the director of education at the Schwartz-Reisman Emergency Center at Mount Sinai Hospital. While at the University of Toronto, Dr. Lee served as a director for the SCME Supplemental Emergency Medicine Experience Fellowship, a CPD program created to enhance comprehensive primary care delivery in rural and smaller communities. Nationally, she has served with organizations including the College of Family Physicians of Canada, the Royal College of Physicians and Surgeons of Canada. She's been the recipient of a number of awards in recognition for her longstanding contributions to medicine and teaching. Dr. Lee continues to practice emergency medicine at the Ottawa Hospital. Thank you for joining us today. We're very excited to hear this talk.
Much for that. All right, I'm hoping everyone can hear me. I also suffer from the same tracheitis that some of our earlier speakers had. So I've got my lozenges and water. I've been expecting a really fun next hour. I know you guys don't think that when you think CMPA, terror strikes in people's hearts, but I'm very happy to be here. And certainly I'm very happy to hear some of the conversations that were happening this morning. As an emergency physician who faces those life-threatening GI bleeds going out both ends, epistaxis where someone has a myocardial infarction because they're bleeding so badly on their NOACs or DOACs. You know, these things are really important what we're doing here today. So optimizing thrombosis care, themes from CMP cases. I do want to thank our committee chairs here today, Dr. Kulia and Dr. Shivji. We started talking about this 9 months ago. So like this is the birth of the conference, and we had in-depth conversations about what would be most meaningful for this audience to share with you today. Now, you've had lots of data this morning, so many studies, so many acronyms, right? And you're hearing there's a lot of gray zone, right? And how do we navigate this as physicians who are trying to do the best we can for patients? So let's talk a bit about that. So my disclosure is I have no conflicts of interest, except that I am an employee with the Canadian Medical Protective Association as a full-time educator with their Safe Medical Care Learning branch. And really, before I get into my objectives today, I just want to do a quick survey. Okay, and I'm going to ask the question, how worried are you or concerned about receiving a complaint or legal action? I want to know who is super worried, okay, moderately worried, not worried at all, or I don't know. Okay, all right, well, I'm here to reassure you actually, when I looked at our CMP data, so we have an extensive research department, that the number of medical legal cases in Canada related to thrombosis disease is actually quite low. Okay, that's the end of my talk. No. But however, there are significant patient safety issues, which although you may not arise into a complaint or a legal action, do require a significant issues with regards to the doctor-patient relationship, to things to do with how we actually communicate with our patients and how we want to actually mitigate risk and prevent bad outcomes. So I'm going to identify some common medical legal themes that we do see in thrombosis management cases based on our Canadian data. We're going to describe best practices to support safe medical care. And I'm hoping, because a lot of information has gone by this morning, that you'll commit to one change in your practice today to improve patient safety and decrease your medical legal risk. Now, these are sort of the top categories. I'm not going to tell you the percentages that we see in our legal files with regards to complaint or legal action. And really, the reason we have this data is to look for themes or potential gaps where we can actually do some knowledge translation or patient safety work across Canada. So we speak across Canada to 105,000 physicians. We receive on average 24,000 calls a year for advice. So everyone uses us. Roughly 250 calls a day come in from physicians across Canada. We have a pretty good idea of what's going on in the country. So the four top issues that I can identify with regards to thrombosis cases that we've seen, the first one is inadequate clinical assessment. And what do I mean by that? So that's everything from not taking a fulsome history, not considering significant risk factors that might put that patient at risk of either significant bleeding or VTE, right? It's either clot or bleeding. And with regards to the diagnostic issues, not ordering a specific test and not following up with that patient with regards to those issues that may occur with them. Some of the consent issues is really huge. I know we all think we do a great job at consent. In fact, whenever we survey physician audience, they're like, I'm great at consent. I've got this down pat. Yet it is almost one of the number one reasons patients do actually raise concerns or complain. So my job here today is to press those edges out for you for one or two things you can do different with consent to ensure actually that the patient is understanding and accepting what you're advising and understands those issues that come up all the time around consent. Even though you think, I just spent an hour talking to them. And they're like, no, you didn't. You tell me any of that stuff. This happened. And anyways, we'll get into it. Test results follow-up. Big area, right? We heard it this time over and over this morning with regards to the importance of starting and stopping, right? Our patients are older, they're on anticoagulants, they need to go for surgery often. When do we restart them? When do we start these things and how do we follow them up? And the last one is communication breakdown. We see that in two areas related to doctor-patient relationship themselves with the patient or their family members because of capacity issues. Also between physicians though too, where you didn't tell me they were on that product and then some catastrophic outcome occurred or they were stopped and had a significant event. So again, those communication breakdowns do come into play and really important sometimes for us, if you think people are going to act on your advice, that you have some documentation to support what you were shared about the concern and what you advised them at that time. All right, so when we do though have a case involving a thrombosis issue, more than 2/3 of those cases have an unfavorable medical legal outcome for physicians. In fact, it's quite high. It's about 85%. I said 2/3 because I didn't want to scare you, but and why is it that we don't do so well, when these do come to legal action? And it's not that your care was bad, okay? But the evidence is not there to support your rationale for why you advised the things you did and your patient's understanding. And a lot of this boils down to when we look at the data, we look at North American data, we have the largest medical legal data repository actually in the world because we have about 95% of physicians here in the country that we support. Only 4% of those medical legal suits are actually due to adverse events. The rest are due to all the other things that can happen that make patients actually upset. And so why is it they do that? So I'm going to talk about informed consent. Oh my goodness, so many new guidelines. We're not sure. I mean, it's hard enough for me to keep on top of these things, right? And the latest DOAC going on and, showing these to patients about, hey, which one do you want? And it can be very challenging. So a couple of things to think about with informed consent. Okay. And this is a typical patient that I would see. I had to kind of chuckle this morning, said, this is 70-year-old Mr. Gus. He's got hypertension. He's got a little bit of high cholesterol. He's borderline diabetic. He has a mild CKD. Like this is my regular person I see in the merge all the time. And he's come in because he's not feeling well, feeling tired for a week, feeling kind of like he has no energy. And you happen to actually examine him because it wasn't a virtual consult. And you see that he has an irregular pulse. So you decide, okay, I'm going to get ECG done. And you can tell that he's feeling lightheaded. He has no chest pain or no palpitations at all. And of course, his ECG shows he has AFib, right? Just like our case this morning. And we see lots of people with AFib, but they're not just Mr. Gus. They're getting younger and younger, right? We're seeing it in super athlete, triathlon people in their 40s. AFib is really common. And how do we manage it properly, depending on where they're at in the spectrum of disease? So knowing that this guy has atrial fibrillation now, and he's probably had it for a week. We have no idea. Really, what would you do next, right? How would you actually move forward with this patient based on the things we talked about this morning, right? There's a couple of different choices. So what do we need to consider, right? And some important points came up with all the talks this morning to kind of think about. Now, when we look at our informed consent cases, we actually did a 10-year retrospective analysis of all CNP cases where informed consent was a significant issue. We had roughly, I'm going to say 900 plus cases. And of those cases, what was really interesting about the informed consent issue in these medical legal files is about 40% of them involved medication, right? So prescribing medication where the medication has a significant risk. And in this category, of course, it's bleeding, or if you stop it, clotting, right? And we see this in our pregnant patients. I used to work at Sinai, which is a very coordinary care hospital for pregnancy patients, and they all had thrombotic disease. It was a nightmare trying to manage them. You have to know your patients in the context and what information is available to them. So knowing that 40% of the time there's a medication issue that actually causes an issue with informed consent, let's move forward. You're probably wondering what the other 60% were, is the surgeons. The female surgeons and the male surgeons. And usually for them, it's actually premature discharge, where they do not start someone on something and they have a risk of VTE, or the patient doesn't understand and stops it too early. All right. So we look at the 3 elements of informed consent. So when the courts look at your informed consent, okay, patient alleges that, I didn't know that DOAC was so bad and it gave me that major GI bleed or whatever, okay? There's 3 things they want to know. Obviously, you're going to share information with the patient. We're pretty good at that. But how do you share that information? Is it just verbal? Are there other modalities that you use? This is a complicated drug. You have to consider the comorbidities. So how do you actually share that information so that they can retain it, understand it, and actually action it appropriately? You have to assess capacity. And I think that's a really important issue. Most of physicians I talk to in this audience, I've spoken to many that do long-term care or geriatrics or have a much older patient profile. Again, it's really important to assess capacity. And that's, particularly with our patients who have cognitive decline, who are often on these medications. If they have no capacity to understand the drug and its potential risks and consequences, you may need to actually get a substitute decision maker, find out who their POA is for health. But capacity, and I actually document is, has capacity to understand the risks and benefits related to this medication. And ensure that the patient agrees or is voluntary. So I've been doing medicine for a while. Heading towards 30 years. But in the old days, we would actually threaten patients, right? If you don't take this medication, you could die, right? And okay, that works. But then if they have a bad complication, they complain and say the doctor didn't give me an alternative, which is not to take it. Right. And so you have to ensure the patient does volunteer. So when your patient says, after your long discussion about DOAC, they're like, oh, I'll take it then. Take that as a physical signal that you should need to pause and slow down. Because you rush through and do your spiel, because I've said this 30 times a day. It's my normal thing I say. You're going to have a patient that's not satisfied and likely not going to be compliant, and adherence is an issue. So read their body language and pause. Informed consent is one of those things that may take you more than one visit to do with the patient. So what would a reasonable patient or family want to know is the standard that physicians are held to with regards to informed consent. This was actually up to about 1980. It was what a reasonable physician would want to share. And unfortunately, there was a couple of Supreme Court cases of really bad outcomes related to clot disorders that actually changed that ruling to what would a reasonable patient or family want to know. And the key word here is reasonable. So it does not mean you have to rhyme every major complication, but what would a reasonable patient in these circumstances want to know about? And these are common things we talk about every day with our patients. So a couple of things they're looking for in informed consent. from a court's perspective that would be reasonable. One is, what's the diagnosis? They have had several studies. It's so interesting. I mean, we're just dealing with thrombosis, but they've actually had clinic studies where patients were complex, were told their diagnosis. And when they left the clinic, they're asked by a researcher, so what's your diagnosis? And about just under 50% didn't know their diagnosis. All right. So make sure they have some understanding of what their diagnosis is or what you're thinking of. In my line of work, I'm often saying and writing for my diagnosis, abdominal pain NYD, headache NYD, chest pain NYD, because it's too early in the course of disease. And I've ruled out the life-threatening stuff. Drives our lawyers crazy. They really were nervous when I told them, oh yeah, I do that every day. They're like, oh. What's the proposed treatment? And this is where you got to slow down, right? So we talked about you might pick warfarin, you might pick a DOAC. I've seen patients pick warfarin because they can't afford a DOAC, or you might do nothing at all, right? So what are the options for that patient? What are the chances of success? This is a bit of a sticky one because there's studies ongoing, right? And sometimes we don't know what the chance of success is, but this is our best, recommendation based on the evidence, right? But patients might ask you that. And I generally recommend national groups, because I speak to a lot of different subspecialties, that if your national consensus group has some guidelines with regards to the chances of success, use those. Because that was where you'll be judged, not so much on perhaps our American data, but particularly if there's a Canadian guideline about risk benefits, use those handouts. So I'm so glad that you're creating these things on the website. What are the risks, material and special? And I'm going to get a bit more into that. What were the alternatives? And what's the consequence of not treating? All right, so some of you may be familiar with this one. This is a nice, quick mnemonic when you're thinking, okay, did I go through all the things I need to? It's called PAR-Q. It was actually created by the government of Oregon. They had so many issues with informed consent cases in that state. They actually created this state guideline, and it's actually been used quite widely in North America. I like it because it's simple, right? So I always think about the procedure or whatever I'm going to be recommending for a patient. What are the alternatives? Again, doing nothing or other medications. What are the risks for that patient, both material and special? And what I mean by that, material would be your usual thing. I'm starting you on a blood thinner. There's a risk of bleeding. Might have to watch your kidney function, et cetera, et cetera. The special risks may be related to that patient, particularly the diabetic patients, or the patient already has comorbidities, has already had one stroke, right? And you're really trying to manage this kind of tight spot that they're in with regards to keeping them safe. But special risk definitely would be related to things specific for that patient's condition. And any questions they have. Where physicians often get faulted or criticized with informed consent is with the A and the Q, right? And so the patient will say, I was never offered an alternative. I wasn't given any time to think about it. I was pressured into starting this medication, and they didn't answer my questions. You have to be careful how you ask, do you have any questions, right? They know we're busy. They can see you're stressed out, you're on your 8th cup of coffee, you've been running your field all day. That was me last weekend. I worked the casino shift and I got home at 6 a.m. It's like, oh, but it's really important that not ask your questions in a way that are open-ended, right? And so patients will say, they've done studies on this, where if you say, is there anything else? And patients answer binary, yes, no. Most of them go, no, because the consult was long enough and they're scared. But if you say something like, I'm sure that I've just given you a lot of information. I'm sure you must have some questions. What else do I need to share with you? Or what else have you not had a chance to share with me? Way more open-ended. And what was really interesting, I think I can't afford that 5 extra minutes in my consult. But what was really interesting is that that's the doorknob question, right? You're trying to leave and they go, oh, by the way, you're like, oh, I wish they'd mentioned that first. Dealing with those what else increases that patient's trust in you, increases their adherence. It may be related to the work. Like maybe they like to do bungee jumping on the side and oh, maybe I gotta not have you on this stuff. And then writing that or documenting that, with regards to their questions, yeah, I'm going to give you a note off work or whatever, is really, really helpful in the court's eyes and perspectives that you actually personalized that informed consent and that it was a fulsome informed consent. It wasn't cookie cutter, like cut and paste, because it's the same thing I do 10 times a day. So courts really take that very seriously when they see that patient had a question regarding X, Y, Z. I recommended the following. So make sure to add a little bit of personalization if you can, because it goes a long, long way to actually demonstrating that I did spend the time consulting with this patient. So personalize that note. Other things I like to think about when I do a informed consent is I will often write about shared decision-making. My acronym, I wrote SDM, although people might think that's Shoppers Drug Mart. But shared decision-making, patient decline following medication for this reason, understands that they're at increased risk of thrombosis, wishes to speak to their OBGYN first before blah, 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 blah. So I actually will write that on the chart, right? Understands that, so that if particularly when patients may choose an option that you don't think is as favorable or might put them at risk. So for me, often it's like not ordering abdo-CTs in young females because they're at childbearing years, and that they understand the risk and understand what flags to look at to come back for further reassessment. This is one informed consent checklist to think about. There's many out there, but really I just want to draw your attention to the two parts. The top part is really about the regular things we do with an informed consent, right? That we talked about in Part Q. The second half, though, is that PCC or patient-centered communication, right? And that's the part actually where patients often will raise concerns, okay? So do you check for patient understanding? And what I mean by that is our patients know that we're busy, okay? They know that very well. And patients want to please us. They're so desperately just happy to have a doctor. They've waited so long to be seen. And what I'll share with you is sometimes patients too don't want to show they don't understand. All right, I'll give you an example. I spent an hour on a consultation with my mother. I was there to support her, and she's been Canada for 35 years. She's like, yes, yes. And she's like, oh, yes, yes. Doctors explaining everything carefully and thoroughly. It was like a pretty long consult. And Dr. leaves, and she's agreed. She signed. She turns to me and goes, okay, what did the doctor say? I'm like, oh my gosh. I just was blown away that my mother, who I thought understood English really well, said yes the whole time, had no clue what she just signed for, And so patients don't always want to show they might not understand. Okay, I'll give you a like-winded, something that makes you think about. It's sort of like when we see our accountants, and you know how they show you 10,000 pages. Like my accountant's doing that right now with me. And I'm like, oh yeah. And I sign 10,000 places. And then my husband asked me, so what did the accountant say? I'm like, I don't know. Pretty good. We did okay on taxes this year. It's the same thing. Or seeing your mechanic, right? We do it. So how do you expect otherwise when we're loading people with so much information? So check for understanding. Okay, what's your understanding of what's going on? Big things, right? Do you explain the patient's concerns and expectations? Expectation management, they should teach this in med school. It's one of the first things I do when I see a patient, besides introducing myself and establishing trust, is managing expectations. My standard Friday night is, I've had back pain for a week. I want an MRI, and so managing those expectations is really important, with regards to, the goals of care today would not be an MRI, but to manage your pain so that you're able to be functional and working. I said, if I see something of concern that would indicate by standard guidelines in MRI, then we'll do that. Manage them up front, right? Inviting those questions in a way that actually looks like you're inviting them. Nothing makes me laugh more when I observe other physicians in the emergency department saying, any questions? He's just like, no. Or they're staying there like this, and they're ready to run off. Okay. Do you pace your information appropriately and avoid medical jargon, right? Health literacy is a huge issue. In fact, it's pretty much a cultural humility or what we call cultural competency issue. We assume people have a certain level, but again, checking to make sure that there are terms we're not using that people don't understand. And the last one's probably the hardest one, because it's hard, you can't teach this, right? Are you empathetic and respectful for the patient's choices, particularly when you don't agree, right? And some people can really push our buttons. There's no doubt about it. We have those patients every day, but they do get to have a choice. All right. So when you verify what the patient understands, okay, these are a couple of things to think about, right? I'll ask them, what's the best case, worst case scenario? And you might think, oh my God, if I tell them the worst case scenario, they won't go on medication. However, hiding that information from them and then they have the complication, or don't worry about it. is really bad answer, right? So what are your concerns? And what are you expecting from this treatment? What are you hoping for? What are your goals of care? Well, I'm hoping I don't have a stroke. Okay. But it might be a risk of bleeding, like 30%. What are the risks for you? And their idea of risk may be very different than yours, because they'll tell you about their neighbor and what happened when they went on that medication all the time. What are the limitations, right? This is not some super drug. It's not kryptonite. You still might actually end up having a clot despite being on this. Like, you know, if you don't modify your risk factors, you smoke like a chimney, you know, and your hypertension's through the roof, right? Again, what are limitations of medications in a kind way, of course. And the fourth one we add, but like I said, I know some of you say, ugh, if I ask that, that's an unlocking Pandora's box. But sometimes when patients are in that really difficult decision spot, they got bad kidney disease, heart failure, diabetes, you know, are you prepared for, you know, what might go wrong, particularly if they're going into a major surgery for cancer or something and you're stopping their DOAC, you know. Again, having those conversations just shows that you care. And sometimes they have to think about it a bit more. But, oh, okay, the monitor's showing me something. I'm going to, hopefully it's not going to turn off. Okay. But again, it actually allows for a more fulsome discussion that they will appreciate, and they will actually come back to you despite if something bad does happen, because they trust that you have their best interest at heart. So capacity, there's lots of ways to define capacity. And it's not just our elderly patients, right? We have patients who have significant, he's coming up. Am I going to be okay? That's the IT guy. So he means this is going to still work. You know, patients who have a delayed development, patients who have mental health issues, right? So you have to really check on that capacity with regards to, do they understand the nature and appreciate those consequences of that particular decision that you're suggesting? It's only to that decision. So sometimes patients may have fluctuating capacity. Okay. What's important is I often ask the patient to do a teach back or read back. So I actually put RBTB check. That's my common thing when I discharge people. I say, what's your understanding of what we just talked about? And they'll be like, well, you told me that I could bleed and blah, blah, blah. And, you know, I need to get with my family doctor. And so then I know they actually understood. And that is my verifying understanding. If I'm not sure they really get it, like, whatever you say, doc, whatever you want. And you're like, they just want to get out of here, you know, or I'm concerned they don't actually understand it. I might get a second opinion. I might actually use ACE or another capacity assessment tool. This one I recommend is just from Toronto, but there's many of them. And often when I worked in Toronto, where there's over 130 different languages, I often had to have a translator or interpreter of some kind that hopefully wasn't a family member. You know, you've all been there. Are you having chest pain? Yeah, no. And you're like, that is not what just happened. Okay. Like, how do I have any idea? They translated what, you know, and the translator is 11 years old, you know, it's like not good. All right. You know, like I'm standing there and wonder, right? Yeah. All right. So informed consent, right? We talked about patients and families are entitled to know those material risks of proposed treatment. This is from our you know, Supreme Court of Canada. Those frequent complications and the serious ones. And I give this enough time to people, I can't tell them they're going to die. No one's ever going to, you know, who's going to want to see me? But if it is a significant potential outcome, you kind of need to let them know. It's a rare outcome, but one of the things that could happen by you not taking this medication, you know, is a very serious complication, including death, you know. Special unusual risks we talked about. And uninsured services, this comes up a fair bit when they want you to sign those special release forms. It'll be interesting to see how long it takes Health Canada to approve this new medication. I do know people who work on the inside that are physicians that approve this stuff. And again, it's important to document why the patient makes those choices. Like I said, the one I've seen really is about costs related to the DOACs versus warfarin. So when you talk about consent, you want to keep it broad, right? And this is about having a structure that you apply over and over again, some standardization how you do your consent procedure. But you need to be specific with especially that A and Q that I talked about. And that really a signature is not enough, right? We often don't do like, you know, we get the hospital form if it's like an LP or anything else. But let's say you're doing LP on someone who's on a DOAC, which I do more often than you don't think, you know, and epidural hematoma and things I think about. You need to actually document that consent and that fulsome discussion. That hospital policy paper doesn't mean anything. in the courts. Okay, it's just you following hospital procedure. Some documentation tips with informed consent, right? I'm really clear about, if you just said risks and benefits discussed, doesn't really cut it. I'm gonna be honest with you. I say discuss risks and benefits alternatives with emphasis on A, B, C, and D, right? I'll be very specific. Address those questions and concerns. I reviewed the handout from Thrombosis Canada website, right? And I know some people who actually hand it to the patient and they stamp patient's copy and they keep one in their own file. I mean, it depends if you're an EMR or whatever, but if you're doing paper, there are ways to say, yeah, that was the hand I gave them. And here's my copy and my thing that I reviewed. And I actually have check marks to have them review every part. Or, you know, there's different ways you can actually streamline your process. Oh, here. Okay. Yeah, we talked about the read back. If you draw diagrams, right? A lot of people are visual learners, or you use mnemonics, right? Keep those in your chart. Again, demonstrates that you're having that fulsome discussion of communication. I always document when I have a translator present and who it is, okay? And the level of proficiency I think the patient has. Because I know that affects how good my history and physical will be, as well as their understanding of the device. But I don't see it as a thing I should make patients feel ashamed of. I think we have to be respectful to meet them where they're at. Who else was there? Sometimes there's a nurse or the translation service. We have this cool machine now I use at the Ottawa Hospital for translation. It's quite funny. The one I used here in Toronto was AT&T. It was a 3-way dial, and anyways, fun. How do you confirm the patient's understanding, those handouts and the diagrams? All right. Because you're like, I have 10 minutes for this appointment. There's no way I can do all this that you just talked about. And, you know, sometimes if you have the luxury time, you give them some information, have them go, and then come back, right? You know, and don't try to rush this. This is actually one of those times with a medication that has potentially high risk that you want to slow it down and make sure that you have those discussions and document it well. I'm going to pause there. How much time do I have? Do I have time? Okay, I'm going to talk a little about virtual care. And I'm sorry I'm flipping between topics because we talked for a long time, all the great things we could talk about today. And I'm hoping to have enough time for questions. So I want you to stop me cold stop at 10 more minutes. Okay, got it. We're on speed dial. So virtual care. This is probably one of the biggest changes we've seen in the last 3 years in the landscape of how we deliver healthcare in Canada. And there's a couple of issues I just really want to hit highlights on. I'm curious to know how many people here do virtual care with their patients. Put a hands up. Yeah, right. And we wouldn't have even considered this 4 years ago, right? And by the way, telephone calls to your patients is considered virtual care. All right. So a couple of issues to think about when we look at virtual care. It's here to stay, right? So we want to get it right. I'm going to talk about these issues and just highlight a few things. Hopefully, most of you have had a chance to look at the virtual care playbook. It's excellent. It's endorsed by both professional colleges that we have, as well as the CMA. It's only about 14 pages. It's a quick read. I would highly recommend if you want to look at standards in Canada nationally, this is a good place to start. As I mentioned, consent. I talked a lot about consent. Consent for virtual care has its own sort of nuances as well. When you're actually communicating electronically or using an encrypted portal or using the phone, you do have to discuss the limits of using that technology because patients think they're exactly the same, as though you were seeing them in person, right? You know, and you don't happen like, you know, when you only see patients from this high up, you can't see their big swollen leg, right? So again, the scopes with regards to the limits of this technology, and I also warn patients, you may be advised that you need to come for a face-to-face. Because you run these lines, I don't want to come in. And you're like, no, I'm really worried about you. You need to go like to your nearest emerge. And the privacy issues, right? You know, how many times have you called a patient, you can hear they're at the hairdressers or the grocery store, like these, you know, they're talking about personal health information, or they have their kids around. Again, you need to make sure that they're in a private location. So checking on that. We need to protect patients' privacy. So that also goes from our end. If you're going to do virtual care from home, make sure you have a room with the door that's closed. Don't do this in your open concept kitchen, right? You know, make sure that your background is blurred so people don't know where you live and what's in your back. Because you wouldn't believe some of the things that patients will learn from, you know, seeing your house. But anyway, so and yet, but having the closed door is a huge one. It comes up often in complaints from patients. They actually have more mistrust of physician who's got an open door, who's doing the consultation. Consider confirming the identity of the person if you've never encountered them before, or usually your admin can have them send their health card and just verifying them and their date of birth if you've never met them. And you want to disable any options so that they can't record you. And we encourage patients ahead of time to participate in a private setting, like set them up for success, right? Ontario MD, I will focus more on Ontario because most of the audience here is from Ontario, but there are several great guidelines on how to use virtual care that are free. This Ontario MD site, there's also a great one in BC, another one in Alberta. There's lots of great resources out there, and I don't own any stock in any of these things, so no plans there. Therapeutic planning. So follow-up came up quite a bit this morning, and I was taking some notes, with regards to the issues that we see with follow-up. A lot of patients have fallen through the cracks in the last 2 years, right? We try to do the right thing. We try it from the right clinics. They often, I know when I give them a medication for MERS, 50% of the time they don't fill it. So again, how do we ensure that patients have the right follow-up needed, particularly on these kinds of medications where sometimes you have to monitor their renal function, and all those other things. So if you can ensure that you have a process, because this comes up a lot with colleges, is what is your test result follow-up system? And you're like, I don't have a system. No news is good news. That doesn't fall through there. We do a whole thing on test results follow-up, but you have redundancy. Like, is your EMR marked with that patient so that if they don't come back in a certain amount of time, it actually blinks, or you have a red flag or something comes out in your file if you're a paper system. So you can't rely on patients, although you can certainly involve them in the process of follow-up of why it's important and documenting that, and I always often say, if you haven't heard from our emerge department in 3 days, then you need to call or this kind of thing. So some type of way to ensure you have multiple ways to do follow-up. Yeah, the adequate monitoring follow-up is a huge question. And again, doing that screening, right? When people say they're on no medications, I had to totally agree with Dr. Sigel this morning. They're on all sorts of stuff. I mean, half the plant's on CBD oil, and you just have to say, are you using any recreational things for your general natural health? Right? Oh, yeah. And then it gave me like a huge list, right? So again, oh, it did. Okay, see, it is blinking, Kelly. So ensure that you do check, because people may start things even though you start medication and take other things. Okay, so you have to check up on that. So make sure, again, about the follow-up advice, the format, telephone call the patient or virtual, the context that you had with regards to assessing them, and the follow-up advice. All right, I'm curious to know, do you think that the colleges and courts expect physicians to provide the same standard of care to patients regardless of the pandemic? How many of you think that's true? Okay. And how many of you think it's false? Come on, there's a few. All right. Well, the answer is false. That's a bit of a relief. But okay, you read kind of between the lines, like, I'm part of this too, right? And then and they'll say that the patients expect the same standard and level of care. The colleges and courts do understand that there's limitations, particularly during the pandemic and resource issues that are ongoing. So the good news is they actually don't expect us to provide the same standard of care, but they do expect you to actually act in the patient's best interests as best as you can. And believe me, when I have a waiting room of 60 patients, and I'm trying my best, there's definitely things that I do a little bit different. I don't really want to thrombolize someone with an MI in a chair, but again, acting in the patient's best interest is really important. So think about our professional associations. This is why this organization is so great. What the colleges, are recommending, they have some pretty good reads, and they've updated a lot of their policies recently. And what your peers are doing, especially for this gray zone stuff that we talked about this morning. Do we collectively as a group, where are our pain points? Let's come up with some type of recommendation on this and how we're going to agree to manage this with our patient population. All right, I can see my time is up. You're giving me the look. I'm going to stop there. Sorry, guys. This is so much good stuff. All right. I think I'll just stop there. I do want to thank you all for all the hard work you're doing every day for patients. I'm there on the front lines with you as well. It's been a hard couple of years, but I know we're going to get through this. And I know that you're going to be able to, know that we're here for you. You can call the CMP anytime, and this is not a promo, but we are definitely here for physicians. When you're having those pain points or concerns about a particular patient and taking care of them, please give us a call. Thanks so much.
Thank you, Dr. Lee. That was a very thought-provoking, informative talk. I know, at least for me. And I'm sure there are a lot of burning, asking for a friend type questions.
Yes.
So we'll get straight to that.
Please ask questions on behalf of your friends.
This is a safe space.
It's a really great talk. We learned a lot this morning about bleeding complications that we all recognize with our management. And if you can maybe talk about those renal patients, for example, and we talked about using DOACs for patients with renal failure on dialysis and atrial fibrillation. And we know that in Canada, we don't actually have approval for DOACs in patients on dialysis. And so what are some of the implications that we need to be aware of when we're having that discussion? Because as you mentioned, you know, patients aren't necessarily medically literate the way we are. So how do we navigate that?
Yeah. And so this is a common question we get about off-label use of medication, you know, based on practices. And sometimes practice evolves before the research publications show it. And again, that's why we have to be very careful when we look at what's out there with the research. With regards to off-label use of something that's not currently recommended for a certain patient population, we often will actually recommend, first of all, probably best to call us because it's very nuanced depending on the specific circumstances of the patient. But if you are going to do off-label use of a medication, you want to ensure that you have extremely good documentation with regards to why you're recommending that medication in particular, what other avenues of standard guidelines you have actually tried first for that patient. Okay, you don't just jump to the latest and newest vogue thing, which seems to be ketamine these days, but for everything. But yet you tried the standard procedure things and they didn't work. And that you had to move off to doing this, you know, sort of off-label use, that you explain thoroughly that it is off-label to the patients. They need to know that. Okay, it's not currently recommended, but we're basing it on this evidence, you know, and that any other consultation you may do with the experts to be following that practice, particularly if you're the only one that's doing it and nobody else is, you really want to pause to make sure that you're doing something that's in the patient's best interest, because the colleges will certainly look at that very strongly with regards to whether or not you actually practice what was considered standard of care at that time. And the reason I say at that time, we have cases from 1990 and the care is very different with what drugs we had than now in 2022. This happens a lot for pediatricians. Everything they do is off-label. There's no good studies for anything. But again, consensus guidelines, like what Thrombosis Canada can do, are really important because this is the best we've got. And doing that collaboration, I think, with other subspecialties, like you're going to have at a conference next year, is very helpful. I hope that answers your question.
Thank you. We have an online question. So one of our participants is asking, how much can be deferred to a pharmacist in discussing risks and benefits of a medication from the medical legal perspective?
Great question. So this is about delegation supervision, which is definitely what we do as healthcare teams. In fact, I see it a lot with neurologists and stroke clinics. They have a nurse practitioner do the informed consent. So perfectly fine to have a pharmacist do part of that risk benefits assessment or discussion with the patient, but make sure they have very clear documentation and protocols that have been signed off. So for example, if it's in a practice, like when I work in the emergency department, we actually sign off as physicians on any practice guidelines we have for our nurses and that they're trained properly and able to answer all those questions for patients. So whoever you delegate to has to be able to answer the patient's questions, not maybe as fulsomely as you, but they have to have a very good understanding of what the proposed treatment is and the risk. So it's fine. But again, they would have to make sure they did some of the things we talked about that consent.
Hi, this is a very excellent talk. I just wanted to follow up a little bit on the documentation you were mentioning regarding discuss risks and benefits. And you know, I guilty of writing, you know, I discussed the risks and benefits, period. The patient understood, but you were just mentioning to go on and actually focus on, you know, A, B, and C. Should there be, you know, more, I guess, atypical complications or more life-threatening complications? But then I was trying to reconcile that where you talked about using abbreviations for some of the things you do, like SDM for shared decision model,
That's just
the
me.
decision
Yeah.
making, exactly. And so where is that, balance of putting down acronyms, which perhaps may not be as explicit, and at the same time writing down, a more explicit comment as to what you discussed with the patient?
Yeah. So great question. Because I'm not here to make your life miserable and then spending an hour on every patient that you see, God forbid. So when you think about when people write about risks and benefits, discussed, and some physicians like to say, look, I have this talk all day. I'm a full-time hematologist. I don't talk about anything else. It's my regular practice. And I always review blah, 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 blah. I'm like, okay, where's your handout then? Where's the other piece of documentation showing that you always do? Because we can actually try to defend what we call a physician's invariable practice, that they always do this. It's much, much harder to defend versus something that's documented. So when you notice that you're talking a lot, like your patient keeps asking questions, that's your ding. I need to write some of this down, right? And so I'm happy that you're even writing risks and benefits discussed, because we sometimes don't even see that with very serious medications. But I think particular to that patient, I would say risk of a few key ones, right? Those major ones, right? And of course, benefits is usually easy sell, right? Yeah. And use handouts appropriately or websites that you standardly recommend to offload some of that. Sorry, the second part of your ask was,
It was just more, I guess, the documentation from using, it was
Oh,
interesting how you
acronyms.
use.
Yeah. Yeah. As long as your acronym is one that's commonly used by physicians, okay, it's okay. If you make up your own acronyms, like I've seen physicians do that, yeah, it's going to be hard to defend. In fact, I don't even use, because patients have access to their charts too. You have to understand there's a different level of comprehension of what you're writing. So I don't even write for my chest exam, no SOB, right? No, right? No increased work of breathing, right? Because that is not an acronym that's going to go well in the public, right? So acronyms are okay if they're pretty typical ones that are used, but again, if you can demonstrate that that acronym is commonly used by most people in medicine, it's okay. As long as I can interpret it as someone who's defending you, wouldn't be me, obviously I'm a doctor, but we read the files actually and recommendations, and I can pretty well see where a physician's thinking, even with the acronyms.
Great, thank you.
Yeah.
Thank you. I don't think there are any more questions. Oh, yeah, no.
I had a question. Well, related to virtual care. Thank you so much for your presentation. It's just wonderful. It was like riveting.
Wow.
Well, it's such an important topic that we don't hear a lot about. So thanks for that. In virtual care, we've struggled a lot trying to, yes, on one hand, it increases access for people who may not otherwise have access. But on the other hand, sometimes you're seeing or expected to, quote, assess patients in clinic who aren't appropriate for virtual care. So for example, a person who is discharged from hospital, unbeknownst to the well-meaning inpatient team, they are in long-term care and have significant cognitive impairment, and you call the nursing home. And, and this person is booked into your clinic. So I have met many times during the pandemic, felt really uncomfortable about that. I actually called CMPA because I thought, what am I supposed to do in this situation? But I guess you still have a duty to that person. And I just wonder a little bit about if there's kind of guidance around how to handle, those situations. The patients and their physicians are have a question for you as the specialist, but you aren't really able to assess that person.
Right? Yeah. Oh yeah. Take a look at the patient. It's like, follow up with your family doctor when I know they have no family doctor. Like, what's the point? Like, really, come on. So yeah, with that particular situation, yes, some patients are no way you want to do a virtual care appointment with an 85-year-old. Sorry. Like, where's my camera? Where's the sound? You just don't want to do it. So the first thing is the triaging of those patients, right? With regards to how they're being managed. A lot of patients in long-term care are managed by telephone advice with subspecialty, right? And so the question becomes, if your discomfort is increasing because, you're only getting some of the facts, not all of it, and, they're kind of at moderate risk, with lots of things, then the question becomes, how might we improve that care for that patient? So when we look at the patient safety quality improvement work being done in long-term care facilities, right? The question is, can you strengthen or fill the knowledge gap for the physician who is the MRP for that long-term care clinic? You know, maybe we need to actually have some education interventions to improve that care so you're not getting these calls. Or despite that, even because you have concerns about the care ongoing, what can you do to optimize that care for that patient? And certainly if I was giving telephone advice based on limited information, I would document that. You know, if there's no other circumstance and, you know, recommended, you know, the following based on the information shared with me, XYZ, and review their internal medicine admission. You know, my telephone advice was the following. However, I raised concerns that the patient, as I'm not, you know, the limitations of telephone advice. Like a lot of us have a standard template we use now for limitations telephone advice. Okay, that's fine. But really it's about doing good care with the patient. The question becomes, can you sleep at night? And if you can't, then it's probably not only a problem for you, it's probably a problem for a lot of consultants in your group. And what's a reasonable solution? I can't tell you how to practice. I can tell you other groups have actually done mobile teams and driven out in their little fun hematology van or, you know, gone to the site if they've got like 20 patients there that they have to deal with because the patients can't come to them. But it's a real headache getting these patients from long-term care into the clinic at the hospital. Does that help a little bit?
Yeah, I think it's just a lot of us maybe deal with that sort of situation and it's tricky and you want to do what's best for the patient and be able to support the physicians who are looking after the patients in long-term care with advice, but you're also not in a position to assess and help make decisions when you're not able to assess.
Right. Yeah. And so there may be standard questions your group actually checks through with those long-term care patients, right? Or screens, or even have someone else screen ahead of time. So it comes to you with that preloaded information, I think would be helpful.
Yeah.
And if there are standard things you're recommending, you know, that makes it simplifying the process with regards to adjusting medications or new scripts. Again, process or systematic frameworks, I think are really important with regards to how do we approach this from a longer lens, you know, than just that patient in front of you.
Yeah. Thank you.
Thanks.
Thank you. Thank you, Dr.
All
Lee.
right. I will be around at lunchtime. Okay, so come by and visit me. Thank you.
So we're going to introduce our next speakers, or rather debaters. We're going to have a mini debate. The first will be how to manage teeny weeny clots, distal DVT and SSPE. Dr. Marc Carrier and Dr. Gregoire Legal will be joining us up here. So Dr. Marc Carrier is a professor in the Faculty of Medicine, Departments of Medicine and Epidemiology at the University of Ottawa, and a senior scientist in the clinical epidemiology program of the Ottawa Hospital Research Institute. Dr. Legal is a professor in the Division of Hematology in the Department of Medicine at the University of Ottawa, a physician and the director of the Thrombosis Program, Division of Hematology at the Ottawa Hospital, and a senior scientist in the Ottawa Hospital Research Institute. Some ground rules before we begin. No physical fighting. No. Why would that be? So both of you will state your respective positions on the matter so that it's clear to the audience. And at the end, we will put it to a vote. All audience members, debaters, and moderators will have to vote as to who's convinced them whether or not we treat distal DVTs and SSPs. So with that,
Well,
please begin.
so we say our positions. So I'm very happy we're following Dr. Lee and the CMPA, because if you want to avoid calling Dr. Lee in the near future, you should follow my position and avoid treatment of segmental PEs and distal DVTs. What's your position? He has the same position. Let's move on.
No, I have the opposite position with the same argument. How is that?
Okay, so these are in our disclosures. So these are mine and Gregoire. And really what Gregoire will try to do today is really to make you do errors of commission. And they're no better than errors of omission. So you need to be very mindful of that. And I don't really blame you, because since we've been in medical school, pharmacy school, nursing school, people have been telling us like PEs are really dangerous. As soon as you have a suspected case, you need to start anticoagulation. If you have confirmed diagnosis, they need to go to the emergency room to be treated. So for decades, clinicians have been pounding in their head that PEs are bad. But the problem is that the diagnosis of PE has evolved over time. We used to use ventilation perfusion scanner. Old enough people like Grégoire and I used to use ventilation perfusion scan. Now we're using CTPAs, which are more readily available, provides alternative diagnosis, but they're very, very sensitive for very small vessels. So when we follow patients over time from the early 1990s to 2022, what we see is that the number of PEs is just skyrocketing. You guys know that when you're in clinic, you see a lot of clots all the time. It's every day I'm amazed how many clots we see. And part of the reason why we see so many clots is that diagnostic modalities have changed. And what you see here is that in 1998, this is when multi-detector CTPA was introduced in the United States. And you can clearly see that afterwards, the incidence of PE has been skyrocketing. And interestingly, there's been no change, I should say, no decrease in mortality since then. So it begs the question, why is the incidence of PE increasing? Well, you may be thinking, well, it's a true increase in the incidence, right? We have more risk factors. Cancer patients are living longer. Maybe there's more things for why we have no clots. So if we see that, we should expect no change in disease severity, right? We should have small clot and big clots all the same. Is CTPA just a more sensitive test? And if that is the case, then we should see fewer deaths expected to treatment because we picked them up early and therefore we're going to change the underlying management. Or are we starting to overdiagnose PE? And I think that's the problem now. So we're starting to overdiagnose PE, more PE. So what we see is that the cases are not really affected by or undergoing anticoagulation treatment. So if that is the case, we should see an increase in the incidence, no change in mortality, and a decrease in the case fatality rate over time because we're just starting to treat a lot of clots that are not clinically important. And this is what we're seeing in the large database that I've shown you. So skyrocketing increase in the underlying risk of having PE diagnosed, no change in mortality, decreased case fatality rate. And are these related to small clots? Well, the answer is yes, because the more detectors we get on these CT scans, the smaller and smaller clots we get. And are they clinically important? Well, let's have a look. This is indirect data, but you can see on your left-hand side that if you have a single detected CTPA, you will pick up about 5% of subsegmental PEs. So those that did not have a diagnosis of PE were left untreated, right, and followed for 3 months. The risk of recurrence is 0.9. When you use a 64 cutter, then you increase your underlying risk of having subsegmental PE diagnosis to 15%. You still don't treat the other patients. The risk of recurrent VT, despite leaving them untreated, has not changed. So really indirect evidence of this increase in 10% in subsegmental PEs are really not clinically important because if you treat them or not, it doesn't change the end results of increasing the underlying risk of recurrence. And this has been highlighted by a number of observational studies. I've picked this particular study because it's from McMaster University, cohort of 2,200 patients who underwent CTPA, 24% had clots, 15% had subsegmental PEs. A lot of them didn't get any treatment, and they all did well. Actually, those that got treated had major bleeding complication. And I think not treating these clots is the right thing to do.
All right. Well, so fair enough. But as you know, right, that was a retrospective study. There was likely some selection bias. Who were the 52% of patients who did receive anticoagulation? Why were they not treated? Why were the other 48 patients treated? We won't know that, right? So, and I get your point about, it's better not to know. Right? Is that what you're saying? Right? Let's not know about, SSPs and we will be all good. But then once you find one, what to do about it, right? And you didn't really answer that one. So we did that study, right? The SSP study together with Mark, where we enrolled some patients with isolated subsegmental PE, meaning no PE more proximal than in the subsegmental arteries. We knew from the diagnostic studies that you mentioned, right, when we were using VQ scans back in the days, or when we were using single detector CTPAs, that whenever these were negative or non-conclusive, we wanted to make sure that there was no DVTs, and that along with a inconclusive VQ scan or negative single detector CT, that would allow us to rule out the PE. So we sought to do that as well there. And Mark was like, well, these are nothing, these clots are nothing. They won't recur more than patients with negative diagnostic testing for PE. So we said, okay, let's try that. So enroll them.
You agreed to that too.
Did I? And get that ultrasound. And then we repeated the ultrasound after a week, which is actually very important because that's how it was done in former diagnostic studies as well. And the ones without the DVT were left untreated and followed for 3 months. And again, with the aim of being able to demonstrate that a 3 months risk of recurrent event would be no higher than after a completely negative diagnostic workup for PE. And here is the outcome. So we had obviously we were a bit worried when we started, continue to worry. And because we obviously, didn't want too many patients to have recurrent events, so that we had a stopping rule and we knew that if more than 7 patients would have a recurrent event during follow-up, our upper limit of our 95 confidence interval would, no matter what, be higher than 5%, so that we would stop the study. And that actually happened. We had to stop the study early because of a too high risk of recurrent event as compared with what we had initially planned. So Dr. Carrier might tell you that 3.1% is not that high, just pointing out the upper limit of the 95% confidence interval here being up to 6%. And certainly, maybe most importantly, and beyond the joke, certainly the main things that we have to point out here is that we were careful at selecting not high-risk patients when we did the study, right? So in that study, the 3% is in patients who didn't have cancer, never had a clot before, weren't admitted to hospital, right? So if you start thinking about doing what he wants, start thinking that, these were the patients included in that study. So certainly a big caveat there. Just to say that we also had a number of subgroup analyses, and that's where he will come back later, showing that definitely patients with single segmental PE seems to be at a lower risk than patients with multiple clots, that younger patients tend to do better than older patients. And that's something that you can certainly use into your informed shared decision-making.
That's true. But keep in mind, Dr. Legat, that 97% of patients, nothing happened. And you and I looked at all the different recurrence at the 3 months. Are you really worried? Did we kill anybody by not treating them? How many people will you have killed by putting them on anticoagulation with a case fatality rate of 10%? If you start treating all the subsegmental PEs, you'll kill more people than you'll save lives. You know that.
All right. So what the guidelines say in the meantime, right, that in patients with subsegmental PE, no proximal DVT in the legs, the suggestion was clinical surveillance over anticoagulation in patients deemed at being at low risk of recurrent VT. And I gave you some hints about who these could be. And the other patients should, well, the suggestion was to treat them with anticoagulants. And we will see what happens after these guidelines are reviewed based on the most recent evidence. And we just mentioned before that there is an ongoing clinical trial as well now, where we are randomizing patients with subsegmental PE between receiving anticoagulation or placebo. Which
so there's still clinical equipoise.
I guess there is. All right.
Okay, distal DVT. I'm not sure how to put that in Gregoire's head even further, but it's the same thing, right? So when we look at DVT, lower limb DVT, 70–80% are proximal lower extremity DVT, 20 to 30% of deep vein thrombosis are calves deep vein thrombosis. And we don't always look for them, and people do just fine. And these are two different studies looking at two different treating strategies where you
prefer not to know.
Yeah, well, why do I need to know if it's not relevant? You're just waiting. I'm not saying not to do anything. I'm just saying not to give them anticoagulation. They need to have pain control with anti-inflammatory medication and other things. But look at this, Legat. So when you look at proximal ultrasound, Again, look at distal DVTs, zeros. When you look at, when you have a complete ultrasound, 65 out of 278 are actually distal DVTs. You don't treat any of those that you didn't diagnose. You follow them over time. The risk of recurrence is no difference. Same thing with the other study. So when you do whole leg ultrasound, you diagnosed a whole lot more clots. Most of them are distal DVTs. And when you follow them over time, they don't do any better. So again, indirect evidence that your anticoagulation treatments are not helpful. And this is a systematic review highlighting the same thing. So on the top, you're looking at studies that just did serial proximal ultrasound. I think, Dr. Legal, you're an author on this, if not senior author on this. So when you look at the 3-month risk, it's 0.3%. When you do whole leg ultrasound, you have 50% of distal DVTs, and the risk of recurrence is still 0.3% after 3 months of anticoagulation.
So same thing, right? We thought we would try to look at it a bit further. Where's Jean-Philippe? Jean-Philippe needs to come help me here. Oh, he's over there. Okay, come defend me a bit. All right. So we did that cactus trial, and that was a French, Swiss, Canadian study, randomized trial comparing low molecular weight heparin to placebo in patients with isolated calf DVT. And so the results are as shown here, right? There was so the risk of extension to the proximal veins or of migration to a PE was 3.3% in patients treated with low molecular weight heparin versus 5.4% in patients treated with placebo. And the risk of bleeding, on the other hand, was, and these were non-major bleeding, by the way.
What's the benefit?
Well, it's clearly there. Like, just have a look.
I don't see it. I don't think it's statistically
All right.
significant.
And then we had some long-term follow-up data
And
as
then you have
well.
harm.
Yeah.
Increasing.
Yeah, look at all these asymptomatic DVTs at 6 weeks point in patients who were treated with placebo, which we don't know what happened to them later, right? And actually, all right. And so certainly again, limitation of that study is that we had to discontinue it early because of low recruitment rate. DOACs came into play, and then the study drug actually expired. And a bit the same story than for the SSP data, by the way, is that these were rather low risk patients, right? That we again, no cancer, no previous VT, no pregnant woman, no admitted patients. And I was bringing Jean-Philippe into the game because Jean-Philippe is actually designing a new study that will be comparing a prophylactic dose of anticoagulation to a full dose of anticoagulation in this patient population. So these are, you were asking what benefits. There was a non-significant reduction in the risk of VTE.
The P is not significant for the benefit, and the P is statistically significant for the arms.
Non-major bleeds, non-major
Okay,
bleeds.
so
We're all good.
okay.
Yeah. And what
Dr. Lee's card will be required for Dr. Lee.
And the guidelines actually say pretty much the same than for patient with SSP, right? Is that if you have a patient with an isolated calf DVT, if there are no severe symptoms or no major risk factor for extension, suggestion is to do serial imaging for 2 weeks over anticoagulating them. While on the other hand, if they have either severe symptoms or risk factors for extension, but I could play games again, but because it's funny to say, oh, what are the risk factors, right? Well, if the DVT was provoked and the provoking factor is still there, then you should treat. So, post-op patients should be treated. And if the DVT is unprovoked, that's higher risk. So you should treat as well. So,
I didn't read it. I didn't write these guidelines.
All right, fair enough.
So I think, just to finish off, because there's 22 seconds left, 97% of these tiny little clots, subsegmental distal DVTs, don't need anticoagulation. Anticoagulating all these clots will for sure lead to some bleeding complication. Dr. Legal have shown it in a study he did himself. It will statistically increase the risk of major bleeding complication. Okay, not only major bleeding, but patients don't like to bleed in general, but clinically relevant bleeding. So I think for the sake of patient safety, we should just not treat these clots.
These cherry-picked low-risk patients is what you mean.
Well, that's the only data we have.
All right.
Shall we put this to a vote? Who is treating eeny, weeny, teeny
You want to split this?
clot?
PEs or DVT?
We will. So for the SSPEs that are low-risk patients and do not have confirmed DVT, because that's just too easy.
You treat most of their subsegmental PEs. Is that a fair way to ask?
Yeah. Subsegmental PEs. To treat or not to treat. This is the treatment.
I'm taking notes, Dr. Siegel.
We should have blinded. them.
Really?
And you two, did one manage to convince the other?
I think we have a similar practice where we treat some and don't treat some. It's important to the risk benefit ratio.
Yeah. So it seems like generally a low risk SSPE who doesn't have a confirmed DVT, it seems like the audience feels comfortable with clinical observation and vigilance. What about our below knee DVTs without a person? Well, I guess we can make it an unprovoked below knee DVT, low risk of bleeding.
Who treats?
Who's treating?
So there's more people treating distal DVTs than subsegmental Ps. This is fascinating.
Mhm.
You would think it's the opposite. Okay.
True.
So we both won one side.
I would say so. That's a tie. Thank you both. We will now invite our next debaters for another amicable debate, although that one was a little heated, but we expect you to behave. So this one will be thrombophilia testing. Is there ever a need? Our speakers will be Dr. Lena Castellucci and Dr. Eric Tseng. Dr. Lena Castellucci is an associate professor in the Faculty of Medicine at the University of Ottawa and a scientist at the Ottawa Hospital Research Institute. Dr. Tseng is a staff hematologist at St. Mike's Hospital and assistant professor at the University of Toronto.
Hi, everybody. It is great to be back here with Eric. We've done this 3 years in a row now where we are working together. So this is a lot of fun for us. So we will talk about thrombophilia testing. My disclosures are here and Eric's as well. And this is what we're going to learn about today. So when is there a need for thrombophilia testing in patients with venous thrombosis? And we'll also talk about some of the pitfalls and how to interpret them. We'll start with a case. We've got a 38-year-old previously healthy actor who injured himself and he had a torn right meniscus and he's going for arthroscopic knee surgery. About a week later, he comes in and he has some right calf swelling and pain and he's seen it emerge and appropriately a D-dimer is measured. And then that leads to an ultrasound, which confirms that he has a DVT in the femoral and popliteal veins, so in the proximal system, and his labs are listed there. He's treated with one of our direct oral anticoagulants, and being a very bright person, he says, well, I'm pretty young. Is there any reason why I got this blood clot? And he asks you if he should get any testing.
So I will say this was very hard to put together because Lena and I agreed on most of it, I would say. So we tried to tease out a specific question that we thought would be controversial for a case like this. So the challenge with this case is this is a pretty minimal provoking risk factor, right? The baseline VTE risk in a young patient after arthroscopic knee surgery is very low. We don't typically prophylax these patients after these procedures. So this is why there's a bit of controversy here. So what are we talking about when we talk about thrombophilia testing? I think it's important to think about the inherited disorders and then also the acquired disorders. These are the disorders you see on your screen here. So the inherited thrombophilic disorders, this is what I tell trainees is the big five. So you'll see them on panels, thrombophilia panels. So the top three are the natural anticoagulant deficiencies. So antithrombin, protein C, and protein S deficiency. The bottom two are the more common inherited disorders, factor V Leiden or the prothrombin gene mutation. And what about acquired thrombophilia? So these are different disorders. These aren't disorders that you're generally born with. These would be disorders like antiphospholipid antibody syndrome, patients who have a myeloproliferative neoplasm with the JAK2 V617F mutation, or maybe a disorder like heparin-induced thrombocytopenia. There are other examples as well, but just to be explicit, those are the different disorders that we're talking about. Okay, so just something to know about these tests, and I think it's really important to think about how to interpret these tests and the constraints around them. We just had a great talk about the medical legal aspects of ordering tests and how do we handle these discussions. There are lots of pitfalls with ordering inherited testing for inherited thrombophilic disorders. On the left here, you'll see the 5 disorders we just talked about, and on the right are reasons why these tests are often unreliable. So let's go through the first 3. You'll see the natural anticoagulant deficiencies. A lot of the things that can impact the testing results would be things like DIC, liver disease. Patients who are on vitamin K antagonists will have protein CNS deficiency if you test those levels. And so that poses a problem if someone's ordered these tests and is not clear if they know how to interpret them. Other things like pregnancy and estrogen therapy can also lower protein S levels. I've gotten several referrals over the past 12 months for that specific question. And so it's really important to think about the pitfalls of these tests before we order them, and so that we can explain it to patients. Factor V Latin for thrombin gene mutation, these are genetic tests, so it shouldn't be impacted by these acquired reasons for having spurious lab results. So I mentioned before that Lena and I, we're friends. There's a lot of things that we agree on, and I think this is something that we both agreed on. So we both feel that inherited testing for thrombophilic disorders is not indicated in a case like this. What I've done here is put some common questions that patients will ask many of you in the audience about why they want this testing done. So the first question is, Dr. Castellucci, why did this clot happen? The second question is often, Dr. Shivji, why don't we do the testing to guide the testing of my asymptomatic family members? And the third question is often, Dr. Koulian, I would like to have information to guide further efforts to prevent further blood clots. So these are the common questions that we get. And I just wanted to give you a sense of why we feel these tests are not indicated in this situation. Why do we not test to determine why a clot happened? It's a bit of a complicated argument, but essentially these inherited thrombophilic disorders do not substantively impact on recurrence risk if one was to stop anticoagulation therapy. So if it's not going to impact on the recurrence risk and the duration of anticoagulation therapy, then why test? In fact, the recurrence risk is more predictive by other clinical risk factors that we know about. Male gender, persistently elevated D-dimer. We'll talk about APLA in a moment. What are the circumstances of the clot? In this case, this is a minimal provoking risk factor. What about guiding testing of other asymptomatic family members? It's usually not helpful. Usually not helpful because a family history of an unprovoked venous thromboembolism at a young age already increases the VTE risk in an asymptomatic family member, regardless of what testing shows. So negative testing might actually provide false reassurance. In other words, you might test negative for the big 5, but you might still be at increased risk for thrombotic risk if your father had a DVT at the age of 35. And the third is, what about helping to guide future efforts at VTE prevention? Usually not helpful because we know in this patient that in the next time he undergoes arthroscopic knee surgery, after he does a stunt and tears his other meniscus, for example, he would probably benefit from VTE prophylaxis the next time he's exposed to a high-risk situation, regardless of the testing results. So why test? So I think really the question here is not this. I think the question is, what about the acquired disorders, and specifically, what about antiphospholipid antibody testing? Should we order a test, that specific test in this specific situation? And I think that's where we kind of disagree. I actually think it would be a bit excess to order this test because how many times have you seen a clinical situation like this? And would we test every single one of these patients? If you have a positive result come back once, that usually would mandate that you would have to bring them back for subsequent testing. And then the patient anxiety that comes from that, the laboratory cost of dealing with that lab result, which might be a false positive to begin with. So there's lots of reasons why I think that testing probably isn't indicated in this situation, and I wouldn't actually test for it. But I'll ask Dr. Castellucci to disagree with me.
Thanks, Dr. Singh. So how do you say no to Thor? He's right in your office and he's looking at you and he's like, Dr. Castellucci, Dr. Singh, what am I going to do? How do I know that I'm not going to get another blood clot? So when is it appropriate to do antiphospholipid antibody testing? And it can be helpful in very specific situations. And I think it's really important to apply this testing to the right patient. And so even though We know that we can avoid the top five as, or the big five, as Dr. Singh mentioned. Antiphospholipid antibody testing does have some consequences to it. And it does require that repeat testing. So it's really important that when you are considering doing it, that you inform patients that a one-time measurement doesn't necessarily mean they have the syndrome. So what do we want to look for? We want to measure antiphospholipid antibodies with your anticardiolipin and your anti-beta 2 glycoproteins, as well as your lupus anticoagulant. And of course, remembering that, as Dr. Singh mentioned, this then requires, if any of those levels are positive, that you would potentially bring the patient back 12 weeks later to have repeat testing. Timing of when this is measured is also really important. So we know that some of these levels can be falsely elevated at time of acute clot. So it's really important that if you're going to measure these levels, that you want to do it at the conclusion of your treatment. So we're going to anticoagulate this guy for about 3 months because he has a provoked proximal clot. And so we would want to do this in the right patient population and at the right time. So in terms of arguing for this antiphospholipid testing, we all agree that we're not going to do the inherited big five, but we may do the antiphospholipid testing. We really want to look at, when do we do it in those patients who are younger than 50 years, because that's really the population where it's going to impact sort of our future management. When they have unprovoked or weakly provoked VTE, like our patient here, so Thor having an arthroscopic knee surgery, it's not common to get clots after that, and it's certainly not common to prophylax, as Eric mentioned. And then unusual site VTE is another case where you may want to do antiphospholipid testing. Or if there's cases associated with autoimmune disease, that would again be sort of the population where we would do this. And so we're kind of arguing for and against at the same time, but really making sure that we have that correct patient. So for Thor, what are we going to do? We're actually going to go and use our Thrombosis Canada thrombophilia tool. So this was developed about 1.5 years or 2 years ago now, and it's available on our website and on our app. So I really encourage you guys to use this. It's a great resource, and it helps you to determine what is your patient's next step. And so you go through and you enter in the information there. This is just a screenshot from the website, and you can see that the first thing that the question is asked is this the patient's first clot or not? And then there's a series of questions after that. And so it gives step-by-step guidance of whether or not thrombophilia testing should be done and when you should refer to a specialist. And I think that's something that we should keep in mind, that thrombophilia testing, again, has those consequences, and you may want to refer to a specialist. So when we go back and look at Thor, we talk about his initial management, and he asks, I want to be tested. What can you test me for? And I think we both maybe agree that we would do antiphospholipid testing only, or at least I would, because how do you say no to that?
I think you said it best, Dr. Castellucci. You both argued for and against thrombophilia testing, which makes both of you winners in this case. And I think highlighting that the Thrombosis Canada tool can help sometimes answer those maybe more gray zone questions or help us guide decision-making was very helpful. So thank you to you both. Just before lunch, I'm sure everyone is hungry, but we will open up for questions for all four speakers. I see a lineup forming.
Everybody knows who I. Two things. I just heard Dr. Castellucci misspeak because she said that beta 2 GB1 was a useful test, and of course it's not. And Wendy Lim and so Debbie Yang from University of Washington just published a really nice systematic review showing that it doesn't really predict anything at all in people who have positive anticardiolipin, positive lupus anticoagulants. So my statement with beta 2 GB1s, which many of you heard before, is that it predicts nothing but confusion. Now I do agree that if it's triple positive, that probably means something. But I'm very hesitant to endorse the use of beta 2 GP1s because they really are not very powerful predictors, and they do cause confusion. And the second thing is, I think when approaching thrombophilia testing, I have a slightly different bent on this. And the slightly different bent is that you might want to test for thrombophilia when there's an intervention which wouldn't otherwise be used, that might be used based on the results of it. And this is an example of it, right? Because there's now 4 randomized control trials that show that rivaroxaban or apixaban, well, both, are inferior to warfarin. And even more concerningly, that the people who had recurrences, even if they'd only had prior VTE, had a propensity to arterial thrombosis. And so we just put an editorial into one of the big journals earlier this week. And we're kind of starting to think, as you know, I'm a big nihilist about thrombophilia testing, but I am starting to think that we probably should think a little harder about APS in these people, even if they don't appear to have risk factors, because a small fraction of them are going to go on to have otherwise avoidable arterial strokes if we use warfarin instead of a DOAC in these patients. It's a super complicated area.
Yeah, absolutely. And I think, again, timing is really important, right? So not really measuring these levels at the outset of the clot and making sure that you're waiting until that sort of decision tree happens.
And also being super careful about them being anticoagulated when you do the testing, because APS, rivaroxaban and apixaban can cause both false positive and false negative lupus anticoagulants. So you need to be super careful about it.
Yeah, it's a great point.
So I'm Alan Mel, I'm a family doctor in Toronto. So first of all, thanks, Lena and Eric, for a great and very entertaining presentation. Okay, so I've been very nihilist in terms of doing any thrombophilia testing, particularly for the inherited disorders. And yet, not infrequently, I will get reports of patients getting all this thrombophilia testing. And sometimes it's from some pretty smart people. So I'm trying to figure out, when should we do inherited thrombophilia testing, if ever?
That's a difficult question. The problem is that I think when I trained, it's been drilled into me by many people in the audience that we shouldn't do it. I think actually I like the Thrombosis Canada tool. I actually think these questions should be thought out really carefully, and that the testing should be done by someone who can counsel appropriately about it. So, the testing, at our hospital, it's actually a restricted test. So only hematologists can order it. When I started practice 5 years ago, I had to get on the list. And if you try to order the testing at Life Labs, it's like hundreds of dollars. And I think with good reason. I think the testing should be thought through carefully, and that there needs to be appropriate counseling. So there isn't really a right answer on who should get testing. There are probably certain groups. The slide that I showed about asymptomatic family members. We often think about young women who are starting estrogen, for example. That's probably the key area. But I think there's no blanket statement for that. I think that's a really important individualized discussion. So I hope that helps and doesn't help at the same time.
Thank you. We have some questions from our virtual audience. So the first is directed to our first debaters. If you opt for serial imaging over 2 weeks and it shows no extension but persistence, do you continue to do surveillance imaging or opt for clinical surveillance again thereafter? So this is pertaining to distal DVTs. Dr. Legal, Dr. Carrier, one of you.
I don't know. I treated him so that he doesn't have to come back every week. No, I think, beyond 2 weeks, usually we say we are happy enough to, and the chances of further extension of recurrence is usually low. So we would still tell them, well, if symptoms progress, call us back, but we would not redo systematic imaging at them.
But in Cactus, you did 1 week serial ultrasound and it was just fine.
Yeah.
Do you do 2 weeks?
No, the question was if
After
someone
1
had,
week, there's persistence.
Yeah, and then keep in mind that you need to treat the symptoms, right? And you need to be reassuring about, anticoagulation doesn't make things better, it's prevent recurrence and extension. And there's some data from Cactus saying that when people are blinded, it was a double-blind randomized controlled trial. They didn't know there is not a whole lot of difference in pain for those that receive anticoagulation with nadoparin versus not. So they need to be treated with anti-inflammatory medication or something. And if there's no extension at the 1 week ultrasound, then they're usually good to.
One last question. Do you screen for antiphospholipid syndrome routinely in patients with unprovoked thrombosis who require long-term anticoagulation? In that case, is warfarin indicated? And this was touched upon a little. There's a second part to this also, which says, would you check antiphospholipid antibodies in the acute setting to ensure it's not triple positive? So I think what the question is sort of comes down to, would you check in the acute setting because it could change management and that you might want to use warfarin rather than DOAC upfront?
Like as Dr. Crowther alluded to, this is a pretty controversial area. And so I think you'll get different answers from different people about at what point do you screen people who otherwise don't have another indication like an autoimmune disorder, ITP, lupus, et cetera, for APLA. So I think you get different answers from different people. In the acute setting, in patients who have acute VTE, I don't screen people for APLA. I don't think that the testing, as Lena mentioned, is potentially unreliable. The times when we do sometimes send out the testing is patients who come in with young patients with unexplained arterial thrombosis, because I do think if you have a young patient comes in with an acute ischemic stroke, I do think of finding of someone who's triple positive, they might need to be anticoagulated. And I think, you acknowledge in that situation that the testing results upfront may not be reliable, but the consequences of recurrent thrombosis in the acute setting are so high, and someone who otherwise doesn't have risk factors for stroke. So that's the group that I would typically reserve that for.
Thank you.
Can I ask one more question? Sure. This is about distal DVTs. Sorry. So this is about distal DVTs, and I will confess that this question was inspired by just a comment that I heard made at a similar talk about the precise location of the distal DVT, like so which vessels it's in. So are there data that suggest that some of those distal vessels should be taken, like, or clots in some of those distal vessels, like should be taken more seriously? Like the perineal versus this, like I just heard this expert say, well, I typically regard one as likelier to progress or more serious than another.
We actually looked at that in Cactus as well, because we had included both patients with either truncular vein thrombus, so perineal or posterior tibial, but also patients with muscular vein thrombosis, right, either gastroc or soleal. And there was no actual difference in the outcome rates. So not really, I would say not really. Likely maybe patients with we even looked at patients who would have had both, and there was no clear sign or small sample size, but no clear sign that it would make a difference in terms of progression.
Thank you all. Thank you. Last question.
So last question. Thank you. This is very helpful. I had a question about Thor, because he's like the minimally provoked clot is really where there may be use for thrombophilia testing. And the reason that I ask this is it's been drilled into my training. Same thing is if it's unprovoked, you're going to continue them on long-term anticoagulation. So why bother? But in these select patients, minimally provoked, where it can actually decide whether they are on VTE prophylaxis or not. So if Thor had a high-grade thrombophilia, like protein C deficiency, would that change your management? And if it would, and when I ask about that is when they take long flights, if, would that change your management? And what would you do in that scenario?
Yeah, thank you. So usually the natural anticoagulant thrombophilia is protein C, S, antithrombin. There's usually a strong family history associated with that as well. And so Thor is not likely to be the first person to present with that. Not that he couldn't be the first in his family, but unlikely to be. And so that's why I generally don't do those thrombophilia tests unless there's that strong family history. In terms of recommendations moving forward for things like long flights or other sort of potentially elevated risk procedures or things, you could do a short course of DVT prophylaxis. I mean, I've given my patients 10 milligrams of rivaroxaban to take on their flight to Australia, for example. That's sort of that one-off discussion with your patient. What's their sort of fear of getting another clot, that sort of thing. In terms of long-term anticoagulants for Thor, I would say no, because I want him to make more movies, and being on long-term anticoagulants, he won't be able to do his own stunts. So yeah, but I'm being a little facetious here, but when I have somebody this young, I try to give them the benefit of the doubt that this is provoked, and I probably treat for 3 months, counseling them that their risk of recurrence is higher than the average person who had a truly strongly provoking risk factor.
Thank you.
So thanks, everyone. Welcome back to the afternoon session. Hopefully you all have been well fed. We have a very great session coming up. It's the first for Thrombosis Canada called Rapid Fire.
It's a pilot study.
Oh yes, pilot study. Please do give feedback. It's called Rapid Fire Thrombosis and Primary Care. So you may have noticed that we had sent out a poll asking 19 questions where you, the audience, had chosen what you want to learn about. We have this wonderful expert panel that includes emergency physician Kristen DeWitt, critical care physician Nadine Swan, hospital pharmacist specializing in thrombosis Allison Bond, and Rufero Chitsike, a hematologist with a focus on thrombosis. So Morale here will be helping me with timing, as each question, including any follow-up questions, will get 5 minutes, but when the buzzer rings, we will move on. Hang on, and here we go. So for the first question, we have Allison Bond who will be helping answer this. When should antiplatelet therapy be discontinued in patients requiring oral anticoagulation therapy?
There you go. Okay. So to answer this question, I refer to the AFIRE study, which was published in the New England Journal of Medicine in 2019. It was a multi-center open label randomized controlled trial that was conducted in Japan. It took over 2,000 patients with atrial fibrillation, and they also had either a PCI or CABG within the last year, or had angiographically confirmed coronary artery disease, not requiring revascularization. They were randomized to receive monotherapy with anticoagulation with rivaroxaban, or combination therapy with rivaroxaban and a single antiplatelet. Their primary efficacy outcome was a composite of stroke, systemic embolism, myocardial infarction, unstable angina requiring vascularization, or death from any cause. This was analyzed for non-inferiority, and their primary safety outcome was major bleeding as defined by ISTH. Of note, this study was stopped early due to an increased mortality risk in the combination group. So when we look at the results, the efficacy results are on the left, and you will see that there were fewer events in the rivaroxaban monotherapy group compared to the combination group. When you look at event rates, they're about 4.1% per year in the rivaroxaban group compared to about 5.8% per year in the combination group. So rivaroxaban monotherapy was non-inferior. When you look at the safety outcome, there were fewer events again in the rivaroxaban monotherapy group compared to combination, with an event rate of about 1.6% per year in the rivaroxaban group versus about 2.8% in the combination group. So in summary, rivaroxaban monotherapy was non-inferior in terms of efficacy, but was superior in terms of safety. And we extrapolate this to VTE as well. So if you're looking for a deeper dive, I suggest looking at the 2020 American College of Cardiology Expert Consensus pathway. It has a lot of amazing figures that goes into great detail. It categorizes patients based on indication and what to do with their antiplatelet and anticoagulation therapy. So in summary, in patients requiring anticoagulation, antiplatelet therapy can be stopped for primary cardiovascular disease prevention, and if they've been on anticoagulation for more than 12 months since the most recent PCI or ACS. Of note, if anticoagulation is stopped or if the dose is reduced, then a single antiplatelet medication is indicated long-term. And of note, there will be selected patients who will require ongoing or indefinite anticoagulation and antiplatelet therapy. People with mechanical heart valves who had a high thrombotic risk were not included in the AFIRE study. And so these patients are kind of an exception to this. Also, just a little tip, in patients who are on 2 or more antithrombotic agents, they should be started or continue on a PPI to reduce the risk of GI bleeding.
Perfect. So she was quick. I don't know if there's any follow-up questions. I don't believe I see any online either, so we'll go to the next question. So to present, when should you continue thromboprophylaxis in medically ill patients discharged from acute care? We have Dr. Nadine Swan.
Hi, good afternoon. So with the medical legal consequences, we need to find out from our patients, what are their expectations from us? What is the fear without the extended therapy? And what were their original ideas in persisting on pushing for this extended therapy? So with VTE occurring in VTE related hospital circumstances up to 45 to 60 days after that admission. Patients are wanting to know that they can get value for their money, especially now that we've received the extended coverage for DOACs after the pandemic. So there should be no inequity with costs and access to it. So patients want what they've proclaimed for and campaigned for with the DOAC. Also understanding nowadays that our lengths of stay in hospital are anything less than 3 to 10 days. So those extended risk factors remain the same for many outpatients: continued age, continued cancer treatment, perhaps continued indwelling catheters, as well as the immobility. So we can understand the rationale behind it, but yet when we're having a look at the validated risk assessment models like IMPROVE, they did great with external validation and showed really good discrimination for medical inpatients at admission. But with the continuum of care for discharge, it didn't help us with decision-making and who should get that thromboprophylaxis. So additionally to that, then looking at systematic reviews with Exclaim and enoxaparin, as well as Adopt with apixaban, and then Magellan with rivaroxaban in inpatient versus extended thromboprophylaxis. The outcomes showed extended prophylaxis having a relative reduction in DVT and mortality, but not an absolute effect, being only 0 to 3 fewer per 1,000 in the DVT. And then having a look at a potential increase in risk for bleeding, that was pretty much the same in an outpatient. But then along came the Mariner trial, and Mariner showed us that there was no significant reduction in VTE, and certainly no reduction with the rivaroxaban in mortality in that extended prophylaxis. So the question is, rather, why not? And the recommendations actually indicate that we shouldn't be continuing with it. Yet we'll still get there. Well, when can we do that? I think our answer to that would be when researchers are able to provide us better absolute reduction, and perhaps with better electronic data circumstances, or with a different DOAC or a different dose yet. So at this point in time, I would extend to your colleagues and patients this graph in evidence that it is good for inpatient and not extended thromboprophylaxis. So remain on the fence. Do not do it despite the push from your patient and colleague. Perhaps the sun has set on this question, or for researchers, has the sun risen for you yet?
Wonderful. So again, we're doing this rapid fire. So any follow-up questions? If not, we are going to be moving on. So question number 3, what patients with pulmonary embolism can be treated in the outpatient setting? We have Dr. Kirsten DeWitt who will be answering.
Good afternoon. So I work in the emergency department, and we send people home all the time in the emergency department. And that's probably what we're most specialist at, deciding who's safe to go home. But researchers have already validated 2 different scores or decision rules to decide for us as to whether a patient could be safely treated at home with pulmonary embolism or whether they need to come in to the hospital. So these are the 2 scores, the Hestia score on the left and the simplified PESI score on the right. And the really interesting thing for me, if you look at the items in the scores, is they're very different. So the PESI score on the right has the typical heart rate, blood pressure, oxygen saturation, signs of severity, which of course we're going to take into consideration, but it has a hard age cutoff, a history of cardiac or respiratory disease and cancer, interestingly. And the Hestia on the left has a whole bunch of other things, including a history of HIT, which is somewhat outdated now, creatinine clearance less than 30 mils per minute, which is also somewhat outdated now, and some other more common sense things like they need to come in for IV pain medications, they need oxygen, or they're hemodynamically unstable or need an embolectomy. So I find it very interesting they include very different items. We do have a a single RCT, which was performed in France and published just last year, the home PE trial, and it actually compared the performance of both of these scores. And what I find really interesting on their infographic, which I took right off of their paper here on the left-hand side of the slide, is that although the SPESI score would have allowed them to send home more patients than the Hestia score, in fact, there were exactly the same proportion of patients who went home if they were assessed using the SPESI or the Hestia score. And what that tells me is that emergency physicians are used to using some shared decision-making and some common sense variables, which may or may not appear on these scores. So obviously, if your patient is at risk of hemodynamic compromise, so they're tachycardic and their blood pressure is a little soft, although not under 90 systolic, you're probably going to admit them into hospital. That's common sense. There are some controversial items on these scores, such as cancer. I certainly don't treat my cancer patients as inpatients unless they have other reasons. Pregnancy, HIT, creatinine clearance, liver impairment, and also developing VTE while they're already on an anticoagulant. Many of these patients could probably be managed at home. And then there is completely understudied or unstudied items, which we use all the time in the emergency department, like frailty, risk of falls, support at home, the risk of bleed overall in the coming few days, and the ability to mobilize safely around their home. So just to say that by all means, you could use either the Hestia or the SPESI to document that a patient's safe to go home, but you also have to have some common sense in there that the patient's also safe to go home for all the other reasons that they might not be safe for. And this is always on the remit that you have rapid access to reliable outpatient follow-up. Happy to take any questions.
I don't see anyone getting up. I also don't see anything online, so thank you. Perfect. So we're actually getting through this very well. We have question number very rapid. So number 4, can I give estrogen therapy again after a DVT or PE, whether or not it was estrogen or non-estrogen related? Dr. Allison Bond, please.
Okay, so to answer this question, I refer to a post-hoc analysis of the Einstein DVT and PE study done by Martinelli, published in Blood in 2016. And so it took around 2,000 women who were treated for acute PE or DVT. They were, of course, treated with either warfarin or rivaroxaban, and looked at those who were on hormonal therapy and those who were not on hormonal therapy and at their risk of recurrent VTE. In women who were on hormonal therapy, their event rate of recurrent VTE was around 3.7% per year, versus those off of hormonal therapy, their event rate was around 4.7% per year. And this was not statistically different. Also, more recently, there was a systematic review and meta-analysis of 19 studies looking at women who had combined oral contraceptive related VTE events, who stopped anticoagulation and their combined hormonal contraceptive, and looked at their risk of recurrent VTE. And they found that their risk of recurrent VTE was very low and was in fact lower than those who had an unprovoked VTE event. So in those who had a COC related VTE event, their rate was 1.22 per 100 person years versus 3.89 per 100 person years in the unprovoked. So in summary, if women are fully anticoagulated, hormone therapy does not increase the risk of VTE, and hormone therapy does not need to be stopped if women are taking full dose anticoagulation. Another important point is that if you stop hormonal therapy in women who are on anticoagulation, this could cause some possible harms, including an increased risk of unwanted pregnancies, and if they become pregnant, an increased risk in fetal anomalies. Also, if women are taking hormonal therapy for menorrhagia and you stop their hormone therapy, you increase the risk of experiencing worsening menorrhagia. The risk of recurrent VTE in people who had a provoked event that was not hormone related and are not on anticoagulation, if you wanted to start hormonal therapy in them, that requires a risk benefit assessment and discussion individualized to that patient. If this is something that you're further interested in looking into, I suggest you check out the Thrombosis Canada podcast called Clot Conversations.
they actually discuss the study that I mentioned in my last slide, and would be a great resource if you're interested.
Perfect, thank you. We are really going through these quickly, so perfect. Clear as mud, okay. So question number 5. We have Dr. Rufero Chitsike who will be answering, how do I interpret the antiphospholipid antibody blood tests?
Right, thank you. So I'm going to attempt to answer this question in 2 to 3 minutes, which is, could spend the whole afternoon on this question. Okay, so this is a typical antiphospholipid antibody screen, and 1 or 2 simplifications. The first point is that the INR does not tend to be elevated in patients with the antiphospholipid or antiphospholipid syndrome. The next thing is the PTT. So the PTT sometimes is elevated in patients with the antiphospholipid syndrome because the way that the lupus anticoagulant works is that it inhibits the test, and so you get a prolonged PTT. So 1 or 2 things that can be done, a preliminary test, you can do a 50-50 mix. So you add 50% normal plasma to the patient sample and you repeat the PTT. And if it fails to correct, it's telling you that there must be an inhibitor that's preventing the test from being completed in the normal range. So the next thing that you might see is a lupus anticoagulant PTT, which is a PTT that is sensitive to the antiphospholipid or the lupus anticoagulant. And this will often be prolonged, typically in patients with the antiphospholipid antibody syndrome. And they've got, or should I say, antiphospholipid antibodies who have a prolonged PTT. Then you can run an insensitive PTT, a lupus anticoagulant PTT, and the reagent used is insensitive to the effect of the lupus anticoagulant. So you should see a shortening. And so that is giving us a clue that this patient could well have a lupus anticoagulant. Now, that alone is not a diagnostic criteria, a laboratory diagnostic criteria for the antiphospholipid syndrome. And so one would need to progress in the testing to do a lupus anticoagulant DRVV normalized ratio or a lupus anticoagulant SCT, that's a silica clot time normalized ratio, with a DRVV standing for the dilute Russell Viper venom time. So what these tests do is that they produce a ratio that takes care of some of the complicating variables. It uses an algorithm. So then when it produces the ratio, ultimately it's telling you that this is more significant or is not likely significant depending on the range. So you'd want to see an elevated lupus anticoagulant DRVV or SCT normalized ratio to consider this as significant. The next thing that you can do is you can do an anti-cardiolipin antibody, and you look at the IgG and the IgM. You can also do the anti-beta-2 glycoprotein 1 antibody, IgG and IgM. We did hear some comments about that a bit earlier, but as per the current diagnostic criteria, these are the tests. And so these are the tests that can be done. The IgA is not considered as a significant antibody for the laboratory diagnostic criteria of the antiphospholipid syndrome. Okay, so there are a few pitfalls. The first is that the antiphospholipid antibody can be transiently positive during infections, often viral infections, but it can be transiently positive. And then not every positive antiphospholipid antibody test is of clinical significance. The next thing is that you can get false positive lupus anticoagulant results in patients on the direct oral anticoagulants, but also on warfarin and heparin. And there may be interlaboratory variation in reporting. So you might want to run this by somebody who has some experience in interpreting these results for tricky cases especially. So if at least you have one of the lupus anticoagulant, anticardiolipin antibody, or the anti-beta-2 glycoprotein 1 antibody, and the cutoff is usually above the 99th centile. You can use above 40 as a surrogate for the anticardiolipin antibody. That needs to be persistently positive at 12 weeks apart. That constitutes only the laboratory criterion for the antiphospholipid syndrome and does not confer a diagnosis in and of itself. In order to then make a diagnosis of the antiphospholipid syndrome, you would need to have a positive clinical criterion, which would be a thrombotic event with a venous, arterial, or in some cases, small vessel on histopathology. And that would make a diagnosis of the antiphospholipid syndrome. And if you have obstetric clinical criterion that are positive, plus a positive lupus anticoagulant antibody, then you'd have a diagnosis of the obstetric antiphospholipid syndrome.
Wonderful. Oh, good questions. Go ahead.
Thank you so much. I have a question about specifically anticardiolipin. If you're asking for these antibodies in the right clinical context and you have a clinical criteria for antiphospholipid syndrome, whether thrombotic or obstetrical, and you have a result for an anticardiolipin, let's say IgG, that is above your laboratory cutoff criteria, let's say between 14, but below, above 15, but below 40, is your clinical practice to repeat that test or to consider it negative per Sapporo criteria and stop the investigation?
I think it would depend on my level of clinical suspicion. So I'd look at everything else. I'd look at the clinical details. And if I was really concerned, I might want to repeat the test. But if it's just a spurious, that's the only result, which is what you sometimes find, I'll probably have a lower index of suspicion.
Thank you.
Thank you, Rufaro. Do you make any difference between IgG and IgM for anticardiolipin antibodies and anti-beta-2 glycoprotein 1 in your practice?
Yeah, great question. So the IgG antibody has got a greater association to thrombotic events compared to the IgM. But I would still use both of them as positive, but recognizing that.
Can I pick your brain for something?
Yeah.
So let's say that you have a level, we'll take anticardiolipin antibodies and it's 45, and then you repeat it 12 weeks apart and it's down to 23. What do you do?
So the key word here is a persistently positive lupus anticoagulant. So because it's spurious, it can be positive at a time and then negative later. So I'd want to, the true patients with the antiphospholipid syndrome, usually there really isn't much opportunity for it to become negative. That's kind of how I approach it.
Awesome. Thank you. Oh, sorry, we do have one. We have time.
Does it have, I have lots of questions. Does it have to be about lab, or can I ask my most pressing clinical question about the antiphospholipid antibody syndrome?
Whatever.
So I'm just wondering, most of the studies that have shown us that warfarin is better than a DOAC in these patients are for like triple positive or high risk. So in somebody who just has one thrombotic event, but persistently positive, 1 or 2 laboratory criteria, so they're not that like ultra high risk lupus anticoagulant or antiphospholipid antibody patient. So hypothetical, persistently positive anticardiolipin patient and a history of thrombosis. Are you using DOACs in those patients, or are you extrapolating from those high quality studies and committing them to warfarin?
Yeah. So I think we've got very good evidence for the triple positive antiphospholipid antibody patients. For the patients who have a single positive, there isn't as much evidence, and it is a very controversial area. Very controversial. I've heard very respectable people saying very different things. But if you look at the observational data that's coming out, there's more and more observational data that comes out. It seems to be trending in my reading of the literature to say that these patients tend to do better on warfarin than the DOAC. So I'll still go with warfarin.
Wonderful. I'm glad that generated a lot of discussion. So, number 6. What are the indications for dose reduction of the DOACs in atrial fibrillation and VTE? Dr. Nadine Swan.
Right. I'll preface it by saying for some of the DOACs, we need to be really mindful of weight. So in our special populations like bariatric surgery, we may need to include a consultation and check in consistently with the patient's measurements on weight. The most landmark trials actually excluded creatinine clearance, advanced age, and obesity in their studies. But edoxaban with Hokusai VTE was able to dose titrate the whole time, considering the creatinine clearance and looking at patients' weight. So that is certainly one DOAC that you would be looking at a dose reduction to 30 at any point in time of treatment. Considering rivaroxaban and apixaban in their trials with Einstein Choice and Amplify Extend, we want to know that they actually only continued their studies for a 1-year period. Also, at that point in time, we had a look at understanding that those studies did not specifically power them against looking at a standard dose versus a low dose directly. So there's room for further research in that area. And then once you're at your clinical equipoise after the acute treatment phase, then we can have a look at individualizing your patient plan, considering potential for teratogenicity and change in bleeding risk profile, and certainly that patient's preference with lowering the dose. And anyone with an unprovoked DVT or VTE event PE is eligible, particularly then men and women with the HER2 score of 2 and higher. But in today's DOAC age, there is less clarity with those predictive models with the D-dimers. So unless your patient is a recurrent VTE on that low dose already, or has a high risk thrombophilia or an active cancer, make sure you're doing a patient personalized plan for them and consider lowering your DOAC with the VT after the acute phase treatment. This would be a picture slide again that you would use in conversation with your patient or your colleague in deciding about that lowering dose. As far as atrial fib goes, well, most again, landmark trials excluded your patient with that decreased creatinine clearance other than ENGAGE. And for each DOAC, you want to ask about the patient's age, considering that they're going to continue on this long term and what their lifespan is going to be, having them weigh in routinely, and their clearance factors, both hepatic and with kidney functions. So with apixaban in particular, 2 criteria have to be met with age, weight, or creatinine rather than necessarily the eGFR. In dabigatran, certainly with Beer's criteria flagging dabigatran, you want to have a look at age over 75. And rivaroxaban, your dose reduction immediately with your change in creatinine clearance. So make sure you're having a look at up-to-date creatinine or renal panels. And with edoxaban, any one of the criteria of creatinine clearance 15 to 50, weight again less than 60, or strong PGP inhibitor. Bearing in mind here, interestingly enough, amiodarone is not on that list with edoxaban. But the other PGPs, for example, commonly used clarithromycin and ketoconazole are. So an image I would want to leave with you in when to DOAC dose reduce is the ABC. So for VTE, the age of the clot after your acute treatment, your patient's bleeding risk and body weight, and creatinine clearance. For atrial fib, age, again, your bleeding risk and their body weight. And remembering in some of your DOAC, you have to have more than 2 criteria and creatinine clearance. So let's do baby doses, balancing the blocks of ABC.
I love that. Thank you. Oh, there may be a question. No. Okay. All right, we'll go on to the next one. So number 7, how do I interpret a follow-up ultrasound scan after a prior DVT? Can I use it to discontinue anticoagulation therapy? Dr. Kirsten DeWitt.
Thanks. So this is an ultrasound scan, and it shows the only thing that you will see if you do a routine follow-up ultrasound following deep vein thrombosis. It shows a chronic thrombus, which is essentially an old clot, which is mostly fibrin, is unlikely to grow or change size or shape. And this is actually a large chronic thrombus, and it was actually a picture taken of one of my patients who'd had symptoms of PE and DVT for months and months before he was diagnosed. It's generally speaking not so helpful for us to know whether the patient has a chronic thrombus on ultrasound or not. And we're much more interested on whether a patient has post-thrombotic syndrome. So I do get a number of patients referred to clinic because their physician, their specialist, or their family physician has done a follow-up ultrasound and is concerned because the clot that they were diagnosed with a year ago or 2 years ago still seems to be there. But of course, it's not an acute thrombus, and it's not going to change in shape or size unless the patient has not been appropriately risk stratified for recurrence. So the only time usually that I would order a follow-up ultrasound is if I'm going to be stopping anticoagulation or making a drastic change to the anticoagulation. So we have what we call a baseline ultrasound. So in the future, when the patient's worried they've had a recurrent DVT and they attend the emergency department and one of my emergency colleagues doesn't check the D-dimer or they haven't used the Wells score and they go straight ahead and order an ultrasound, we have a previous ultrasound to compare it to. So we know, is this chronic thrombus? Is that just exactly what was there 2 years ago? Or is this something new? So if we want to decide about length of anticoagulation or long-term anticoagulation, it would be much more helpful to use a clinical decision rule. And here in Canada, we have the HER2 rule. There's a variety of others as the DASH rule, the Vienna rule, whichever one you want to use. But as you all know, the HER2 rule, they say men continue and HER2, so most men with unprovoked DVT would be offered long-term oral anticoagulation, and women would be risk stratified according to this rule. I would never use the results of the ultrasound to make that decision any different. I would simply use a clinical decision rule. I'd be happy to take any questions. Hi, Amy.
In the case of provoked DVT, do you ever use a 3-month ultrasound? Like if you see there's some residual, but say the patient doesn't have, but their symptoms have resolved, would that ever change whether you continue to the 6-month or just stop at that 3 month?
No, I actually tend to use the symptoms. So if they have really bad PTS, I would continue longer. If their leg looks great, I wouldn't worry at all. But I do a baseline ultrasound, even though we don't think it's likely that they'll have a recurrence because it was provoked. Often these people are really anxious and they're the ones who come back to the emergency department and end up getting the scans. So I'd still do a baseline ultrasound. Thanks.
Perfect. I don't see any questions online, so thank you. All right, moving along. Number 8. Is there any indication for monitoring of anti-10A levels in pregnancy? Dr. Rufaro Chitsuke.
Right, thanks. So the first thing to note that's important is that pregnancy alters low molecular weight heparin pharmacokinetics. So in pregnancy, there's an increased plasma volume and an increased glomerular filtration rate, and that changes the volume of distribution of low molecular weight heparin. The anti-10A test can measure the anticoagulant effect of low molecular weight heparin. Now, we do know this as well, that pregnancy alone is not an indication for low molecular weight heparin anti-10A testing on a routine basis, because there's no good data to show an association between routine anti-10A monitoring in pregnancy and clinical outcomes. We do also know that the American Society of Hematology guideline in pregnancy recommends against routine monitoring of anti-10A levels in pregnancy to guide dosing. However, there are some subpopulations that might potentially be at risk. So patients with severe renal impairment may potentially be at risk of accumulation of excessive low molecular weight heparin. Patients who have a very low body weight may be at risk of overdosing. And patients at the extremes of obesity who who have a very high thrombotic risk, for example, patients with mechanical prosthetic heart valves, and those with recurrent venous thromboembolism while on anticoagulation therapy may be higher risk patients. So while we know that there isn't any room for routine monitoring of anti-TNA levels in pregnancy, is there any indication for monitoring of anti-TNA levels in pregnancy? Yes. Testing can either be indicated or can be considered in a few scenarios in pregnancy. These are patients with mechanical prosthetic heart valves, severe renal impairment, significant extremes of body weight, and patients who have had recurrent venous thromboembolism despite anticoagulation therapy.
All right. Any follow-up questions for that? I also don't see any online. However, you are up for the next question. So we are moving along beautifully. How soon does oral anticoagulation therapy need to be switched to low-molecular heparin once pregnancy is discovered?
Okay. So the first thing that's important to note is that oral anticoagulants cross the placenta, whereas the heparins do not. So warfarin and the direct oral anticoagulants cross the placenta. Low molecular weight heparin and unfractionated heparin do not cross the placenta. We've been using them safely for pregnancy or in pregnancy for decades. And of these, low molecular weight heparin is preferable. The next thing that's important to note is that warfarin exposure from 6 weeks gestation is associated with teratogenicity. The highest risk is between the 6th and the 12th week. Later in pregnancy, particularly around the time of delivery, because of the immaturity of the fetal coagulation factors and the trauma of delivery, potential trauma of delivery, the fetus may be at increased risk of cerebral hemorrhage, which may be fatal if the fetus is exposed to warfarin therapy. And there are some reports of adverse effects on the CNS, development of the CNS of the fetus, if there's been warfarin exposure at almost any time during pregnancy, or should I say beyond the 6th week. So the direct oral anticoagulants, the most important thing to note about them is that we do not have enough data to say that these drugs can be used safely in pregnancy. Now, there have been 2 observational studies, retrospective studies that have looked at this. And from this, we found that the embryopathy risk associated with the direct oral anticoagulants appears to be small. However, it cannot be excluded, which means that DOACs are not regarded as safe in pregnancy. Notwithstanding this, DOAC use is not regarded as medical grounds for termination of pregnancy. So, how soon does anticoagulation therapy need to be switched to low molecular weight heparin once pregnancy is discovered? For the direct oral anticoagulants, it should be switched immediately, as soon as pregnancy is discovered. For warfarin, it should be switched to low molecular weight heparin as soon as pregnancy is discovered and before 6 weeks of gestation. Thank you.
Oh, looks like there might be a question.
Thank you, Rufaro. I'd be question I have all the time, and I would be interested in what you do in your practice. So when the pregnancy happens unexpected, it's easy. But let's say that, you know, a young woman wants to become pregnant. She's on long-term DOAC, and this may take a few weeks. It may take a year or 2 years. Do you keep them on the DOAC until they know they're pregnant, then you switch them? Or do you do like what the SSC suggested, which is switching them to low molecular weight heparin long-term, which could be costly and parenteral, or warfarin until they're pregnant, then you switch them to low molecular weight heparin? What do you do in your practice?
So, yeah, this is a very difficult question. It's not an easy one to answer, and it requires a discussion with the patient and looking at their values. Not many women, I'd say, are willing to be switched to warfarin, even though we know that we can give warfarin as long as it's stopped before 6 weeks of gestation. The problem with using parenteral therapy like low molecular weight heparin is that it may take a long period of time. So it depends on what the patient's preference is. If they're prepared to, for example, wait for however long it takes to fall pregnant. It would depend on the discussion with the patient. It's so hard because we don't know the effect of the direct oral anticoagulants before 6 weeks. So yeah, I'd agree. There isn't a one answer that I'd give it. It just depends on.
But have you, after having a discussion with patients, did you have patients that willingly would continue DOAC and then become pregnant and very vigilant to do testing for pregnancy and then switch at that time?
I don't actually remember having too many of those discussions, to be honest. Usually what happens is it's a consideration when
for myself.
It's a consideration when the consult is sent. And usually it's the patient is already pregnant. So it's not that typical. But it's just once or twice I think I've had that conversation. So it's yeah.
Thank you.
Thank you.
And we also have a question from the online participant. They want to know a bit more about if a patient is pregnant, but also has a mechanical heart valve. How do you manage the warfarin?
Right, another extremely controversial question. So we know that exposure of warfarin in pregnancy between 6 and 12 weeks is very well documented to be associated with teratogenicity with warfarin. Beyond 6 weeks is a more difficult question to answer. So there have been studies that have looked at exposure of pregnant women to unfractionated heparin or getting them to use unfractionated heparin for their mechanical prosthetic heart valve throughout pregnancy, and there were treatment failures and maternal valve thrombosis and fatalities. So we know about that. And then we also know that when patients have been given low molecular weight heparin with a flat dose throughout pregnancy without monitoring and adjusting based on anti-10A levels, that there have also been treatment failures and maternal deaths. So we know about that. And we know that warfarin is very efficacious for this indication if continued throughout pregnancy after the 12th week. So there are some authors that will suggest switching back to warfarin. There is some data. It's not very good data, but there is some data that has shown that if you use low molecular weight heparin throughout pregnancy with adjusting the anti-10A up to the peak anti-10A for that particular manufacturer's anti-10A level. So often it's an anti-10A between 1 and 1.2 is what we'll often use 3 to 4 hours with a blood taken 3 to 4 hours post dose to get a peak anti-10A. And that is continued throughout pregnancy. That has been shown by a number of studies to have resulted in safe deliveries. So maintaining both safety for the mother and for the developing baby. But that's it is an area of controversy.
For sure. Perfect. Thank you so much.
Thank you.
We probably have time for 1 or 2 more of these rapid fire questions. So Dr. Nadine Swan, what are some considerations for patients who have epilepsy and VTE?
So as a rapid response team member, we often run out to our hospitalized patients having a syncopal event or a seizure. 1 in 6 of those hospitalized patients land up actually being a PE. And then in other cases, our younger female patients are presenting a seizure, but actually have the cerebral vein thrombosis as well. Right. So bearing in mind that our primary treatment for those patients are anticoagulation and not seizure medication, we also have to balance the whole idea of when does that seizure occur again? And if it is outside of the acute treatment phase, we may actually have to introduce the two drugs together with your DOAC and your anti-epileptic medication. We also have to pharmacologically now bear in mind that your anti-seizure drug has the side effect of hematopoietic suppression, and your DOAC has your anticoagulation bleeding risk. So this is the typical chicken and egg scenario. If that patient was seizuring and they're having an intracranial hemorrhage, is it as a result of your seizure injury that's caused the bleeding, or our bleeding risk because of our anticoagulation and adding your anti-epileptic drug side effect? So all about balance again. So in these situations, most of our data, unfortunately, is in vitro and case studies. We need more evidence. So in practicality, the reality is those preferred anti-epileptics are not our routine drugs that we find in family medicine practice. So how do we approach it in that sense? Well, we've got to bear in mind then that your DOAC is being induced, or rather metabolized a little bit faster by your CYP450 system. And if you're going to try and add another intestinal absorption situation with the PGP absorption or the substrate efflux, we're really running into a situation where we also might have to be monitoring drug levels. Choosing Wisely Canada is saying we're not supposed to be monitoring anti-epileptic drugs routinely, and it isn't our routine practice to do anti-10A levels neither. So perhaps it would be wise in these circumstances to be monitoring an INR. It leaves you with a little bit of food for thought, and at this point in time, the guideline merely says caution when prescribing. So I'll leave you with the tweetable answer of which comes first, chicken or egg in this situation.
Wonderful. So Dr. Carey, do you have a question? Okay. Sorry, you might have to come back up.
I know I'm a pain, but I just wanted to pick your brain on something. So you mentioned that there's some drug-to-drug interaction with the CYP3A4. How do you feel about certain anti-seizure medications that are used frequently, like phenytoin, darlantin, with like the bigoteran or edoxaban, where they're more dependent on glycoprotein P, so that it's not, the interaction is not as strong? Do you use that in your practice every now and then?
Not routinely in my practice, and perhaps I would defer the answer to refer in the situation, but I think our safer drugs would rather be the levetiracetam.
Wonderful. So we actually got through 10 different topics in this rapid fire session. So big round of applause for our panelists.
Welcome back, everybody. So we're nearing the end of today's meeting, and we're going to have 3 fairly short talks, and we will take questions directed at all 3 talks at the end of the 3 of them. So our first speaker will be Ryan Kirzner, and his talk is titled Weighing the Evidence, DOACs in Extremes of Weight. Ryan Kirzner is a clinical pharmacist working at the Jewish General Hospital in Montreal since 2008. And so with that, I'd like to welcome him to the podium.
Is this on? All right. So thank you, everyone, and thanks for the invitation to be here today. So we're going to get right into it because time is a bit short. I guess oh, wait. No. Oh, how do you? Oh, there we go. All right. So these are my disclosures. And today we're going to talk about, well, I'm going to start off by saying, so I'm going to be talking about the use of DOAC specifically in patients with extremes of weight. And I'll start off, and I probably shouldn't admit this at the beginning, but I'm not going to have all the answers. And sometimes there's certain situations where we're not really going to exactly know what to do. But I'm going to at least give you the information that we do have and that we can kind of use our clinical judgment to make the best possible decisions for our patients. So I'm going to start with a case. This is a 62-year-old lady with breast cancer. She was admitted with a mastectomy, and it was complicated by a DVT while she was in the hospital. So for medications, she takes some blood pressure pills, some diabetes pills, and some tamoxifen, none of them which interact with DOACs, just to be nice. And she has a normal renal function, but she is 135 kilos with a BMI of 44. So initially, she's treated with low molecular weight heparin, sent home with follow-up in the thrombosis clinic. And then, we sort of wonder, can we use a DOAC for this patient? Here's a second one, a 55-year-old with new onset AFib, known for hypertension and some prediabetes. He's on several antihypertensives, but this gentleman weighs 177 kilos with a BMI of 62, normal renal function, but he absolutely refuses warfarin. He had family members who are on it and hated going for the INR testing and all that fun stuff. So he's like, not happening. And the question is, can we use a DOAC for this patient? So obviously, obesity is something that's been on the rise worldwide. Here in Canada, especially over the last 30 years, we've seen a threefold increase. And it's really associated with a significant health outcomes, healthcare costs, and quality of life concerns. Now, one thing that's interesting, obesity itself is a very important risk factor for both atrial fibrillation and for VTE. And just for time's sake, we're not going to go all the details, but it's basically a population that, might require more and more these types of medications, and yet we don't really know how to use them. So we'll get into that. And just a quick word, also say patients that are underweight as well have a higher incidence of AFib, not the case for VTE. So when we talk about general pharmacokinetics, and if we're looking at the four main PK parameters, so in terms of absorption, basically minimal changes. Distribution, that's probably the more important one because we get changes in volume of distribution of the medications based on many different factors, and we'll talk about that. Metabolism, there are some variable effects as well, and same with elimination. Generally, with the long-term, patients tend to have quite a faster decline in their renal function in the more obese populations. So the bottom line is really you get this variable PK effect. It's still a very heterogeneous group as well. And there's different levels of obesity, different fat, adipose tissue composition and things like that. So it's not exactly one exact category of patients. Very limited data on the best possible management. And as we know, the obese and the very underweight are very often excluded from the big trials. So when the DOACs first came out, they came out as a sort of one size fits all. We do know that the effects are generally, they're quite influenced by levels of plasma concentration. So with obesity, we end up really noticing an increase in the volume of distribution of the drugs. So you get basically more drug going into the tissues, less drug available in the circulation. So a possible underdosing and therefore a possible decrease anticoagulant effect. In the underweight patients, the opposite, where you can get more potential exposure and more anticoagulant effect. And that's what we worry about with these patients. So if we look at our RCT data, and this is a summary of the 4 big AFib trials that all use the DOACs versus warfarin as a comparator, and we could see that there's sort of different definitions that use weight or different weights or BMIs. And we could see that basically, and especially for the ones that concern us the most higher weight, especially BMIs over 40 or weights above, let's say 100, well, we don't even see them there. It's a very small percentage of the patients that were actually in the overall population of the trials. Overall, we know that CVA outcomes were generally the same when we compare this to the other weight patients, and bleeding outcomes were generally the same as well between the DOACs and warfarin as well, a slight difference with apixaban. When you put all these together, the top graph, this was a meta-analysis of those 4 trials, and we see the top graph is the underweight patients, and we see that still with this one, it kind of favors to the left, it favors DOACs versus warfarin in the patients with BMI less than 20. And the one that's circled on the bottom, those are the BMI over 30, the obese patients, and we see DOACs are just slightly favored over warfarin as well. With VTE, and I'll just say there was a little error on the slide. I realized that after I'd submitted the slides, there is data, there is a subgroup analysis of Amplify and for the apixaban data as well that wasn't included here. We have a lot less data than we do with atrial fibrillation, but in general, from what we do have with apixaban and rivaroxaban, efficacy was maintained and no big change in terms of bleeding. Now, when we look at a meta-analysis of the VTE trials that was done, in terms of VTE recurrence, we could kind of see on the top graph that it pretty much evenly crosses the one there. No difference in terms of VTE recurrence and no difference in terms of bleeding. So a lot of our data actually, so we don't have that much data from the big RCT. What we do have is a ton of observational trials, and there's so many of these that have been published. I chose one, and it's sort of graphically, I know they're a bit small, but just to point out basically what they did, this was a single center, but it was like 36,000 patients that were analyzed. And they kind of divided patients into 4 BMI groups. So BMI group 1, the ones on the left of the graph, are the BMI less than 18.5. Group 2 is 18 to 30, group 3, 30 to 40, and group 4 is over 40, BMI over 40. And what we could see is that for all of the major outcomes, so ischemic stroke, bleeding events, and all of the other ones as well, the DOACs were always better than warfarin in terms of all of these outcomes. And this has been replicated in many, many different observational trials. When we look at other meta-analyses and systematic reviews for the atrial fibrillation data, we see on the top left, that's obesity class 1, then we have class 2 BMI 35 to 40, and the one on the right is BMI greater than 40. Absolutely no difference in outcomes for stroke or for bleeding events. So, and there's a lot of this that sort of keeps coming back. In this paper also, they looked at the underweight group, and just to say there was no differences as well. When we look at a meta-analysis and systematic review of the VTE data, now a lot of this was more, these were observational trials that were sort of grouped together. And we see, it's a bit hard to see it, but on the graphic, there's basically, again, no difference. And this is patients above 120 kilos or above a BMI of 40. Again, no difference in efficacy between warfarin and the DOAC comparators. So the product monographs themselves, they sort of summarize, and they're pretty much between the 4 drugs, the data is quite similar. Basically saying is that in patients who are obese, like once you go to a weight above 120 kilos or a BMI of 40, you kind of get a decrease in exposure by about 20 to 25%, and for underweight, the opposite. And this is kind of consistent without them. And we know DOACs generally, they don't really have a narrow therapeutic index, so we do have some room to maneuver. We know that, for instance, with certain drug interactions where like amiodarone or diltiazem, that might increase DOAC levels by 20-ish%, and it's still considered safe to give. And so that's basically the data that we have. Now, in terms of guidelines, the ICH, they have the newest sets of guidelines. These came out several months ago now. They updated a 2016 version. So basically they're saying, and this is specifically for VTE, is that patients who have a BMI of up to 40 or a weight up to 120, you're absolutely safe to use DOACs without any worry. And I think there's quite a bit of data to back that up, and I definitely agree. Then they say for patients who are above 120 kilos or above a BMI for 40, they're saying that for VTE, apixaban and rivaroxaban can be safely used regardless of the weight or the BMI. There's a lot less data. They also go on to say there's a bit less data for, well, we don't use dabigatran really for VTE. And for edoxaban, there was not as much data available. So they said, more, and most of the data actually does come from rivaroxaban. They also make a comment about not doing drug-specific, like peaks and troughs basically of DOAC levels to target that, and we'll talk about that in a sec. Thrombosis Canada, this is their recommendation, basically saying that for patients who have a BMI between 30 and 40, that pretty much DOACs are safe to use. And that above 40 or a weight above 120 kilos, patients should be informed of the limitations to the available information and potential risk of underdosing. So it's basically saying this is a discussion we should be having with our patients, and I do agree. And just to say, the CCS and the ACC there are no formal recommendations in their AFib guidelines. I'm not going to go too much into this because I know Deb Siegel talked about this morning about the utility of doing drug levels, but basically we really don't know what a true therapeutic target is. So it's kind of, there's that, and they're not always widely available, and even getting the levels done at the right time. So it gets a bit complicated. So I don't generally favor doing levels for these patients. So in conclusion, I'm going to sort of jump into really just right to the conclusion. I'll have a few minutes to discuss this. The data does support the use of DOACs. I think we're all comfortable up to a weight of 120, and I think even 140 kilos, I'm pretty comfortable. But to say that above a weight of 140 kilos that, 141 kilos and 180 kilos are both above 140 kilos. And my approach might not be the same when I look at, these two patients differently. And this is where individualization of treatment comes in. And I believe strongly in number one, there's a big difference between, let's say, a 40-year-old who has a CHAD, or you have a young patient with a CHADS of 1 versus a patient with a pancreatic cancer with a giant PE. And so, you might, where the risk of thrombosis is very different in those kind of populations. And so I think it's something where you have that discussion with the patient, you tell them, look, and I'll be honest, I've seen patients 180 to 200 kilos. We have several patients at our hospital that I've seen on a DOAC for atrial fibrillation. I don't know how many people in this room would be comfortable giving a 180 kilo patient with a cancer-associated thrombosis a DOAC. Personally, I'm not there yet. I have not seen enough to make me feel comfortable to do that. So, I think it really should be looked at on a case-by-case basis. This is the information we have, and sort of, and that's why I think the importance of individualization. Definitely in patients, especially with lower weight, you want to make sure you're attenuating the bleeding risks, looking at drug interactions. Are they on antiplatelets? Are they even on SSRIs and things like that that can increase bleeding risk? And really choosing your patients wisely on who can safely get one of these treatments. And patient education is the key as well. I think making sure our patients understand the risks and and what to look out for and things like that. Going back to the cases then. So in our first lady, the lady with the cancer-associated thrombosis, who has a weight of 135 kilos, I'd be very comfortable giving her a DOAC, I think, with proper monitoring. And I think that would be appropriate. With our atrial fibrillation patient, now he's absolutely refusing warfarin. I think if we explain to the patient, look, these are the risks. I cannot guarantee, that you might be slightly more at risk of having a stroke, but if you're willing to take that risk and, and have that discussion, I think that's reasonable, and I very much believe in that joint decision-making between the patient and the healthcare provider. And with that, I will end it and pass it on to my next colleague. And if there are any questions at the end, it'll be my pleasure to help you guys out.
Thank you. Our next speaker, Dr. Vicky Tagalakis, will talk about DOACs and special clots, splanchnic and cerebral vein DVT. Dr. Tagalakis is an associate professor of medicine at McGill University and an attending at the Department of Medicine of the Jewish General Hospital. She's also a division director of the Division of General Internal Medicine at McGill University.
Thank you, Maral, for that introduction. And thank you, Ryan, for really shedding some light onto that very, controversial topic. And let's not forget, if we are giving a DOAC to a 180 kilo gentleman with a massive P, we document accordingly, informed consent, describe the risks and benefits. While I'm trying to here we go. Okay, great. So thank you for inviting me to talk on atypical thromboses, specifically cerebral vein thrombosis and splanchnic vein thrombosis, and the role of direct oral anticoagulants in this area. Also a very nuanced and controversial area, and hopefully we can kind of come together to some sort of understanding as to how we potentially could approach these conditions. So the goals or the objectives of my talk are to provide an overview of the anticoagulant treatment of cerebral and splanchnic vein thrombosis in general terms, and then to describe the potential role of direct oral anticoagulants in the treatment of these conditions, all in 10 minutes. So cerebral vein thrombosis, what is it? It's, well, let's first talk about how often do we see it? We see it in anywhere between 2 to 4 per 100,000 person years in our general population. It is much more prevalent in the young versus the older age categories, and more common in women and men. And that's primarily driven by the fact that there are unique risk factors in this special population. And those are the hormone-mediated type of risk factors, specifically pregnancy, hormone use, and oral contraceptive usage, has a predilection or an association with cerebral vein thrombosis, which is quite interesting and fascinating to me. But that pretty much is an important explanation as to why we do see a higher incidence in the young, particularly in young women. And later on, we do see a catch up in the men, and that's because malignancy now plays a bigger role in the older age populations, specifically myeloproliferative disorders seem to have a predilection in this patient population. And there are various complications or symptoms that patients present with. We can see cranial nerve palsies, motor deficits, altered mental status. They can present with seizures. And that's usually because there is a venous obstruction and venous outflow, which results in significant cerebral edema in many cases, which can then lead to seizures and altered mental status. So cerebral edema is quite frequent, but even equally frequent are intracerebral hemorrhages in these patient populations. Now, these are not your typical intracerebral hemorrhage that we've talked about earlier, that we often see, that we would see with anticoagulation, and usually driven by perhaps a space occupying lesion, amyloid angiopathy, and so on. These are due to their venous infarcts, and that's because there is thrombosis, congestion, edema, and the infarct that results as a result of this can lead to hemorrhaging. So what are the outcomes that we see in these patients? So in about 3/4 of patients, usually it's a favorable outcome with treatment. However, there are complications. These include early death at 4%. Death at 1 year is thought to be anywhere between 7 to 9%. In patients who do survive, there is about 5 to 10% risk of having some sort of disability at 1 year. These could be physical disabilities, such as cranial nerve palsies, for example. But we should also remember that depression, anxiety, and cognitive impairment has been observed in these patient populations. And of course, recurrent cerebral vein thrombosis is also commonly seen at around 2 to 4% within the first year, as well as DVT/P, because a lot of these patients do have prothrombotic conditions that would also put them at risk for your typical clots, such as a DVT or PE. So we aim to anticoagulate quickly when we are dealing with a patient like this. And the goal is to prevent thrombus propagation, restore anterograde drainage, salvage brain tissue from permanent damage, and prevent recurrent thromboembolism. And how we do that, we have an acute phase and a long-term phase. In the acute phase, after we've documented the cerebral vein thrombosis using our different techniques, we start the treatment, and usually it's in the form of low molecular weight heparin or unfractionated heparin. There's little data to support one over the other, but we preferentiate low molecular weight heparin when we can in general practice, generally due to the ease of prescribing this medication and managing it. When they're even in the concomitant intracerebral hemorrhage bleeding, we can use low molecular weight heparin. And we reserve unfractionated heparin usually when there is vast intracranial hemorrhage or there's an anticipation of having some sort of intervention due to impeding problems resulting from the hemorrhage or edema. In the long term, we have to switch. We usually switch to an oral anticoagulant, and that's usually when we deem the patient to be clinically stable. According to the most sort of prominent guidelines in this area, the American Heart Association and Stroke Association and the European Stroke Association, these guidelines, which are from the the most recent guidelines dating from 2011 and 2017, support using the vitamin K antagonists over direct oral anticoagulants. And moreover, they do provide some guidance on duration of therapy. For provoked cerebral vein thrombosis, their recommendation is anywhere between 3 to 6 months. For unprovoked cerebral vein thrombosis, 6 to 12 months, and perhaps indefinitely as well, if there is an associated severe thrombophilia, such as antiphospholipid syndrome or recurrent cerebral vein thrombosis. Well, what about the direct oral anticoagulants in this area? So there are some data emerging. There's probably quite a few small observational studies, and now we're coming into the realm of some some trials. So here we have a small trial. It was published in JAMA Neurology in 2019 by Farrell and colleagues. And I looked at the safety and efficacy of dabigatran versus dose-adjusted warfarin in patients with cerebral vein thrombosis. This was an international study, only 120 patients. It was exploratory in nature, but they looked at patients with cerebral vein thrombosis who were initially treated with unfractionated heparin or low molecular weight heparin for about 5 to 15 days, and then randomized to dabigatran or vitamin K antagonist. And their endpoint was a composite endpoint, and that was either recurrence of venous thromboembolism or major bleeding at 24 weeks. And what they found, is simplified on this graph, was that the occurrence of the outcome was quite low. One case of a GI bleed in the dabigatran group, and two cases of intracranial bleeds in the vitamin K antagonists. So based on this small study, we see that these outcomes are quite low, and suggesting that perhaps dabigatran is a potentially usable form of oral anticoagulation in cerebral vein thrombosis population. Now, this is patients who did not have any evidence of intracranial hemorrhage on their CT scans. So it is a much less comorbid type of patient population, and that needs to be taken into account. What other trials are coming? So stay tuned. We do have a larger trial called the SECRET trial, which is run by Talia Field out in Vancouver, which is looking at rivaroxaban versus vitamin K antagonists. And there's also an international large prospective study called the DOAC CVT study, which is enrolling 500 patients. We should have results at the end of next year. And both studies are looking at a combined endpoint of recurrent VTE and major bleeding. So in summary, the basic principles of CVT treatment are to treat patients in the acute phase with heparin. Low molecular weight heparin is preferable over unfractionated heparin. We generally treat anywhere between 3 to 12 months, and perhaps indefinitely in certain patients with, for example, severe thrombophilia. The guidelines support vitamin K antagonists, but DOACs are increasingly used in practice. I do recommend that if you do venture into using a DOAC, that you use a multidisciplinary approach, especially in patients that have complicated CVT. And using follow-up with your neurosurgeon or your neurologist is quite important. There is really a consideration to think about malignancy and antiphospholipid syndrome patients, where the role of a DOAC, for example, and an antiphospholipid triple positive, for example, would not be recommended. So in the last few minutes, I'll talk about splanchnic vein thrombosis. I know there's a lot of information. So here we have the splanchnic vein thrombi that we're very aware of. Portal vein is the most common, followed by mesenteric and splanchnic vein thrombosis. And the Budd-Chiari syndrome, which involves the hepatic veins, is a much less common occurrence. So here we have the epidemiology associated with these conditions. And to point out, we talked about earlier about incidentally discovered PE or SSPE. We do have an increasing incidence or prevalence of unsuspected SVT. So I suspect that this condition does become more and more frequent in our general practice as we do significant CT scans in some of our patients that present into the emergency room with nondescript symptoms, and we may be picking up these things more and more. Risk factors, I just kind of briefly want to go through this, is that we think of these risk factors as local versus systemic. Local being things like cirrhosis, cancer of the liver or pancreas, or local inflammatory conditions such as peritonitis or pancreatitis. Systemic factors are usually cancer and oral, such as the myeloproliferative disorders, antiphospholipid syndromes, and as well, again, we have a role of prothrombotic, hormone-mediated or pregnancy-mediated role for playing a role in SVT. Outcomes are worse usually than what we see with DVT or PE, and they're listed here with variability according to the type SVT vis-a-vis the provoking factor. So you can see the worst prognosis are usually associated with liver cirrhosis, whether it be major bleeding or thrombotic events or mortality. And patients with transient risk factors, such as those that are taking oral contraceptive pills, usually have less complication rates. The basic principles of treatment here are to improve canalization, especially with portal vein thrombosis, as we do want to avoid portal hypertension, to reduce the risk of SVT extension and recurrence, and even possibly other more typical clots, and possibly to improve survival. So the approach we take here, and I'll just concentrate for the sake of time on the left side of the screen, looking at acute symptomatic or incidentally documented splanchnic vein thrombosis. One of the things that we should not forget is working with our gastroenterologists, making sure initially that there is no suggestion of an increased risk of portal hypertension in these patients, and doing, if needed, endoscopic evaluation to ensure there are no esophageal varices. And if there is, that we should institute appropriate medical prophylaxis or even interventional procedures such as banding of esophageal varices before undertaking any form of anticoagulation. And in the acute symptomatic or incidental splanchnic vein thrombosis, the recommendation, or generally we treat, is we start treatment for 3 to 6 months of anticoagulation, irrespective of underlying risk factors. And then we consider going longer or indefinite should there be any evidence of recurrence, or there's significant underlying thrombophilia, or any other persistent thrombotic risk factor. And the standard of treatment, and the treatment that most often is used in these patients, is to initiate with unfractionated heparin or low molecular weight heparin. As mentioned earlier, low molecular weight heparin being the preferred agent, followed by vitamin K antagonists. And low molecular weight heparin has a role to play as a monotherapy agent in patients with underlying liver disease or significant liver disease, cancer, and thrombocytopenia. What about the direct oral anticoagulants in this area? So we do have a couple of small studies. We have this study by Dr. Agnagno out of Italy, who looked at rivaroxaban for the treatment of non-cirrhotic splanchnic vein thrombosis. And this was an international study, a small study of 103 patients that looked at prospectively the use of rivaroxaban in these patients. And the primary outcome was major bleeding. And as we can see here, looking at the bleeding events, they were low. 2 patients out of the 108 had experienced a major bleed. 4 patients of the 108 experienced a clinically relevant non-major bleed with low rates of recurrence and death. Similarly, there's another study, much smaller. This was a study now looking at cirrhotic patients and non-neoplastic portal vein thrombosis. And this looked at rivaroxaban versus vitamin K antagonists. Again, small patient population, 80 patients, less probably sick patients, meaning that these were post-surgical patients or who had a portal vein infection rather than more extensive disease. And once again, if we look down at the GI bleeding and the PET recurrence, this seems to suggest that the rivaroxaban group fared much better than the warfarin group. And so what do the current guidelines say? And this is my second to last slide. There has been a recent re-looking at the guidelines at ISTH in 2020. We now see that DOACs are included in the management of non-cirrhotic splanchnic vein thrombosis. It is a bit of a surprise to see that being put forth as a first-line type of management for these patients. The panel did indicate that they are very well aware and acknowledge the fact that direct oral anticoagulants are not specifically approved for the treatment of splanchnic vein thrombosis, but nonetheless, you see that they are figuring into the guidelines. The Hepatology Consensus Society also published their guidelines this year. They're still recommending preferably vitamin K antagonists, but DOACs are mentioned as well as being potentially used in this patient population. So in summary, what do I do for the treatment of splanchnic vein thrombosis? So early initiation, looking to control any reasons for the to decrease the risk of bleeding, such as looking with with gastroenterology to ensure that there are no varices and controlling for that. initiating low molecular weight heparin most often, followed by VKA, and using low molecular weight heparin monotherapy for my cancer patients. And given the fact that there is emerging evidence for DOACs, I do feel that there is reasonable information out there or evidence to consider starting using DOACs in certain patients, non-malignant patients, non-cirrhotic, splenic vein thrombosis, where the liver dysfunction is limited to child A or B. We know with rivaroxaban, there is concerns when there is child B cirrhosis, so it wouldn't be my first agent to use. But increasingly, DOACs do seem to play a role in this area. Thank you.
Thank you. Next is Dr. Zach Liederman to tell us about warfarin in 2022, the right choice for select patients in a few situations, some of the time. So Dr. Liederman is a clinician teacher and assistant professor in the Department of Medicine at the University of Toronto.
Great, thank you. Hopefully that title makes a little bit more sense as we go along. Some business slides, so my disclosures. Getting into things. So our outline for the next 10 minutes or so, we're going to focus on warfarin. So I recognize that other vitamin K antagonists exist. Nothing against them, but we're going to keep things simple. There's been a lot of great talks today on DOACs in different populations, and I'm hoping to put it all together for where warfarin still fits in among oral anticoagulation. And along the way, we'll highlight some different studies that have come out in the last couple of years. So by the end, I'm hoping you have a good understanding of how warfarin compares to DOACs and really when and when not to use it. Big take-home point is that warfarin is not the right anticoagulant for most of our patients. And this is reflected pretty much universally across atrial fibrillation and venous thromboembolism guidelines, including Thrombosis Canada. Right. DOACs are less work. You don't have to deal with annoying INRs, less bleeding, in particular, less intracranial hemorrhage, at least equally as effective. Now, cost is important. It's also complicated, and I'm not going to talk about it. So despite warfarin not being right for most of our patients, there's still a lot of our patients who still use warfarin. Some of the data is a little old, but looks at warfarin prescription rates in Canada, UK, and US. So the Canadian data ends around 2014, and warfarin had gone down to about 2/3 of total oral anticoagulation. Definitely a decrease, and it certainly has gone down further, but it hasn't disappeared. So who are these patients, and why are they still getting warfarin? When I was thinking about this presentation, I spent a long time looking at my own practice and trying to figure out which patients do I still use warfarin for. And I came up with 3 major groups, and these are not exhaustive lists, but they're generally how I approach it. So the first one is the it's not you, it's me category. So this is historical or inertia around switching to DOACs, but really in 2022, it's been supplanted by pretty strong evidence around DOAC use. Going to highlight frailty in advanced age. The rationale here is that these patients are hard to include in clinical trials. There's a lot of polypharmacy and comorbidities that may increase the risk of DOAC complications. So interesting study from the US looking at Medicare data, patients with atrial fibrillation over the age of 65 who met criteria for frailty. Used a composite endpoint, stroke, death, and bleeding. Rivaroxaban and dabigatran are about on par with warfarin, and there seemed to be a benefit for apixaban in this population, mainly driven by reduced bleeding. So overall, I think based on the evidence we have, DOACs appear to be just as safe for this population, and we'd expect these patients to really benefit from not having to go for INRs and simplified dosing. Okay, so category 2 is the we should talk group. So this is real concerns for DOAC use, but the clinical picture and studies continue to evolve. I don't think things are set in stone yet. There's a big spectrum, and some of these disorders, I think DOACs are becoming more readily integrated, where others still remain pretty warfarin heavy. Again, you've heard a lot of these today. I'm going to focus on low adherence. The rationale here is that warfarin's got a much longer half-life compared to DOACs. So there might be a bit more wiggle room or buffer if your patient were to miss a dose. So studies from US, so another retrospective analysis through veterans hospitals, and they looked at the first year from going from warfarin to a DOAC. TTR, so time in therapeutic range, was used as a surrogate for adherence. Not perfect, but it gives us some idea. So just to highlight, at the first year, so the patients that had high TTR going in, so more than 50%, not surprisingly, 83% of them were adherent to DOACs. However, even the patients that did pretty poorly on warfarin with a TTR less than 0.5, 70% of them were still taking their DOAC more than 80% of the time. Now, for the patients that do not take their DOAC, this is a retrospective study from Korea, which compared outcomes in atrial fibrillation patients between adherent and non-adherent patients. Okay, no big surprise. If you take your medication as prescribed, tend to do better, less heart attacks, less stroke, less death. And patients did relatively as much better whether they were taking their warfarin or DOAC. What I think is interesting with this data is the non-adherent group. So looking at the absolute numbers, the risk or the outcomes seem to be about the same regardless of what anticoagulant you weren't taking. So rate of stroke, rate of death, roughly the same. So not definitive data, but I think it's at least suggesting that just because a patient does badly on warfarin, their adherence may be better with DOAC. It's certainly much easier. You don't have to worry about INRs. And even if they're not adherent, it's not clear that the outcomes are any worse. So the third category is the ICS getting old together. So this is a really, I think, strong and positive relationship with warfarin. I was pretty choosy here, so I'm looking for pretty definitive evidence that warfarin remains the standard of care. I only have two, so high-risk antiphospholipid antibody syndrome and mechanical valves. So diving into high-risk APS, so a small study that looked at apixaban trying to build on previous work with rivaroxaban. Trial was designed, it was a pilot study, so relatively small sample size to begin with. It had multiple methodologic changes along the way and ultimately was stopped early. So we have to interpret it carefully. In total, 50 patients were enrolled, 25 on warfarin and 23 on apixaban. There were 6 strokes, all in the apixaban arms, and split between initially the trial started with 2.5 BID and then switched to 5. And the strokes were split between the two groups. And they tended to happen in the patients you'd expect. So triple positive serology or risk of history of stroke. So building on TRAP study and previous work in this area, I think it's getting pretty clear that warfarin is really the better option, at least right now. So even though warfarin is an old drug, it's not totally static. It is learning some new tricks. So this is the I can change. And there is work going on that's improving how we use warfarin. So better or simplified bridging strategies. There's also work on improving patient education, increasing access to INR testing through like home coaguchecks, as well as interesting work on coming up with new ways to measure INR and removing some of the factor 7 variability. Just to look at peri-procedural bridging. So we'll talk about the PERI-UP2, really interesting Canadian trial. I suspect some of the authors may be here today, so if I get anything wrong, please correct me. But looked at randomized patients to either risk-adapted post-procedure bridging with dalteparin versus placebo. Everybody got pre-procedure dalteparin. And what made this study unique is that in addition to atrial fibrillation, it also had a sizable population of patients with mechanical valves who were excluded from previous trials. So overall, bridging didn't really seem to matter. Dalteparin postoperatively didn't help things. And this remained true even in the mechanical valve subgroup. So as a whole, I think these studies are leaning that maybe with the exception of the very high risk patients, most of our warfarin patients may be able to get away without bridging. Further work is needed, but definitely interesting. So just to summarize things. So in 2022, and DOACs are preferred for the vast majority of our patients. And the patients who remain on warfarin, some should be switched. A few situations you should probably consider switching or at least take a look around. And there's a select number of patients where warfarin really means standard of care. Ongoing work in the area will hopefully continue to improve warfarin for the patients that remain on it. Anyway, thank you, and next we'll open up to questions.
Thank you to all our speakers. We have a question from the virtual audience for Ryan, and they are asking, should warfarin be encouraged in all obese patients?
So, I mean, it depends. I mean, that's a hard thing to answer. So in all patients, I would say no. And as I said, me personally, I'm comfortable for most indications up to a weight of 140 kilos. I think there's enough, at least at best, observational data with all of its usual limitations sort of supporting that, but there's quite a bit of it out there. You know, it really depends. So if you have a very, very high risk patient, like we've seen this, and we've seen patients 200 kilos. Like at what point do you say, well, who knows what's happening? You know, and we could potentially look at doing levels, even though it's not recommended, just to see like, is there any drug left on board at that point? But it really depends on the case itself, the indication, the other comorbidities and everything. So it really comes down to individualization, I think.
Thank you. The next question would be for Dr. We have a question from an audience member. Go ahead.
Thanks so much, everyone. Great talks. I actually have a question for you as well in regards to obesity and DOACs. How do you feel about prophylactic doses of DOACs, such as rivaroxaban 10, in people with high body weights?
So
for, I mean, in approved indications, such as after total knee and hip arthroplasties.
So I get this question almost weekly, and it's something we discuss. And so for instance, we'll say, what is the weight? And, you know, look, there's a few ways to answer this, because first of all, we're starting to use a lot more, even at our center, after there's a couple of our orthopedic surgeons that are using aspirin right now after 5 days of rivaroxaban. And of course, there's those trials there's the EPCAT trials, and there's EPCAT 3 that's ongoing. So we have used them, but you know, at a certain point, I'm a bit less comfortable. These are very high risk, especially like the total knees and the total hip replacements. And so at some points, we'll just switch to low molecular weight heparin if we really can be sure. Same with aspirin, like who knows, even at much higher weights, you know, and we do see a high amount of DVTs in these patients. So I don't know if it was my own parent, if I'd feel comfortable, let's say, you know, if weighing 180 kilos to give Riva 10, to be honest, because we just don't know. And so I'm a bit less comfortable with that. So it really depends.
Thank you. From the virtual meeting for Dr. Tagalakis, would you consider DOAC for management of non-cirrhotic superior mesenteric vein thrombosis where underlying thrombophilia may be concerned?
Great, thank you. Yeah, so in the context of an underlying thrombophilia, and I guess as we've heard earlier, there are a variety or a range of thrombophilias, some being, you know, a factor V Leiden heterozygote is something that I wouldn't, if I've made the decision, just to backtrack, that I would be using a DOAC in this type of individual. And more often than not, if it's an unprovoked, and more often than not, there could be a thrombophilia investigation that is pursued, as we've learned earlier. It depends really on the type of thrombophilia that we find. So you know, simple question is probably not, unless it is a quite weak factor, such as a, you know, a factor V Leiden or a prothrombin gene mutation.
Thank you. A question from the audience.
Thanks very much. Just a quick point. I think we just talked about the rivaroxaban in the obese patient for prophylactic dosing, and you mentioned low molecular weight heparin. I was going to suggest that's also a weight-based variation, right? So I'd be a little careful about that, just on the same principle. But actually, the question I have was for Dr. Tagalakis, which was, if you have a patient with a portal venous thrombosis and you're suspecting varices, you mentioned not a contraindication. How quickly do you get an OGD for these patients? And if you saw, let's say, a CAT scan where you're obviously that's where you're picking up your thrombosis, and it mentions varices, which it often does. Are you looking for high risk features? How quickly are you getting that out of the way before, or do you just go ahead with a blood thinner and then
Yeah,
kind of?
no. So more often than not, it's very quick. And by quick, I mean within, 24 to 48 hours, these patients are probably more often than not either admitted or remain in our emergency room. More often than not, we will initiate, if there's no red flags of immediate bleeding, it doesn't mean that the occurrence of that varice that you see on the CT scan, for example, is at high risk for bleeding at that moment. So it's not something to negate going ahead with anticoagulation. There would be other factors that, if there is a history of bleeding, melena, or the patient has been describing bleeding, and then yes, I would immediately try to get an endoscopy done. But generally speaking, just a finding on CT scan without any red flags on history or on labs, for example, that would suggest acute bleeding, I would proceed with anticoagulation.
I guess the thought process here being in the case of PE, for example, obviously the clinical outcome could be grave within hours, but with a PVT or an SVT, you're thinking more, within a week, you could theoretically start anticoagulants, at least according to old guidelines. So if you're thinking you have time, what's the utility of trying to get that OGD in the next day or two if possible? This is just things that go through my mind because clearly the clinical context is different between PE and a
So clearly, yes. So the evolution of a portal vein thrombosis, we don't have great data. The goal is to improve the risk of getting a portal hypertension and improving your chances of recanalization. So necessarily, we don't have that idea of a typical deep vein thrombosis with the risk of embolization and causing a PE. But there is that idea that if you have a PVT, there may be a prothrombotic risk that's systemic. And so that the individual also could be at risk for, any other type of clotting event. So generally speaking, if I have to wait a week to get a gastroscopy because I've noted varices on the CT scan, it would not impede me from starting anticoagulation at that point in time. And I would use low molecular weight heparin because I do know that I would need to stop for the endoscopy to proceed. And so you want to be able to have a quick sort of on-off.
So it might depend on how quickly you're able to get them seen and have a scope done. That might actually factor in as well.
Yeah.
Thanks.
Blair, I remember in the SSC guidance, I remember a 2-week period where they gave you like this flexibility of doing the investigations. I don't think it's based on much, but it looks like you have a few days to.
I would agree. That was kind of my thought process, that it really isn't quite the same in terms of acuity. So if I was able to get a scope, these are high risk bleed patients by definition, usually if they have varices on a CT scan. So I'd be thinking about trying to get that done, given that you have some leeway, but I note that it's not always something you can get done quickly.
Yeah, I think, these patients are presenting usually to your emergency room. And generally speaking, my experience has been that we're often able to scope them within the next few days. It may not be the case in every institution, I agree. But generally speaking, I don't want people leaving here thinking that a portal vein thrombosis perhaps is not as associated with adverse outcomes as much as another.
It's just a timing thing, not so much.
No, and I think it makes sense if you're able to get it quicker, great. If waiting a week or two, but I generally would be anticoagulating them with low molecular weight heparin while waiting for that week or in 2 weeks.
With that, I will just say thank you to all our speakers. I'll remind the audience members and our virtual attendees that you can forward all unanswered questions to Holly at thrombosiscanada.ca.